Good morning, everyone. Welcome to Hall B of day one of Trendo 22. So for the first session today, we have a very interesting session. We have a clinical case seminar. This is clinical case seminar 1 for Hall B. And the topic for today is titration of thyroxine, common mistakes in clinical practice. It's a very practical orientated topic. And for this, we have an array of endocrinologists to talk about this with clinical case scenarios. The speakers for this topic are Dr. Jayashree Gopal. Can I please ask her to come on stage? Consultant endocrinologist from Chennai. Dr. Kumarvel, consultant endocrinologist from Madurai. Dr. Vel Murugan, consultant endocrinologist from Puducherry. And Dr. Asha from CMC Vellore, consultant endocrinologist. And to moderate this session, we have Dr. Rajendran from Chennai. So we have 40 minutes to go for this. So we have clinical case scenarios. And the way this is going to be set out is we're going to have cases with discussions with the panelists. And at the end, we will have audience interaction. Rajesh, the floor is yours.
Thank you very much, Anand. Thank you for the kind introduction. So without further ado, we would like to move on and start for today. Can we have the presentation up on screen, please? I'd like to thank the panelists for being here. So how we're going to go about this session is I've got some hypothetical cases. So we will put up these cases and we'll have a discussion among the panelists as to how they should be approached. They are not any out-of-the-milk cases. They are just straightforward cases which we see in our daily clinic, cases which would go to general practitioners, cases which would be seen by obstetricians in daily practice. Nothing complicated, very simple, straightforward cases, and how to actually approach them and what mistakes are possible and what can be done to avoid those mistakes will be discussed by the panelists. I've still not got it on screen here. I've actually got it on my screen here, but it's not showing up on the main screen. I think while they're trying to get it up, I will just read out the first case. So it's a 19-year-old girl who's got no previous thyroid disease. She has already been seen outside, or she's actually self-tested herself. She's got no symptoms, but somehow these days everybody gets tests without symptoms. And she's got a TSH of 13 and a normal T3 and T4. No past medical history. And she weighs around 50 kgs. And now she's actually been sent for further evaluation and treatment. So I'm going to ask the panel, so what should be done for this patient? A very straightforward, 19 years old, no past medical history, no symptoms. She's got a TSH of 13 with normal T3 and T4. Can we start with Dr. Jayashree, madam, please? Thank you.
Good morning. Thanks, Rajesh. I think a fairly common thing. the things that I look at are why were the thyroid tests done? Was it done for case finding? Were there any particular symptoms? Particularly for young girls, it's things like hair fall, tiredness, body pain, joint pain, irregular periods. Or was it done as part of a fishing expedition, you know, like a master health checkup type thing where all the tests are done? So that's one of the first things. When I decide to treat, the things I look at are again this: is there any evidence of any symptoms suggestive of thyroid underactivity? And on a physical exam, I'd be interested in looking at things like what is the blood pressure, is there any goiter on exam, is there a thyroid nodule, what is the family history, do I need to measure thyroid antibody levels, is there, if she is obese or there is a PCOS type phenotype, what is the lipid profile? So these are all the things I look at before deciding if I want to initiate treatment. And I just want to finish by saying, if it's the only time she's had a thyroid check, absolutely no symptoms, no significant family history, no goiter on exam, sometimes I may just choose to wait and repeat the blood test in about 2-3 months' time, if there is no pressing need to start therapy at present.
Okay. Dr. Asha, madam, any other views?
Yeah, I
This
agree.
patient had the blood tests as a part of her routine checkup. She thinks she may have had similar results before as well.
Okay. So if this is a repeat test and it's still found to be TSH more than 10, that is 13, in the absence of symptoms, she's an who have TSH more than 10 are likely to progress to overt hypothyroidism over the next 2.5 to 3 years, especially if they are antibody positive.
Yes. Anything else to add on, sir?
Yes, sir. I agree with ma'am. Because the TSH is more than 13 in this case, if it is confirmed by a repeat test, the threshold of starting treatment is little on the higher side because of the chance of progressing that into an overt hypothyroid. So, if the test is repeated again and it's more than 10, it's better to start treatment, especially in a young woman of 19 years old.
Yeah, I think this is a very straightforward case of subclinical hypothyroidism. And since it's asymptomatic, I think when you go by guidelines, any TSH more than 10 would require treatment, or if anti-TPO positivity, it would be treatment. Pregnancy, depression, dyslipidemia, infertility, they may require treatment. In this patient, if it's repeatedly there, I think anti-TPO antibody would be the only thing which would really decide whether we need treatment or not. If suppose we feel this TSH is normal, other comorbid is not there, no other clinical symptoms, if TPO antibody is positive, probably we might treat. Otherwise, it's a straightforward case of subclinical hypothyroidism. But the only thing which I would like to insist is whenever we are planning to start treatment for any patient with thyroxine, try to diagnose, write your clinical diagnosis and then decide on treatment.
Yes. Thank you very much. I think that was a very useful discussion, and there was a very important point that was highlighted by Dr. Ashan madam. We have to ask patients about their marriage and their future plans, because that is again a very important determinant factor in young women. So let's go to the next case. Another interesting case, I would say, which we see routinely. A 39-year-old female, and her concern is thyroxine is not working properly or correctly. She's been taking thyroid hormone replacement for several years with fluctuating levels. Her TSH a year ago was 12, and she had a normal FT4, and 3 months ago it was around 0.23, And now when she's come to our clinic, it is around 7.9. And this TSH has been above and below goal for the last few years. And she says she has been taking her medications properly, and she's been testing herself, and she's not been to a doctor as such, because she thinks she's capable of managing it. But now she's actually sought professional help because of the concerns and these fluctuating levels. So how are we going to approach this patient, madam?
Again, this is not actually an uncommon scenario, and then we are left sort of scratching our heads about what do we do. So the things that I think about, have the thyroid test been done in the proper way, meaning has it all been done fasting, has it all been done, has she missed the tablets? Sometimes they say they are regular, and then you sort of go deeper and they'll say, oh, a week before I missed the tablets for a few days because I was out of town and I did not have the tablets. So that's a very common answer. The way I take it is, if in the last 1 month they've missed the tablet for anything more than 2 to 3 days, I would consider as a significant factor in causing an elevation of the TSH. Has there been any change in the brand? Sometimes I find that brand changes, which is not recommended, can cause some difference in the TSH. Third reason why the TSH may fluctuate in spite of the same dose would be weight fluctuations. Anytime people gain weight, they land up requiring a higher dose. When they lose weight, the TSH comes down, they may need a lower dose. Though, of course, the time frame does not fit that, but that is a third consideration. So weight fluctuations, has it been done in the same lab? Has it been done in the proper way? Has she been compliant with the medications? All of these things would go into determining why the TSH is fluctuating. Fourth and final reason, which is very rare, is truly there are people who cycle between hypo and hyperthyroidism. But there, if she truly is becoming thyrotoxic, hyperthyroidism, the TSH would be suppressed. You'd see a TSH value of 0.0 something, or very, very low TSH. So that has been described in the literature also, people who cycle between a hypo state and a hyper state. But it's something to keep in mind, because if we try to reduce the dose with a low TSH and they continue to remain thyrotoxic with a very, very low TSH, we may need to stop the levothyroxine for a while and see what the true clinical picture is.
Thank you, madam. Madam, anything more to add, madam? I'm sure there is.
Yeah. In addition to what Dr. Jayashree has just said, there are some more things to keep in mind, especially with concomitant medications, especially iron and calcium supplements. She's a 39-year-old lady, would have some aches and pains, would have been prescribed calcium. Many people at this age with hectic lifestyles may have some GI upset, taking pantoprazole or other PPIs. So acid is required for absorption of thyroxine. So any acid suppressants, iron or calcium supplements which are taken within 6 hours of taking thyroxine, all these commonly affect the absorption of thyroxine. In addition, there are various other drugs which can affect thyroxine absorption, the anti-epileptics and the other groups of drugs. The other thing to keep in mind is GI disturbances per se, inflammatory bowel disease, H. pylori, gastritis. These can also affect the absorption of thyroxine. Patients following bariatric surgery, both due to the weight loss as well as due to the malabsorptive procedures created by bariatric surgery, can have elevations in TSH or a suppressed TSH, either due to weight loss or to weight gain.
Thank you, madam. Anything more to add, sir?
Just add to what Mama said, just to summarize, like any patient who comes for follow-up for hypothyroid, there are two questions definitely we should ask. One is whether the patient taking drug regularly. So that can be asked by the patient, and you can even confirm with the thyroxine tablet, because it comes in 100 numbers. So amount of tablet that is left so gives you a fair indication whether patient takes drug regularly or not. Second is the spacing. Spacing with food is another important factor which patient usually misses. If usually you take thyroxine, like around 70 to 80% get absorbed, like the viability is somewhere around 70 to 80%. If you follow a standard precaution of at least spacing of 45 minutes But if you just take tea or coffee immediately, like you don't expect that much bioavailability. So it will be somewhere around 10 to 20%. So these are the two things that should be definitely asked for every patient coming for follow-up, like having some the disturbance in TSH level, which was previously controlled. And as Pam has said, then further we have to decipher the other questions to get into the conclusion for such fluctuating TSH levels.
Thank you, sir.
Yeah, I have only one thing to add. I think it's very important to look at the expiry date of the most of the medications, because thyroxine, we take it's 120 tablets. Now they have increased the pack size, so 4 months. So when people buy, they check the expiry date, maybe for 3 months, they might miss it. That is one. And common thing, when we keep on changing the dose from 75, 50, 100, most of the patients come to us with 3 tablets of varying strength. They say, doctor, I have 75, I have 50, I have 100, what should I take? So when you have 3 tablets, naturally you lose when is the manufacturing date and expiry date. So that is one common reason what we see, apart from whatever has been highlighted with other panelists. I think checking the expiry date is also very important in all those patients.
I think that's a very important point, sir, because they come in bottles and patients don't want to waste medications. That mentality is always there. So sometimes they inadvertently, they would have checked the expiry date probably when they bought the medicine, but thereafter they won't. And when we change the dose, sometimes if they have the old stock left, and if that is the dose that has been prescribed, they will take that, and at that point they may not check the expiry date. That's an extremely actually valuable point. And the other point which Madam mentioned was patients may actually change the brand, and that can lead to different bioavailability. And that is quite common, at least I am seeing it quite commonly. And that also happens with these online retailers, because they tend to upload their prescription, and when they don't have the same brand, they issue a different brand which is actually available to them. And once the patient has received it, there is always less intention to send it back, and they continue with that. So I think all these can actually, apart from everything else we discussed, affect these TSH levels. I think this case was just put up to show the practical problems which we can talk to the patient and find out. Because all these, what was discussed, all we need to do is talk to the patient, and we will get the answers from the patient. And that's what is actually important, what I wanted to highlight in this case. So just putting up whatever was discussed in this slide. So this is again another straightforward patient which we see or we get referred to from the gynecologists, and in most instances they manage it themselves. A 27-year-old female, she's a preemie, 8 weeks, no symptoms, no family history. She's got a TSH of 4.5, and she's been seen by the gynecologist, and she's been referred for further evaluation and treatment. So Asha madam, how do we start with this?
So this is a 27-year-old preemie. So she has not had any previous pregnancy losses. That is the point to note here. Her TSH is borderline 4.5. This is definitely above the trimester specific range when we take the Western data into context. So the trimester specific ranges are listed here. For the first trimester, you would like the TSH to be between 0.1 to 2.5, second trimester 0.2 to 3, and subsequently third trimester as well. So why is this important? So during the first trimester of pregnancy, during the phase of organogenesis, the fetal brain development, especially the neuronal migration and the organization of the neurons, is dependent on the maternal thyroxine. The fetal thyroid has not yet started producing its own thyroxine, and hence we are very concerned about the maternal thyroid functions, especially in the first and early second trimester. So in this case, the TSH is borderline, This lady has not had any previous bad obstetric history. Looking at the case, it looks like she has conceived spontaneously without the need for any IVF or other kinds of treatments. So in this case, we would check the thyroid antibodies. If the TPO antibodies are positive, we may consider treating this borderline subclinical hypothyroidism. Again, the evidence is that in patients who are antibody positive and who have subclinical hypothyroidism, there is an increased risk of miscarriage. And hence, when the lady comes in the first trimester, you would consider treatment. While in antibody negative patients for borderline TSH, treatment is not recommended until a TSH level of 10. But you may consider treatment even in antibody negative women, especially if there is a history of previous pregnancy loss and if they have conceived by IVF or other treatments.
To just take ma'am's discussion further.
Yeah, please.
Thank you.
So to simplify that, if you get a TSH like this at the first trimester, if the TSH is more than 4, you tend to treat. 4 to 10, I mean, more than 10, there is no question that we have to treat. We have a clear-cut evidence. If it is 4 to 10, you around other side, you treat the patient with maybe around not with the full replacement dose, but at least with 1 microgram per kg body weight. If it is between 2.5 to 4, is a gray area where still people are not sure what to do. So another parameter that can help you is anti-TPO antibodies. People say if that is positive, you still treat irrespective of previous history of abortions. If that antibody is positive and history of abortion is there, if the TSH is between 2.5 to 4, you treat with around 50 mics per day. Okay. If it is antibody positive, if there is no history of recurrent abortion, there is 2 schools of thought, either you treat or don't treat. Okay, so that is a gray area. So to just simplify, more than 4 you can treat. 2.5 to 4 with antibody positive, definitely you treat with whatever the evidence which is existing. The other thing is gray area, right? And the target to treat, like you, so once you start treatment, you get an next TSH after 4 weeks or so. At least in the first 20 weeks, you get the TSH every 4 to 6 weeks, and after that you can do it once in a trimester. That should be enough. And target is, like, if you want to have one target, you can just keep less than 2.5. So that could be one for like one size which could fit for every trimester, or you can follow the trimester specific range also.
Sir, thank you, sir.
I think here the major, I would not say it's some controversy here, is what's the normal TSH in pregnancy. Because it keeps on varying. For example, 5 years before, up to the TSH upper limit in first trimester 2.5, now it is 4. And again, people say, when you don't have your trimester specific normal range, because most of these are Western data, we may not have our own trimester specific TSH range. In such case, what the guidelines suggest is, whatever normal data, what you have been using, you reduce in pregnancy by 0.5. So if suppose normally you take it, your upper limit of 4.5, you take it 4. So depending on whatever lab you use, you can decide on what it is. So though the guidelines might suggest you should treat more than 4, I may not really jump into and treat by taking these numbers. So I think this is the area where you have to use your clinical skills to decide what has to be done, because we cannot simply go by numbers. So usually I generally tend to repeat the values, especially in pregnancy, when you really don't have hardcore data to suggest the harm of without it, especially in this borderline cases, we should repeat it. Another thing where I would decide based on your T3 and T4 levels, because this is one scenario where I would consider T4 ranges also. If suppose I have a TSH of 4.5 and my free T4 is above the upper limit of nearing the upper limit of normal range, I may not jump in and treat. If suppose I have a TSH of 4.5 and my free T4 is lower limit of the normal range, I may consider treat. Though these may not be given in the guidelines, this is some clinical tip which I use in my routine treatment.
Thank you, sir. That was a very valuable tip. And Dr. Jayashree, madam, your thoughts on this case. I put this up because there should be different opinions for this case is what I thought.
So I also tend to use a TSH of above 4 to consider treatment. And I just want to point out that when we looked at our data, at least in Chennai from one center, most of the sort of the upper 95th centile of the TSHs tended to be around 4.5. And I think that's pretty much the data from across India. I'm sure Dr. Asha also would agree. Whether it's studies from the north or from the south, the upper limit of the TSH in India in general is higher as compared to the TSH ranges that we've looked at from the literature in other countries, the Caucasian countries. So, and we also looked at specifically the outcomes in the group of pregnant women who had a TSH of between 2.5 to 4 and between 4 to 5 to see if there was any difference in outcome in the 2.5 to 4 who were not treated, and we found absolutely no difference in outcome. So I think the more recent ATA guidelines which says use a TSH of 4 in the first trimester to determine treatment is what I use, and it is borne out by at least the data from what we've looked at in our center. And this is on a fairly large number of people, almost about 1,800 pregnancies that we looked at. So first trimester, if she comes in with a TSH of 4 and above, in general, I would go ahead with treatment. I think, like Dr. Velmurugan mentioned, 2.5 to 4 is a little bit of a gray zone. So if I see somebody with a TSH of 3.6, say, or 3.8, I would repeat, like what Dr. Kumaravel said, I would repeat it along with thyroid antibodies to see which way is the TSH going. Again, this is a little bit of a nuanced decision making. It depends on, like what Dr. Asha said, what is the previous obstetric history? Is this an elderly primey with recurrent missed abortions? I would be more inclined to treat for whatever it is worth. So the other thing that always I keep in mind is there any, we always think of a minimal dose of levothyroxine as somewhat safe. Nothing much is going to happen if you give 25 micrograms, if you give 50 micrograms. To some extent that is true. If at all we are considering treatment for values that are borderline like this, say 4, 4.2, make sure we don't overtreat. There is data from the literature to say that if you are overtreating people, we are keeping the free T4 at the upper limit of normal, it is associated with some adverse outcomes in terms of the fetal heart rate being higher, the fetal, it affecting the fetal growth. It does affect it does cause some amount of growth restriction to the fetus. So there is some detrimental effect to overtreating. So when we have the gray zone, try to keep the free T4 within the middle of the normal range, whatever it is you're going to treat. Try not to overtreat as much as possible. But in general, I use a TSH of 4 to determine whether I'm going to start treatment or not.
Yes. Thank you very much. I think that was an important highlight from this discussion. We are still reliant on Western data, despite having one of the largest number of pregnancies in the world. I think the premier institutes should actually guide us by giving us local data and local, again, I would say data pertaining to each population. India is such a diverse country, so we need data for each state as to what would be the correct trimester ranges, because this is a very, very important and often, I think, debatable topic. And right now, yes, the consensus is TSH of 4, but I still think we have to have proper Indian data published, and that would be possible from centers like Dr. Asha Madam's input. Thank you. But these are the cases which we see in daily practice, and yet these cases actually require a lot of thought before the decision is made. I think that is why I put up this case. So this is another case which we see in our daily routine practice. A 70-year-old male, and he's on a lot of medicines. He's got ischemic heart disease, diabetes, hypertension, and of course he gets a master health checkup, which he would do, and his TSH is 7, and he's been referred because the referring doctor is very keen that he started on thyroxine. So Dr. Kumaravel, sir, can we start from you, sir? So how do we approach this patient? I'm sure this is the routine referrals we'll get.
So again, when you don't look at the age, it's a straightforward case of subclinical hypothyroidism. So this patient, 70 year, again we know the TSH, it's a it varies between the various age group and your physiological condition of a state. Your TSH cutoff in neonate might be different, in infant might be different, children is different, and reproductive age group is different. It might be the same TSH. So in 70-year-old male, this TSH7, it is not too high. I would say up to 6.8, I would consider it's normal. But there are some data to suggest high TSH in person can increase the risk of coronary artery disease, and there is some chances of where it increases the carotid intima thickness and data. So these are data, but again we too have data to suggest when your TSH is slightly at the above range, it increases your longevity also. So this TSH of 7, I may definitely not treat in a 70-year-old male.
Yes, thank you, sir.
So like in a very old or elderly people, there are only two things to consider, sir. First, whether you want to pass it as a normal physiological change, which is that TSH with age increases. Like by 60 or 70, if you just take a population of 50 to 70 years old and do a TSH, most of them will have a TSH between 5 to 7, that is around 75%. So the first decision is whether you want to treat or not. If you decide to treat, and second is to decide like how slowly you are going to treat, because there is no urgency in replacing levothyroxine for a 60 or 70-year-old male, whether there is an history of coronary artery disease or not. So for this patient with TSH of 7, I think we need not treat, like we can just wait and watch. And if at all, like if the TSH is more than 10, for example in this case, if you decide to treat, then you start at very low dose of 25 or 12 to 25 and then increase only by 25 with careful monitoring of any history of recent onset angina or breathlessness or anything. So like when you start at when you decide to start a levothyroxine therapy for elderly people more than 60 years, you start with low dose and tell the patient if there is any history of chest pain, breathlessness or worsening symptoms of cardiac issues, they should just contact the doctor immediately. So once you do that, if there is no such things happening, then you can increase the dose by 25 every 6 weekly.
Madam?
Yeah, I think my colleagues have covered all the points. I just want to add a few things. One is, though subclinical hypothyroidism in the elderly has been shown to be associated with increased fatigability, their increased risk of heart failure as well as cardiovascular disease, prospective studies which have evaluated the effect of treatment on short term have really not established demonstrable benefit over short term in terms of improvement in skeletal health or the left ventricular systolic or diastolic function as well as the fatigue scores. So the effect of treatment is definitely not based on strong hardcore evidence, and hence with borderline TSH in an elderly person, it is safer to not to treat and follow up these patients.
Thank you, madam.
I don't really have anything to add, but I just wanted to ask a question to the panel, if you allow me.
Yes,
so
madam.
What if this was a person who came in and they're asking for clearance for a CABG? What is the TSH cutoff you would use to give a clearance? Or how would you give a clearance for a CABG? And I'll give you 3 TSH values. Same one, TSH of 7. Is that okay? Sorry, Rajesh.
Sure, madam, sure.
The reason being because this is a common thing for people working in hospitals. You know, we get asked this all the time. So let's say a TSH of 7, a TSH of 25, and a TSH of 80.
Okay, for a TSH of 7 with normal T4, I would give clearance, no problem with it. TSH of 25, if the T4 levels are normal and if the patient is asymptomatic, I would consider giving clearance, but not definitely for a TSH of 80. I would check whether the patient was previously on thyroxine, which most often is the case. They would have stopped medications for a while, and that is often the reason for this problem, or it would be a newly diagnosed hypothyroidism. In that case, definitely for an 80 TSH, I would treat. 25, I would recheck the T4 and the TSH and take it up from there. And the TSH again comes as 25, T4 is borderline low. I would consider starting low dose treatment before giving clearance.
I agree with what ma'am has said, but same case, we have faced a similar scenario that patient was planned for a CABG and TSH was somewhere around 150. Okay, he has discontinued the treatment for about 6 months. So when we started the treatment with 25, he was fine. When it was converted to 50, he started to have chest pain. So in that scenario, we didn't progress further. We took the patient for CABG, and post CABG, we started to titrate. So like if the ceiling point here is angina, so it means you cannot increase the TSH, thyroxine further. So that is one thing that you may tend to see with such patients.
I think I totally agree with the panelists. Once when you say when the TSH is 80, they are not fit for surgery, next thing they'll ask when can they be taken for surgery next. So generally the TSH takes at least 6 to 8 weeks to normalize. So in such scenarios we go by free T4. Generally what we do is you give thyroxine for 2 weeks at least, and when your T4 has normalized, we might consider for surgery. But again the issue is most of the anesthetists are not comfortable giving anesthesia when TSH is more than 20. They say you give clearance sir, but we have to face the problem. So generally anesthetists are comfortable when it's less than 20, but when CABG cardiac status is too bad, you want to do CABG as early as possible. I may put this patient on thyroxine, wait for at least 2 to 3 weeks. I may not wait till the TSH is getting normalized, depending on the condition of the patient.
I think in many centers now the anesthetists are not comfortable if the TSH is above 10 itself. And I get many of the referrals for that as well. And even for local anesthesia, for cataract surgeries, I've had referrals from the eye centers saying they want an endocrine opinion before the patient can be taken up for cataract surgery because the TSH is above 10. So I think it was an excellent discussion, and the question that you had asked, madam, was very valid. So because CABG in most cases tend to be an emergency procedure, and as the panelists highlighted, that's how we should approach. So in that case, we have to take clinical markers like angina and actually T4 and not just focus on the TSH. But for this particular case, the consensus is we don't jump into treatment with these borderline values in the elderly patients. The more difficult scenario, I think, is when the patient has already been started a week ago. And that is what, to be honest, we see. The patient would have seen the local general practitioner. They would have started the patient, and the patient will come back and ask us for an opinion. So the question at that point is whether to take it off or not, but that's another individual decision, I think. So I think we are running out of time. I thank the panel members for the interesting discussion we've had on the four very common clinical case scenarios. Thank you very much. I'm not sure if we have time for questions, but if we do, then we will take it.
Anyone?
I think we do have time for a couple of questions from the audience. One question maybe.
It's opposite situation. There could be some patients with newly detected toxicosis or who have toxicosis not under control. If they are planning for angiogram, because most of the iodine containing angiogram may aggravate toxicosis, how would you approach? Would you give a clearance, or would you ask them to postpone the angiogram till toxicosis is under control? So I've had some patients who went into atrial fibrillation and lost the patient. So in toxicosis, planning for angiogram, how would you approach?
In a patient with atrial fibrillation with thyrotoxicosis, we know that thyrotoxicosis itself would have precipitated the atrial fibrillation. But in elderly, coronary artery disease is also a precipitating factor, so angiogram would be required. So we start treatment with antithyroid drugs. Usually you can control the thyrotoxicosis with antithyroid drugs in a week or 10 days, and then recheck the T4 levels, and based on that give a clearance at that time.
Sometimes the angiogram is done on emergency basis. Shall we give one dose and then ask them to go ahead, because it is many times it's a primary angioplasty, there's emergency situations.
Yeah. If it's an emergency primary angioplasty, the goal is to control the heart rate, which can be done with IV beta blockers during the procedure, and they can take up the patient. Subsequently, we definitely have to start antithyroid drugs. because of the use of iodinated agents, it's better to give them a dose of either carbimazole or PTU before taking for the angiogram.
To just add to what Mama said, if it's an emergency procedure, then the decision has already been taken, right? You want to take the patient for the procedure. Then from our side, I think we can start treatment and then follow up and face the consequences if something like occurs, then we should manage it. So there we don't have much choice, right? So we have to take the patient for the procedure and start the treatment parallelly and see if any other reactions occurs, then we should manage it.
Last question, thank you.
Yes, thank you everyone for the nice discussion. Actually, my question is regarding the case number 2, where we had cyclical variation of TSH. There are some reports saying that exposure of the levothyroxine tablets to the sunlight, humidity has an impact over its effectiveness. How far you see that, whether some preparations are being sold in the amber colored bottle and all. Do we have to prefer such kind of preparations, or is that okay to give in a PET bottle kind of things?
I think that's a very important point, and we did not address that, but very definitely the tablets are very sensitive to heat and light. There is some loss of potency, probably maybe about 20-30% loss of potency if it is exposed to heat and light. Where I find that being a challenge is particularly among women who keep the thyroid tablets next to the gas in the kitchen or above the fridge or TV, common places where it's very hot. So I just ask them that question usually. It is something we need to consider and see whether, like Dr. Rajesh mentioned, the expiry date. If it's sort of closer to the expiry date and they've been keeping it in a place like that, very definitely that is a factor in the consideration. And that's why we were mentioning brands also. We need to go for reliable brands. We've all faced problems where switching from one brand to another, maybe a lesser known brand, has caused problems with fluctuations in thyroid levels, maybe related to the mode of production.
Thank you. I think with that, we can conclude this session. Thank you very much to all the panelists. Thank you.
Thank you very much for the fantastic session. May I request Dr. Talabadi to come on to stage to felicitate our speaker and, our panelists and moderator. Dr. Talabadi, can you come on stage to felicitate them? Thank you very much once again. So without wasting much time, we move on to the next panel discussion, which also is going to be proving to be very interesting. So the topic is management of thyroid nodule, for which we have a host of endocrinologists and also endocrine surgeons. So may I call upon the panelists, Dr. Prem Kumar, consultant endocrinologist from Salem, Dr. Talabadi from Chennai, Dr. Manikandan from Madurai, and Dr. Kamal Ratnam from Madurai. And to moderate this session, we have Dr. Usha Ayagari from Chennai. So, Usha, the stage is yours.
Right, could I please have 45 minutes on the clock for me? Excellent, thank you. Hi, welcome everyone. Over the next 45 minutes, we are going to do the basics of thyroid nodule management. Now, we're not going to be able to cover every single nuance of this, obviously. But the objective for me is that, considering that I have endocrinologists, surgeons and interventional radiologists on the panel, I want to set out the common scenarios and the options for management, and perhaps then give you an awareness of what your referral options are. So coming to case 1, we have a 55-year-old female with no significant comorbidity, complains of symptoms of hyperthyroidism, palpitations, feeling hot, poor sleep. Given her age, initially put down to menopausal symptoms, but she continued with symptoms and weight loss without trying. So she was finally referred for further investigations. As you can see, her TSH is suppressed with an elevated FT4 and FT3. No eye, skin or other changes that would suggest autoimmune perhaps etiology. So straight, without any delays, I'm going to Dr. Prem. Dr. Prem, in this kind of a situation, what would be your investigation of choice, please?
So the case presentation is suggestive of a functioning solitary thyroid adenoma. Though the radioiodine technetium uptake scan gives many information regarding the nodule, still I would like to go do an ultrasound, because any thyroid lesion, the gold standard investigation is an ultrasound. So I like to do an ultrasound in this patient, because ultrasound will confirm whether the nodule seen in the technetium uptake scan corresponds to the nodule seen in the ultrasound or not, and it can also tell about the location of the nodule and also presence of other nodules. It may not be picked up if it is a iso-functioning thyroid gland, and that will be seen. And it also gives about other qualities of the nodule, its density, the echogenicity, that's hyperechoic, isoechoic or hypoechoic. And also if there is any fluid, it will be seen, partially cystic or purely cystic. May not be. Otherwise, usually ultrasound brings forth all the qualities, and also the margin of the nodule, and also if there is any microcalcification or macrocalcification. Microcalcification highly suggestive for a malignancy, that also will be put. And also presence of any associated cervical lymph node, if not amenable to palpation, can be brought forward by an ultrasound neck. So it is not a complementary a technetium uptake scan. It should always be ultrasound neck has to be done to evaluate the nodule properly.
So you would do an ultrasound scan followed by an uptake scan, looking for correlation between the features that you see on the ultrasound and the uptake scan. So this patient went for an uptake scan, and the uptake scan effectively showed a single toxic nodule. Now, with a single toxic nodule, what would your options be for medical management?
Yeah. When we say medical management, radio are willing for that. And second thing, one should also discuss with them, there is a risk for hypothyroidism and a long-term follow-up. This is minimal at the initial 1 to 2 years. What studies have shown is at the end of 10 years, around 25% become hypothyroid, and at the end of 20 years, more than half become hypothyroid. So this possibility also should do that. Then the patient will decide whether they want to go for a radiation ablation or they want to go for a surgery. The other option, there are certain elderly patients with multiple comorbidities, and they have a certain group of patients who are scared about radiation ablation because of the future risk for malignancy. Though it's very little or maybe negligible, they still have it. And they don't want to go for surgery too. In those group of patients, we advise anti-thyroid drugs, and it's a good choice provided they tolerate it. But if they don't tolerate and they develop some adverse reaction, then again they have to be given either radiation ablation or surgery. This will be my approach.
In terms of medical management, we have anti-thyroid drugs and we have radioiodine ablation. It is individualized to the patient depending on the duration of therapy, the risk of hypothyroidism, and the patient preference. So, Dr. Dalapathy, what are our surgical options, please, if in a single thyroid nodule, toxic nodule?
In this case, if we consider a surgical option, we need to take several factors before deciding on that. The size of the nodule also matters, because we consider surgery for nodules more than 3 centimeter for surgical option, because giving radioiodine or for nodules, whether the patient is desirous of pregnancy, young females who are desirous of pregnancy or in the lactation period. So these are candidates that are surgical candidates. Another thing is, if they want to have a one-stop solution, that's an immediate solution, then surgery will be the better option because of the safety of this surgery. We will do not only a nodulectomy, we will do a hemithyroidectomy so that we remove the isthmus also, so that we expect a compensatory hypertrophy of the opposite lobe after a hemithyroidectomy. In that case, cosmetically, it would be a better option if we remove the isthmus also along with the nodule, though it is confined to one lobe. So we would like to consider hemithyroidectomy rather than doing a nodulectomy or a lobectomy on the one side. So that is an option. And any other suspicious features that have been seen on ultrasound, then surgery would be a candidate than a radioiodine or thing, because we need a tissue diagnosis that would be yielded by a surgery alone.
Okay. So in larger nodules, maybe people who would prefer surgery as the first choice, or in people not coming under control with medical management, surgery is an option. Now, we also have an interventional radiologist, Dr. Kamal Ratnam, on our panel. Is there an option for ablation, whether with the microwave radiofrequency or other options, in a toxic nodule? We'll come to core nodules later, but toxic nodule in particular, please.
Toxic nodules we have a limited role from RFA and microwave, but larger nodules which are having compressive effects, patients who deny surgery for that, then we can combine with radioiodine ablation. And as Sir suggested, pregnant patients who want to avoid radioactive iodine ablation, we can go for microwave, which is safer in pregnancy.
So in toxic nodules,
yeah,
under limited circumstances, ablation might be an option, where perhaps other modalities of treatment may not be optimal under those circumstances. Correct. So thyrotoxic patients picked up as a single toxic nodule, you have options for medical management, anti-thyroid drugs or radioiodine ablation. You have options for surgery, but perhaps under specific circumstances, options for radiofrequency or microwave ablation. Now, I'm going to go on to case 2.
Just a minute. I'll just add one point. We are doing a hemithyroidectomy. The thing is, the opposite lobe might be suppressed. That is the one thing which we have to be taken care of, because we must not rush into start thyroxine in the postoperative period immediately after a hemithyroidectomy, because the suppressed lobe takes time to recover. So we would like to wait for at least 3 to 6 months before we start a thyroxine.
And similarly with the radioactive iodine ablation, there also is suppressed surrounding areas, and again they might require this one. And it will take time. So anti-thyroid drugs has to be given after the radioiodine ablation, and sometimes if the size of the nodule is huge, we might require this one very early thyroxine supplementation also for the surrounding region to start functioning.
So when you have a toxic nodule, when the nodule is overactive, the surrounding thyroid tissue may well be suppressed, and post-surgery or post-radioactive iodine, this tissue may take time to recover, and you might need to bridge with medical therapy interim, or wait and watch post-surgery before jumping into thyroxine replacement therapy. I think that's the point. Okay. So going on to case 2, a 40-year-old female presented for a routine annual review, and we noticed a neck swelling. So she mentioned that yes, she noticed the swelling over the last few months. She didn't have any symptoms, so she thought not much of it, and of course over the course of COVID not many people have come for regular follow-up. So we went for an ultrasound scan followed by an uptake scan, and this showed a cold nodule. Now I am going to go initially to the endocrinologist Dr. Prem on my panel. So in a cold nodule, what would the role of an endocrinologist be? What are you looking for when you think in terms of which way to refer or what further investigations you might want?
Yeah. So when this case comes to us, we have to establish what the nodule is. And there are certain investigations we do. During ultrasound, we stage the risk for this nodule to be a malignant.
I'm going to go to our radiologist and to money for the risk stratification.
Okay. And what the question from?
So what I'm trying to get to is you do a thyroid function test, establish normal thyroid function test, do the ultrasound, and then decide based on the ultrasound features whether to FNAC or not. So our role initially is mainly to guide the patient towards further investigations, isn't it?
Yeah. So what we will do is we have to decide on FNAC. Any cold nodule needs an FNAC, and thereby we know what we are dealing with. So what we do is we usually advise an ultrasound guided FNAC in such nodules, because it has been seen when we do a blind FNAC, the yield is less, 40 to 60%. So we usually advise an ultrasound guided FNAC, and it has an important role when it's cystic or partially cystic, and it has a role. And so what we will advise in such patient to undergo an FNAC, and FNAC we interpret as per the Bethesda classification.
So what kind of a nodule that you pick up on ultrasound might you be tempted to watch and wait and not FNAC directly? So what nodules would you say are safe to observe?
Okay. Yeah. So if the nodule is purely cystic, then it doesn't require an FNAC. And when it has a thin wall and the margins are correct. And similarly, there is also one category of group of people called as very low risk for malignancy. These are typically a spongiform nodule, or when it is predominantly cystic, it is a little bit solid component, which are not eccentric, and size less than 2 centimeter. If it is a spongiform nodule, or it's partially cystic with a non-eccentric nodule component, if it is more than 2 centimeter, you can do an FNAC. If it is less than 2 centimeter, we not do. And similarly, if there is a solid cystic nodule, less than 1.5 centimeter, but low risk for malignancy according to Tirad scoring, the size cutoff will be 1.5 centimeter. Otherwise, all nodule more than 1 centimeter, if it has got a high suspicion for malignancy or interpreted suspicion for malignancy, they have to undergo an FNAC.
So nodules that are purely cystic, well-defined, may not need FNAC, you might want to observe. Smaller nodules which have no suspicious features on ultrasound, you might want to observe, but larger nodules, mixed nodules, you would want FNAC. So when they come to you, Dr. Kamal, we know that we use a scoring system called the Tirad scoring system for thyroid nodules. So would you talk us through the Tirad's scoring system, please?
Tirad is basically for categorizing the thyroid nodule. It's based on the echogenicity of the nodule. We categorize it, whether it's hyperechoic or hypo, that's one, and then what it's made up of, cystic or spongiform as I said, and solid components, mixed. So, and then we look for calcifications, microcalcification, macrocalcifications, and basically common tail artifacts, which is peripheral eccentric, which should not be mistaken for a microcalcification. It's common in colloid nodules. And orientation, the taller the nodule, the more malignant it is. And next is the well-defined borders, margins. If it's well-defined, then it's more suggestive of a benign nodule, and if it's irregular, lobulated, then it's more suspicious, and whether any extrathyroidal extension is there. So thyroids 1 is benign, 2 is also benign, and 3 is moderately suspicious, 4 is highly suspicious, 5 is suggestive of malignancy. So anything in thyroids 3 we FNAC, thyroids 2 we don't FNAC, but if the nodule is more than 3 centimeter, then thyroids 2 also we FNAC if it's a mixed nodule, it's having some suspicious solid components.
So based on the orientation of the nodule, oval, wide,
Yeah.
based on the margins, based on what the nodule looks like internally, vascularity, there are certain ways where you get a classification of what is the likelihood of malignancy in this nodule. Cystic nodules, thyroids 1 and 2, smaller nodules we might choose to watch and wait, but thyroids 3 and above or larger nodules even at 2, we would choose to biopsy. I think that's the sum of it. So when we biopsy, we get a grading called a Bethesda classification. I'm going to go to that and then come back to this. Dr. Mani, would you talk us through the Bethesda classification system for thyroid nodules, please?
So as with ultrasound scan, when we do an FNAC, we also have a grading system to identify the ones we need to be worried about and the ones we don't need to worry about. So it's categorized into 6 categories as projected. So Bethesda 1 is a non-diagnostic sample, so they didn't have enough cells to make a comment on. So this usually happens when we do an FNAC without ultrasound guidance. So as Dr. Prem pointed out, the recommendation now is to do with ultrasound guidance. So the risk of having a non-diagnostic smear comes down. Then Bethesda 2 is what we would like all our patients to have, which is benign. So which will have a risk for cancer to be less than 3%. Usually for these patients, we just ask them to follow up in the clinic, and they might require a further ultrasound scans. And if they do not have any features of the nodules changing, or if the nodule is not growing, then we might stop scanning as well after 6 to 12 months, or depending upon the pathophysiology, we might keep monitoring it every year or so as well. 3 and 4 are classed as indeterminate stages. So 3 is ATP of unknown significance or follicular lesion of unknown significance. The risk of cancer is about 10 to 30%. Category 4 is for follicular neoplasm and suspicion of follicular neoplasm, which has got a cancer risk of 25 to 40%. Usually for these things, molecular testing will be helpful, or we repeat the FNA after some time and see, or we will ask for surgery. 5 and 6 are for malignant lesions. So 5 is for high suspicion for malignancy, and 6 is malignant, which we usually refer them for surgery. So it helps us guide which patients to be referred for surgery.
So when you come to thyroid nodules, cold nodules, you really need to look at both these classification systems, the thyroids and the Bethesda, because this is what guides your referral for surgery. So once we decide to refer, Dr. Dalapathy, which of these patients would you take for surgery, and what are our options for intervention from a surgeon's point of view? Are there any of these patients that even if I refer to you, you would say, actually no, let's watch and wait, and which of these patients must we not miss referring to you?
Actually, we take into account the patient factors as well as the imaging as well as the FNAC. All the 3 has to be taken into account. Patient factors in the sense how well they will be coming for a follow-up, and how will they will be over a period of time they will be following up. Suppose if it comes as a malignancy, in that case. Regarding the ultrasound as well as FNAC, as Dr. Prem and Dr. Mani has told, we have to take, if we take the FNAC 1 and 2, Bethesda 1 and 2, we would like to follow, definitely. Unless otherwise there is compressive features or a huge nodule which is having some pressure effects, then, or very rarely for a cosmetic reason, we would like to operate. Otherwise, we also like to follow in Bethesda 1 and 2. Definitely for 5 and 6, definitely we'll offer surgery straightforward for a total thyroidectomy or a near total thyroidectomy. But the issue comes is Bethesda 3 and 4. That we just discuss with the patient whether we would like to follow it up or I would offer surgery. Most likely we would err on the side of surgery, because, and we would like to offer them whether we would take a hemithyroidectomy or a total thyroidectomy. That option definitely would give to the patient. But at the same time, when we give the option of hemithyroidectomy, we would combine a frozen study also. Though frozen study is not 100% effective, especially in case of follicular neoplasms, because follicular carcinoma, especially micro-invasive follicular carcinoma, might be missed in case of frozen study. Maybe widely invasive follicular carcinoma can be picked up by the frozen, but we would just tell the patient, counsel these risks also. So if the patient is ready to take the risk of a resurgery, if we do a hemithyroidectomy, we go for a hemithyroidectomy in 3 and 4 if it's a solitary nodule. Or if it's a if some other nodule is there in the opposite lobe, we will definitely do a total thyroidectomy upfront. So these are the factors we would like to do, especially when we have a malignancy like 5 and 6. In case of a papillary thyroid carcinoma, we would like to combine a central compartment lymph node dissection also. In that case, what we would like to add is a parathyroid auto transplantation also we would like to do. From the inferior, we will take an inferior parathyroid. Before we proceed for a thyroidectomy, we would like to auto transplant a parathyroid in the sternocleidomastoid muscle, because even though we preserve the parathyroids, the hypocalcemia is a very distressing symptom to the patient. So we would like to take care of that upfront itself. So we would auto transplant the parathyroid in the sternocleidomastoid muscle, because even though we preserve the parathyroids, they may get devascularized because of the end arterial supply.
Yes, one more comment. In Bethesda 1, where there is a non-diagnostic aspirate, the chances for malignancy is high. So it has to be repeated.
Yes.
And as early as 3 weeks. Because if you re-aspirate within 3 weeks, there will be a lot of other hemorrhagic thing which will disturb the picture. And regarding Bethesda 2, we also should look into the size of the nodule. If it is more than 4 centimeters, people have found in follow-up studies the chances of it becoming malignant is to the tune of 20%.
We're coming to the larger nodules next.
Yeah,
we are coming to that.
Yeah.
Yes. So even the surgeons are telling you that not everything is automatically for surgery. They will look at the thyroid score, they will look at the Bethesda score, and if the patient is low risk, they would rather watch and wait. And if the patient is higher risk, then the discussion is to be had about what is the most optimal surgery with or without neck clearance. One other thing I'm sure that the surgeons would appreciate from us is if we were to make sure that the patient has vitamin D replacement before they get to you. And please make sure that your surgeon, whoever does your thyroidectomies for you, does reimplant the parathyroids, because that minimizes the risk of post-operative hypoparathyroidism and hypocalcemia. Now, up until now, our best chance for these patients has always been surgery. But now we know that there are newer techniques coming in. And Dr. Kamal has been very kind to provide us with some images with the newer techniques he's doing with ablation, whether with radio frequency or whether with microwave, or in the case of cystic lesions with alcohol ablation. So I'm going to hand over to Dr. Kamal for the next 2-3 minutes so that he can talk us through the various interventional techniques that are available now other than surgery for thyroid nodule management. And just tell me when you want me to slide the change the slide, please.
Like we offer thermal ablation that comprises of RFA and microwave for thyroid nodules, basically Bethesda 2 with compressive symptoms, and patients who are non-surgical candidates. It's a take-care procedure done under local anesthesia and mild IV sedation. It takes around 30 to 40 minutes, the procedure. It can be done in an OPD setup also. And we ablate the nodule, and we use microwave needles which are around 18 gauge, thin needles which doesn't cause much bleeding, and we ablate the nodule. Basically we ablate the solid components after aspirating the cystic component in a mixed nodule.
So I think you have given me an image of a mixed nodule which has a solid and a cystic component. Yeah. So you'd aspirate the cystic component and then ablate the solid. So in terms of pros and cons, advantages over surgery and the limitations of radiofrequency ablation, what is your take on that?
We can't treat larger nodules. We can't give immediate decompression effect. More than 60 cc or more than 50 cc, RFA doesn't have any role. So anything around 30 40 cc max, we can treat the nodules and provide good results. Maybe in 1 year follow-up, you can reduce the volume up to 70 to 80% in RFA and microwave.
So I think you've shown us pre and post for the nodule on that side, and your images for pre and post 2 years post ablation. So there is a good reduction in size.
She was a lactating female. She wanted to avoid surgery. She had a left dominant nodule, large one, around 18 cc. We did a single microwave ablation, and this is her follow-up. Presenting cosmetic score was 4, that is visible, and then it came down to 2 over the period of 1 year. And she's not on any L-troxin drugs now.
So I think in smaller to moderate sized nodules where compressive symptoms don't need to be addressed as a matter of urgency, where perhaps the patient has a preference to avoid surgery or cannot go through surgery like pregnancy or lactation, definitely I think interventional radiology now offers a valid solution. Limitations wise, is size the only limitation or are there other limitations?
Size is the major limitation, because the results are progressive. You can't expect the nodule to reduce in size in a week or so. It takes 3 to 6 months to achieve around 40% reduction.
Right.
So that's the major concern. And sometimes the nodule might be calcific, very calcific, so it would be hard to ablate such nodules.
So
Mostly
larger
common.
nodules with calcification. What about
Dense
malignancy if it's a single focus? So single nodule papillary, let's say. Because I've seen some recent literature around that.
Papillary microcarcinomas less than 1 centimeters have been treated. Literature is in major in Korea and China, not in the European or the Western population. They have treated around a large population, around 350 to 500 papillary microcarcinomas, followed up for 4 years. According to the ATA guidelines in 2015, they had put an option for active surveillance of nodules less than 1 centimeter. So the Korean Society of Thyroid Radiology, who started the ablation RFA way long back, they have studied over 1,200 patients and followed up 350 papillary microcarcinomas. In that, the population which were on active surveillance for 4 years had developed lymph nodal mets, but those who had been ablated earlier, 4 years before, didn't have any lymph nodal mets or local recurrence.
So unifocal, smaller micropapillary carcinomas, which may be suitable for surveillance or may be suitable for ablation. Okay. So moving on to case 3, let's assume a similar kind of presentation, but this time the mass has been slowly growing over the last few years and it is now a large multinodular goiter. Initially I'm going to ask literally for without cervical lymphadenopathy, so keep it simple, we don't have malignancy. Would this be suitable for medical management? Because I've seen practitioners give thyroxines to shrink the size as we've been told. Dr. Prem, Dr. Mani, quick thought, any role for that kind of medical shrinking?
If the TSH is within the normal limits, I don't...
TFT normal.
Then we don't need to give them thyroxine. It doesn't make any difference.
So let's not be under the illusion that we can shrink a goiter by supplementing thyroxine in a euthyroid patient. In a euthyroid individual, no role.
Okay, there are certain disadvantages of shrinking a euthyroid goiter. What we achieve is only a 15 to 20% reduction in size. But the risk benefit ratio, if you see, the risks are more in the form of tachyarrhythmias or a bone loss, and especially in an elderly. So sometimes we do a TPO, it's positive, tend to suppress, but we won't achieve full suppression in most of the patients. It's only a group of patients with a partial response, and so it is debatable.
Dr. Dalapathy, surgery in a large multinodular goiter without any cancer on FNAC, let's assume we've had our thyroid scoring, we've done our Bethesda, this is a non-malignant large multinodular goiter. What would you advise?
A large multinodular goiter, definitely.
And it's been growing over the last few years.
Yeah. If it's growing over the last few years, then we would offer surgery to the patient. And in concern with the patient, then we would offer a total thyroidectomy or a near total thyroidectomy for this patient, so that the pressure effects will be taken care of. Moreover, cervical lymphadenopathy has also been there. So I would like...
So I'll come to the if cervical lymphadenopathy. So if they have cervical lymphadenopathy and this was a malignancy, you would...
No, even if it is not malignant, if there are lymph nodes, during surgery itself we'll take the lymph node and send for frozen study.
Yeah.
Even if the multinodular goiter in the FNAC is benign, if there are the nodes, if they are suspicious or if the size is more than 1 centimeter, we would like to do a frozen study of the lymph nodes at least before we proceed to the thyroidectomy.
If we come to, let's assume Dr. Dalapati has done his thyroidectomy. As endocrinologists, we follow these patients up longer term. We need to look at maybe whole body radioiodine scans, radioiodine ablation. Dr. Prem, where do we go if there is a malignancy in a goiter of any size? What do we do after the surgery?
Okay, a patient undergoes thyroidectomy and prone to have a malignancy.
So let's say a single nodule or a multinodular goiter which has been shown to have malignancy. Surgeon has done their job, done the neck clearance, done the thyroidectomy. They're back to you. What are we going to do next?
Immediate post-op, the occurrence of hypoparathyroidism has to be noted, because it's very common. It may be transient or permanent depending upon the, if it is high volume surgeon like Dalapati said, it doesn't happen to the minimum. Otherwise, the usual risk is less than 2%. So that should be the aim. And so if it is a malignancy, biopsy report comes, what we do is we do not start thyroxine, and we do a radioiodine uptake scan at the end of 3 to 4 weeks when a TSH goes above 40 to 45. And at that time we also measure a thyroglobulin and antithyroglobulin, and if the usually if it is a papillary or follicular, a good dose of radioactive iodine ablation has to be done. And post-therapy scan is also taken after 48 hours, usually 24 to 48 hours. And this will put the patient whether because if there is a distant meds, it will be lighted up by the post-thyroid scan. And the baseline level of thyroglobulin, antithyroglobulin also shows how much of a residual tumor is there, and also the uptake scan will show how much residual thyroid gland is left in the thyroid bed. And this will help us in the further follow-up. How frequent, if the post-therapy scan doesn't show any metastasis and the stimulated thyroglobulin is less than 0.2 and less than 1, sorry, and antithyroglobulin antibody is negative, we may not do a radioiodine ablation later. We will just follow up them with a serial thyroglobulin antithyroglobulin measurement.
So if you have malignancy in the thyroid, my very sincere plea would be, unless you're used to handling these on a daily basis, because even those of us who handle volumes of thyroid cancer, I have to go back and look at the scoring, I have to go back and look at the cutoffs for radioiodine ablation, because the ATA has very good guidelines as to who requires. So less than 40 years versus more than 40 years, less than 2 centimeters versus more than 2, unifocal, multifocal. There are a lot of criteria that determine who requires to go for radioiodine ablation and who might be a watch and wait candidate. So unless you're dealing with volumes, please do consider referring these individuals to somebody who's dealing with volumes. If I come to Dr. Kamal, so in malignancy, is there a role for any kind of radiological ablation? If so, what's the role, please?
Yeah. Patients who have comorbidities, who are not fit for surgery and who have compressive symptoms, maybe anaplastic or medullary carcinoma large, we can ablate. We can combine with embolization of thyroid arteries. We can go there and embolize the superior and inferior thyroid arteries. So the size of reduction is more combined with embolization. That's the main thing we offer for non-operative cancers.
So
and
those
recurrent,
that can't be operated, we have an option, but it's not the first line of treatment.
It's not the first, it's palliative.
Okay.
And any recurrent cancers, post total thyroidectomy, nodal recurrence, which are very small and the plane has been fibrosed and it's difficult for a surgery. Yeah, then we can go there and ablate the recurrent nodule.
So thyroid nodules with cancer in them, your first resort is to your endocrine surgeon. who does volumes, again, because outcomes in this kind of a scenario depend very much on your surgeon's skill and on your surgeon's fingers. I think we'd all agree on that. So in the last sort of 5 minutes, can I go around the panel, and if you wanted the audience today to go away with one message in terms of thyroid nodule management, Dr. Prem, what would your message be to them?
So any palpable thyroid abnormality, ultrasound has to be done, and it also requires a referral to the person who handles.
Okay. Dr. Dalapathy, what would you tell them if you had one message? So palpable thyroid nodules, please ultrasound. That's number one. What would our surgeon tell us?
Surgery has to be individualized based on various factors. It's not that surgery now it's very safe. Unlike in the past, even total thyroidectomy is safe, and the rate of hypocalcemia and nerve palsy is too low, maybe less than 1% or so. So it's safe to do a thyroidectomy rather than have a suspicious nodule with a follow-up.
Dr. Mani?
I think if when you're planning to do FNAC, it's better to be done in a high volume center with ultrasound guidance. That gives us a good yield, because otherwise we might be missing a malignancy, giving false reassurance as well. So I think that's very important that we use it, do it in a proper way.
Yeah. Dr. Kamal?
All benign goiters need not be operated. In case of cosmetic concerns, they can get ablated. And even in non-operative comorbidities, we can ablate the nodule. So it can be kept as an option for the patient.
So we have a few more minutes. So I've got a couple more questions for the panel. What are the nodules that you would watch and wait? I'll go to Dr. Kamal and Dr. Mani for that. What would you not touch? You wouldn't FNAC, you'd watch and wait. You've done your ultrasound scan, you've done your thyroids. What are you comfortable watching and waiting? So this is something I really want the audience to take home, because not every nodule needs us to do something. And most importantly, we need to know where we can actually not do something.
Any nodule which is less than 2 centimeter.
Less than 2 centimeters.
And it's completely cystic.
Completely cystic.
Or completely spongiform.
Spongiform, cystic, or smaller in size, less than 2 centimeters.
It doesn't have any compressive symptoms. It has been detected incidentally. I would like to watch.
Okay. Dr. Mani?
I think if someone presents with acute thyroiditis, if they have a painful nodule, that's once again, it's better to watch and wait, because it might settle down with the thyroiditis settling in. If they're having pain, we can give them analgesia and a beta blocker for a few days, and then reassess them in a week's time, along with the thyroid function test, which will tell us what's happening.
So TFTs and painful nodules, if it looks like thyroiditis, watch and wait. I'm going to come to Dr. Prem and Dr. Dalapathy. Which ones would you FNAC, but perhaps wait and watch for a second ultrasound or second FNAC? What is your criteria for a repeat?
So, if you have a nodule which has got either high suspicion for malignancy or intermediate suspicion for malignancy, but the ultrasound guided FNAC shows a Bethesda 2, then I would like to actually go in for a surgery, because the thyroids 4, 5 and 6, it has to be given higher importance. And sometimes the nodule may be less than 1 centimeter in size, but ultrasound characteristics are highly suggestive of malignancy. Then again, I would like to do an FNAC.
So it's not one or the other. You really take into consideration your Bethesda and your thyroids in deciding where you can watch and wait or where you might go for surgery. Yeah. And in those that you want to redo, what's your interval? How long do you want to wait for before you redo? What's the minimum? What's the maximum?
The ATS says 3 months. But depends upon what lesion it is. If it is a cystic lesion, partially you can wait to. But if it is a solid hypoechoic lesion, or if it is having peripheral rim of calcification taller than wider, then as early as 3 weeks. I discussed with my pathologist, they say after 3 weeks if you do, and the hemorrhagic background will not be there, it gets absorbed. So
even if there is any hemorrhage on the first FNAC, it will resolve when you are able to.
When the pain subsides and swelling comes down, you can repeat it.
Excellent. Dr. Dalapathy? You are comfortable with us watching and waiting these sort of slightly lower suspicion nodules for a repeat FNAC and sitting on them?
Actually, we will be more comfortable with a dedicated sonologist who does an ultrasound. That is very, very important. Nowadays, actually, sorry to say, not all radiologists are very well fond of doing a thyroid ultrasound. So only now the endocrinologists and the endocrine surgeons have started doing the surgeon performed ultrasound or the physician performed ultrasound in the office setting itself. So we need a dedicated sonologist or radiologist to comment on an ultrasound. That is very, very important, because even few FNACs have false positives and false negatives. But I would like to go, if the sonologist who I believe has done a good job, I would give more importance to the ultrasound report rather than an FNAC.
I agree completely. A good sonologist is your best friend in this kind of a situation.
Yes, for a follow-up, that is the report given by the sonologist is more important, rather than, because there may be inter-observer variation in FNAC, but a sonologist, it's very, very important.
Yeah. So a sonologist who has high volumes, who has good experience, and a pathologist who reports regularly do not accept any thyroid nodule reports without a TIRADS and an FNAC that has a Bethesda, please. So I think we still have maybe around 4.5 minutes. I'm happy to take questions. I know I'm the last person standing between you and lunch, but if you have any questions to our panel about any of the things we've discussed or anything we've not covered, yes, please, the mic's up front. Please come up to the mic.
Yes, it was an updating, amazing panel discussion, Dr. Usha.
Thank you.
Dr. Kamal, I just want to ask, because when you just told, I think in case 2 or something, the lactating female, when you just told about the radio ablation, is it better that we can wait for the physiological changes of the lactating period and then go for radio ablation, or you decide it during the lactating period?
We can wait for 3 months and then do an ablation, but it doesn't have much changes on the lactation, ma'am. Like, it's only on the nodule. We don't go into the normal thyroid. We just ablate the nodule. And it doesn't alter the thyroid function also, mostly.
Okay. Thank you.
So your friendly neighborhood radiologist with an ablation probe is your bet in lactation and pregnancy.
Okay, sure.
So any other questions from the audience, please? No? In which case, can I please hand back to Dr. Anand? Thank you.
Thank you very much. Thank you, Usha, and thank you, panelists, for that fantastic session. That session really was amazing. So, can I request Usha to felicitate our panelists? Thank you. Thank you very much. So we're going to go and break up for lunch right now, and so we should be back again by 2:15 for symposium number 4. So lunch, and we're back here again at 2:15 p.m. Thank you very much. Good afternoon.
அது நீ மாற்றிக்கோ, நான் அதான் ஃபுல்லாக மாற்றிட்டு வந்துட்டேன்.
type of patient in your day-to-day practice. Presented with weight loss, tiredness, and nocturia. His BMI was 23, not very high. Blood pressure was 142/82. Concerned about weight loss. And the fasting blood sugar was 188 and postprandial was 286 with a HbA1c of 9.4%. Had normal renal function and lipids. He admits that he takes a lot of carbohydrates. So what would be the next best choice for this patient? He had a HbA1c of 9, so maybe he might need a dual agent to begin with. So there is wide array of the anti-diabetic medications now available under 12 classes are available now to treat type 2 diabetes. And all the guidelines are uniform in choosing the first one. Metformin is the first one. And the second is influenced by the multiple international and national guidelines developed by various organizations with the intention to optimize the management of type 2 diabetes. So what is the doctor's expectation on the treatment of type 2 diabetes? So whatever medication we choose should be easy to prescribe, should provide a good control, provides long-term control, no or minimal side effects. Once daily, it should be once daily for the patient to have good adherence and protects from complication, minimal or no interaction with medications of comorbid conditions. As you know, sulfonylurea is the first one to develop first oral hypoglycemic agent. It is evolved from sulfonamales, which was accidentally found to reduce blood sugar. And so in 1940s, the first generation sulfonylurea were marketed, talbutamide and cropopamide. But University Group Diabetes Project reported higher CV mortality in 1970s. So talbutamide was withdrawn. In the 1980s, second generation sulfonylureas were introduced, that is glipizide, glibenclamide, and glyclazide were introduced in 1980s. And in late 1990s and 2000, long-acting second generation glyclazide, glimepiride, and glypizides were introduced. And after that, over 2000 to 2020, we had some cardiovascular risk studies with sulfonylurea. It was advanced study, advanced arm study, Steno-2, and TOSCA-IT studies were done. So coming to glycemic efficacy of sulfonylurea, if you this is a meta-analysis, and this compared with the other newer oral hypoglycemic agents like sitagliptin, vildagliptin, DAPA, and Saxa. And if you see, glyclazide and glimepiride scored better than all the other agents. It was equal to that of metformin. This also was shown in an Indian real-world evidence study from Kaldra et al. And Mohan group, where the HbA1c reduction was 1.3 to 1.5%, and the effects of fasting blood glucose was also much better. They've also found that the hypoglycemic episodes were less in patients. There was 4 in Kaldra et al. Group, and Dr. Mohan's group, it was about 0.3. So this reiterated that the efficacy is good with less sulfonylurea, less hypoglycemia with sulfonylurea treatment. So Wikipedia study, is an age-old thing. We've been seeing it in almost all the presentations. What is the highlight of Wikipedia study is that it is done when using sulfonylurea as an intensification agent in patients with type 2 diabetes. So during the study itself, it showed that there was microvascular and macrovascular complication reduction, and that also carried on for about 10 years after the end of the study. So there is legacy effect as well when you control the blood sugar earlier with a stronger agent which reduces blood sugar well. So intensive glucose therapy with sulfonylurea demonstrated reduction in the risk of microvascular complication in Wikipedia study. So what does the global guideline say about sulfonylurea in type 2 diabetes patients? There are various guidelines we follow most, some of them like ADA is one of the important things which influence our practice. International Diabetes Federation, NICE guidelines, EASD and AACE guidelines are the one which we look upon for management of type 2 diabetes. What do they say? Previously, it was all glucocentric. We were, even the American Diabetes Association was pointing out to reduce the HbA1c previously. But now it is all patient-centric, and you have to consider the ASCVD or diabetic kidney disease before you choose a medication. And so sulfonylurea was pushed to the third or fourth line in ADA guidelines. They also mentioned that it can be used as a second-line therapy when the ASCVD or heart failure or CKD are not present for a patient if cost is a consideration. You can use this sulfonylurea as a third-line therapy in patients with ASCVD or CKD as well, following a failure of SGLT2 inhibitor or GLP-1 receptor agonist. IDF is little lenient. They were considering our population as well. So they say that sulfonylurea can be given as a second-line therapy in patients except glibenclamide and when metformin is not tolerated or a combination with metformin. So they also say that newer sulfonylureas are safe in elderly patients and so consider glycoside or glimepiride in patients instead of glibenclamide. From the NICE guidelines, it was updated in 2022, which shows says that it is in line with the ADA guidelines, where it says that you have to stratify the risk of a patient before you give a medication, and they say SGLT2 inhibitor or GLP-1 receptor agonist as a second line with metformin. But you can consider SUs in a special populations and in patients who are not tolerating metformin, or if they are having higher blood sugar even with SGLT2 inhibitor and metformin. So you can use it as a third line. So EASD and AACE also reiterates what the ADA says, and they say that sulfonylurea should be treated as should be given as a third line or fourth line therapy, considering the risk of a patient. What do the national guidelines say about sulfonylurea and type 2 diabetes management? There are lots of countries have got their own guidelines in managing type 2 diabetes, and I'm going to highlight only about what we do in India. That is, ESI and RSSDI have formulated the clinical practice recommendations where the sulfonylurea can be given as a second-line agent to be used in persons with type 2 diabetes who are not obese. So that is a phenotype of our population, and it is not that we are very obese that we develop diabetes. So sulfonylurea are preferred in South Asian population, and dose of sulfonylurea should be reduced when the prandial insulin is introduced. Glimepiride and glycoside modified release are preferred sulfonylurea than glibenclamide, which causes which is longer acting and causes more hypoglycemic episodes. So second generation sulfonylurea are recommended in diabetic kidney disease, but they also recommend self-monitoring of blood glucose of patients who are on sulfonylurea. In NICE guidelines, what they say is you need not ask the patient to monitor the blood sugar when they are on oral agents alone, and you ask them to monitor the blood sugar if the patient goes on insulin. But our population, when even sulfonylurea is given, there is a higher risk of hypoglycemia, and so monitoring of blood sugar is important, and we have to reiterate for most of the patients who are affordable and can do it. So summarizing the guideline recommendation, there are about 33 recommended guidelines which recommend sulfonylurea as a second-line therapy for diabetes management, but there are not that much for the other agents to be given as second-line therapy. And the International Task Force recommendation on the use of second-generation sulfonylurea also reiterates whatever point which I've mentioned in the ADA and other guidelines for use in patients who are having metformin monotherapy failure. You can use second-line sulfonylurea. It can be used it can be used with other classes of anti-hypoglycemic agents as well. And second-generation sulfonylurea is preferable than other sulfonylureas. So what is the cardiovascular safety of sulfonylureas? A review of guidelines. The advanced trial was the first one which was using glycoside modified release, and it showed combined microvascular and macrovascular complication reduction of about 10% in patients who were intensively treated with sulfonylurea. And the Carolina trial, which compared linagliptin with glimepiride, also showed that it is non-inferior to, glimepiride is non-inferior to linagliptin in reducing the cardiovascular risk in patients who are older, younger. The patients were from 40 years to 75 years, and there were no increased risk in various age groups of type 2 diabetes patients. So the relative effects of linagliptin versus glimepiride therapy on CV outcomes were similar across age groups. The incidence increased and the mortality events increased with the increasing age anyway. But the HbA1c reduction was a little bit better in patients who were treated with glimepiride at the beginning of the study. But eventually, at the end of the study, there was not much difference between the HbA1c reduction between each group. But the hypoglycemia risk was little higher with sulfonylurea rather than linagliptin. If you look at the subgroup analysis again of Asian patients in Carolina group, there were about 933 patients who were Asians who were randomized to have linagliptin or glimepiride and followed up for 6.2 years. And this subgroup analysis reiterates the safety of glimepiride over, and it is equal to that of linagliptin in the CV safety in Asian type 2 diabetes patients. So this finding of CV safety of glimepiride in Asians is important because we were using sulfonylurea more than any of the other countries in the world. So findings from the Carolina trial have been integrated into most recent guideline updates, which acknowledge similar CV safety of glimepiride to DPP-4 inhibitor. So indirect comparison of Carolina and Carmelina also shows that glimepiride is non-inferior to placebo in the CV as far as CV risk is concerned. And confirmation of CV safety of glimepiride is reassuring. So TOSCA-IT trial, in this long-term pragmatic trial, incidence of cardiovascular events was similar with sulfonylurea. In this study, they used mostly glimepiride and glycoside, but also glibenclamide was also used in this study. So, and it was compared with pioglitazone as an add-on treatment to metformin. Both is widely available and affordable treatment or suitable options, and respect to efficacy and adverse events, it was all equal. And pioglitazone was associated with fewer hypoglycemic events comparing to sulfonylurea. If you take the other special population like elderly people, glycoside seemed to be scoring better than glibenclamide, as I pointed out before with the guidelines. It has less hypoglycemic events comparing to glibenclamide. And during Ramadan, when you are fasting, the sulfonylurea was compared with DPP-4 inhibitors and glibenclamide. So if you see, glycoside produced less hypoglycemic events than sitagliptin itself. So it is safe to use in Ramadan as well. So as long as other special population is concerned, you have not enough data with pregnancy. So we cannot use in pregnancy, even though we have some data with glibenclamide in pregnancy. I would not be advising that at all for patients here. So in children, it is not recommended can be used, second generation sulfonylurea can be used in comorbid conditions because of ASCVD risk reduction in patients who are using glycoside and glimepiride. Sulfonylureas like glypeside preferred with people with moderate to severe CKD, and lowering the dose of sulfonylurea is mandatory in patients who are having mild to moderate hepatic impairment. So even though we have evidence of efficacy and also safety of sulfonylureas, there is difference in positioning of sulfonylurea. EASD and ADA says that sulfonylurea should be as a last choice in people with ASCVD and CKD and heart failure. And Canadian guidelines also was similar, not advising sulfonylurea as a first-line therapy. But recommendations from RSSDI recommends glycoside MR and glycoside glimepiride as they cause less adverse events. The other guidelines like South Asian Federation, Canadian, Australian guidelines and South African guidelines all mention about second generation sulfonylurea and glycoside, maybe because of a lower risk of CV risk, lesser hypoglycemic episodes, weight neutrality, microvascular benefits, and lower cost. So what should we do as far as Indian population is concerned? So we have to have a patient-centric approach to sulfonylurea therapy. We need to see what is the risk of patient, the comorbidities, ASCVD risk, heart failure risk, and CKD risk, hypoglycemia, the risk of hypoglycemia for the patient, the side effect profile, body weight. Our phenotype is different than other population. Cost is another important factor we need to look at, and patient preference as well. So need for individualized type 2 diabetes treatment in South Asia is mandatory. We need to have a separate guidelines for us considering our phenotype, which is diverse and heterogeneous lifestyle. We have a heterogeneous lifestyle. Environmental, cultural, and social economic factors have to be considered as well. So coming to that patient, considering his socio-economic status, he was started on metformin plus glycoside MR, 60 milligram once daily. After 3 months, fasting blood glucose was 136, postprandial was 178, HbA1c of 7.2%. He was experiencing some hypoglycemic symptoms, so his glycoside dose was reduced to 30 milligram once daily. See, he missed his follow-up. He came back after 1 year, was taking the same medication, no hypoglycemic symptoms, and his fasting was 122, postprandial of 168 with a HbA1c of 6.8%. He was asked to continue on the same medication. So coming to a summary, sulfonylurea continued to play an important role in the management of type 2 diabetes in our country. We have to choose an agent which is cheaper and which is have longer duration of durability, less hypoglycemia, and also cardiovascular safety should be considered. So I always tell this in this meetings about this Thirukural, which is Utran alavum pini alavum kalamum katran karidi cheyal, which means that you have to, which is patient-centric approach, which was written about 2000 years back. Old but still gold is an apt phrase for sulfonylurea therapy in our country, at least for now. Thank you.
Thank you, sir. That was very excellently put in a nutshell. Especially, I think 10, 15 years before this, I think we never ever thought about any other drugs other than sulfonylurea and metformin in the management of diabetes. But the current scenario has changed, and there are so many new kids on the block which has replaced the role of sulfonylureas, which are trying to question the role and position of sulfonylureas in the management of diabetes. But I think sir has very elegantly put 3 things. In a country where cost effectiveness is very important, and glycemic efficacy is still unsurpassed. Sulfonylurea still holds its place, and we are moving more and more towards personalized medicine. I think sulfonylurea should be chosen cautiously in patients who actually require that medication. And again, the newer generation sulfonylureas, glycoside, glamiprid, and glyphosate, I think they are relatively safer, as time and again shown by the Carolina trial. And hence, sulfonylurea, though old, it's almost completed 75 years in diabetic therapeutics, but still it holds its place. Thank you, sir.
Now we understand that with the advent of modern sulfonylureas, they still have a role, especially in the developing population like ours. One thing I want to tell us again, strict adherence of lifestyle modification is also equally important, and we have to target on all the aspects of diabetes, including the complications. And I would like to, sir, I would also like to point out one Tirukkural, Marundana Vendavam Yakikku Arundiyatrathu Potrivunam, highlighting the effect of nutrition therapy. So any questions from the forum? We'll take up at the end of the sessions, both the sessions. Thank you, sir.
So for the next topic about CGMS, Continuous Glucose Monitoring System, I'd like to invite Dr. Shanmugasundar sir, who is a very known endocrinologist, renowned for his speech from Magna Center for Obesity, Diabetes and Endocrinology, Chennai. Over to you, sir.
Good afternoon, everyone. At the outset, I thank the organizing team of this Trendo 2022 for giving me this opportunity. So, the topic given to me is the role of CGMS, advantages and pitfall in clinical care. So, what I'm going to do in next 15 to 20 minutes is basically what should we know about CGM. So, what are the types of CGM available in our country, and what are the important concepts? What should we look for when the patient comes to us with the CGM report? What should we look for? And what is AGP, ambulatory glucose profile, and how to review this in a nutshell. And then I will discuss about the advantage. What are the studies available to say that this time in range and CGMS is beneficial for the patient, and in what ways? And what are the barriers or the disadvantages of using the CGMS? And what are the patients requires CGMS in our clinical practice? So what is continuous glucose monitoring? Basically, a sensor measures the glucose level in the interstitial fluid, whereas blood glucose measurements measures the glucose in the blood. So CGMS has a sensor, it has a transmitter, and usually the phone or we will have a receiver which receives the data from the sensor. And there are two types, real time and flash. So real time means the transmitter will be continuously sending the data to the receiver, that is either the handheld receiver is there, or phones nowadays, a lot of apps are there with which we can receive the data. So it's a real time glucose monitoring. Second is flash glucose monitoring. Here the patient periodically has to scan the sensor. So the receiver then takes the data from the sensor. So at presently available this Abbott Libre, you have to take the data every 8 hours. So the sensor has the capacity to store the data for 8 hours. If you are not going to scan within 8 hours, the data will be lost. So the flash glucose monitoring, patient has to scan the sensor frequently. So HbA1c is a time-tested measurement. We know that it measures a long-term glucose control in the last 3 months, and lot of data are there with HbA1c, which are shown by keeping the HbA1c within the control leads to good reduction in the micro and macrovascular complication. But the HbA1c does not reflect daily glycemic excursions and does not tell us whether the patient had any minor hypoglycemic episodes in the last 2 or 3 months. So we don't get those data, we'll just get a number. So the same number can be achieved in a 2 different ways. The patient may achieve it without any glycemic variability. The other patient would have been had multiple episodes of hyper and hypoglycemia, but with the same HbA1c. So we don't have any of those data with the HbA1c. And we don't know exactly how much postprandial glycemic excursions has happened with the HbA1c level. Whereas CGMS addresses all this lacuna. So we know what are the daily glycemic excursions happen in the patients in the short term, last 7 to 14 days, and how many hypoglycemic episodes have happened with the patients. And we know with respect to the patient lifestyle or the food pattern or the medication, how the postprandial glycemic excursion has been happened, and how much time the patient is within the time in range. So that concept time in range is a new concept, new glucose metric. So we will know from the CGMS how much percentage of the time the patient is within the range, above the range and below the range. And another important thing is patient trend towards the hypoglycemia and hyperglycemia. So these are the many concepts I will be discussing in the future slide. So what are the types of CGM systems? One is the professional CGM and personal, and another is personal CGM. Professional CGM is the owners, the clinic, the doctor or the hospital will own the receiver. So the patient will be put in sensor, and the patient will come to us after 7 days or 14 days, and we take the retrospective data. That is the professional CGM. 2 to 3 years before we were using this professional CGM. So examples are iPro 2 by Medtronic and Freestyle Libro Pro. But now we have this personal CGM. That is the patient owns the receiver. So it can be a company given receiver, or it can be a mobile phone also. So here we will get the real-time feedback. In the real-time CGMS, automatically the sensor will be sending the data to the receiver. If it's a flash device, the patient has to scan frequently so that the sensor will give the data to the receiver. And it can be weighed for 14 days also. Now we have this Freestyle Libre, the patient can wear it for 14 days. So we can real-time, we can see the data. And personal CGM is not compatible with the insulin pump. And professional CGM. Personal CGM, it is compatible with smartphones, and also it can be linked with the insulin pump so that this loop can be formed. Automatically the insulin pump can deliver the bolus insulin. So comparison of personal CGM systems. So there are 4 types of personal CGM system: Dexcom's G6, Freestyle Libre Flash, Guardian Connect, and Eversense. In India, mostly we use Freestyle Libre and the Guardian Connect. So I will just focus on these 2 things. So the main difference is the calibrations are not required in Freestyle Libre, whereas calibrations are required in Guardian Connect. MARD, that is which tells about the accuracy of the CGM. So it's 9.4% in the Freestyle Libre, and Guardian Connect is 9.54. And insulin pump integration can be done with the real time. Now even the Freestyle Libre Flash, now the real time has come in the Western countries. It is called Freestyle Libre 2. It's not available in India. And FDA approved for dosing, again very important. It is approved for Freestyle Libre. That is if the patient has hypoglycemia or hyperglycemia in CGM monitoring. The dosing, the insulin dose adjustment can be done if the patient is wearing Freestyle Libre, whereas in Guardian Connect, the patient has to confirm with the glucometer reading. And for pregnancy, Freestyle Libre is approved. Guardian Connect, still we don't have the approval. So coming to important concepts. So I will discuss about lag time and what is the trend. Trend means what in CGMS, accuracy of the CGMS, time in range, and other important concepts. So lag time, very important slide. So this green indicates the plasma glucose level, and the red indicates the sensor glucose. So if the patient is experiencing hypoglycemia, if we see, there is almost 5 minutes lag time between the sensor value and the patient this blood glucose value. So usually the sensor glucose value lag behind the plasma glucose. So always if the patient has hypoglycemia, it's always better to confirm by the blood glucose. And the second thing is when we give treatment for this hypoglycemia, again if the blood glucose rises, the sensor value lags behind the blood glucose lags behind the sensor value by almost 5 to 10 minutes. Why it is important is if the sensor value is showing very low sugar glucose again and again, we will be giving treatment again and again. So the patient can land up in significant hyperglycemia. Again, when you are going to treat the patient hypoglycemia, when the sensor is showing hypoglycemia, low glucose values, always better to cross check by the glucometer values. And when the patient has been treated, if you see again the sensor value is lagging behind the blood glucose value, glucometer value, sensor glucose is lagging behind the blood glucose, and usually it overshoots after some times. So this lag behind the blood glucose value you should know. When the patient is experiencing hypoglycemia and when you are treating hypoglycemia, it's always better to reconfirm by the glucometer value rather than just taking decision based on the sensor values. What are the trend arrows? So nowadays in the real-time monitoring, we will get this trend arrows. If the trend arrow is upward, it shows that glucose values are rising rapidly. So you can increase the correctional dose by 20%. And if the arrow is like this, shows it's rising but not rapidly. So you can increase the bolus dose by 10%. If arrow is it's flat, then the glucose changing is values are changing very slowly, so no need to change the bolus dose. Similarly, for the downward arrow, if it's straight down, the blood glucose is falling very rapidly, then you have to decrease by 20%. And if this arrow is like this, then it's falling but not rapidly, so decrease the value by 10%. Again, these are the general guidelines, but individual adjustment has to be based, it has been taken based on the patient's comorbidities, specific needs, age, etc. So, but we should know what is this arrow indicates, so accordingly treatment has to be given. Coming to accuracy, that is measured by MARD, that is mean absolute relative difference. It helps in assessing the accuracy of the CGM. It is the mean difference between the interstitial glucose and reference blood glucose values. So if MARD less than 10% means it's accurate enough to take the treatment decisions. For example, like Dexcom and Freestyle Libre has MARD less than 10. So that's why FDA has given approval to make decision based on the sensor values. If MARD is more than 10% means it's always better to check the glucometer reading, crash check by glucometer reading before making the decision. And we have to remember the accuracy of sensor is dependent on the blood glucose range within the range. If the patient is having significant hypo or hyperglycemia, it's always better to crash check. Also, it showed the lag time between the difference between the sensor and the blood glucose value. So if there is any significant hypo or hyperglycemia, always crash check with the glucometer values. Coming to time in range, new glucometric for managing diabetes. So it tells us how much duration the patient is within the range, 70 to 180 milligram per deciliter, and it also tells us how much time the patient is below or above the range. So the recommended TIR, time in ranges, range targets are for the different diabetic population is different. So type 1 and type 2 diabetes, older patients, and pregnancy with the type 1 diabetes patient, pregnancy with the type 2 diabetes and gestational diabetes, it's all different. So I will concentrate on type 1 and type 2 patients. So the time in range is the value of 70 to 180 milligram per deciliter. At least 70% of the time, the patient should be within the time in range. And time below range, level 1, that is from 70 to less than 70 to 54, the patient should be in the less than 4%. Time below range, level 2, it should be less than 1%. That is time below range, level 2 is less than 54 milligram per deciliter. Time above range, level 1, less than 25% of the time, the patient should have 180 to 249. And time above range, less than level 2, that is, it should be less than 5%. That is, the patient should have more than 250, less than for only 5% of the time. So this is for the type 1 and type 2 non-pregnant patients. For GDM and type 1 high-risk patients, it's completely different. Other consideration, the paracetamol intake, again interferes with the interstitial glucose measurement, particularly with respect to the older Dexcom and Medtronic. Newer Dexcom and Medtronic has addressed this issue. And direct pressure, any direct pressures on the CGM again interfere with the local blood flow, so that again can lead to alteration in the value. It shows low value, so that should be taken into account. Coming to ambulatory glucose profile, what is ambulatory glucose profile? So this is how we will get the report in the ambulatory glucose profile. So time in range already discussed. So glucose management indicator, before it used to be measured, mentioned as estimated HbA1c, now it has been changed to glucose management indicator. So that tells us average, approximately average HbA1c in the last 14 days. Second is glucose variability. So how much glycemic variability is happening in those last 14 days. So usually it should be less than 33%. So we also get daily glucose profile like this, and ambulatory glucose profile is retrospective data, average of the last 14 days. So here a lot of data we can see, get it from this. So this center dark line indicates the median blood glucose. So it tells us the average blood glucose at point of time. For example, at around 10 p.m., the average blood glucose of this patient is around 250 milligram per deciliter, 10 a.m. And this dark blue indicates 25th to 75th percentile. So this is the time, most of the time the patient is having a blood glucose between this 25th to 75th percentiles. Third, this light blue indicates 10th to 90th percentile of the time. So when this data are present, what should we see? First thing what I will see is how much time the patient is experiencing hypoglycemia. For example, I don't want my patient at any point of time less than 54 milligram per deciliter. That is, the 19th centile at any point it should not be less than the 54 milligram per deciliter. Then I am more concerned about this patient. Second thing is, if 25th centile, if it is less than 70 milligram per deciliter at any point of time, again I am concerned that my patient is prone for hypoglycemia. So this first I will notice this 10th centile and 25th centile. So 10th centile any point of time less than 54 or 25th any point of time less than 70, then we should address that first. Then if those things are not there, if my patient is not having hypoglycemic episode, then I am more happy to see the center line, median. So what at that particular time, what is the average blood glucose, so when the hyperglycemia is happening, and what could be the cause for that, again you can address. So in this patient, if we see, the patient is developing hypoglycemia, so we have to address this, and also post meals, post breakfast and post dinner, he is having hyperglycemia. So we need to ask the questions, what type of meals he is taking, whether the insulin dose is appropriate, or there is any change in the exercise pattern day to day. So all those things has to be questioned and has to be addressed. So how to effectively review this AGP data, because a lot of data we have. So first thing is mark directly few things, type of diabetes, duration, age, and what time he goes for walking, what time he used to take the meals, what type of meals he is taking, how much carbohydrate he is taking, and what are the medication he is taking. So all those things, mark those on the AGP. And next is look for the patterns of low glucose rating, already discussed. The 10th centile less than 54 or 25th centile less than 70 milligram. You need to address that first, and look for the patterns of high blood glucose value. That is, if the hyperglycemia is happening particular time, again ask for the meal pattern, exercise pattern, all those things, and try to address that. And finally, go for the action plan. So change in the lifestyle, change in the diet, change in the insulin dose, all those things can be discussed with the patient with this lot of data. So how to approach? So after getting all this data, we can change the meals. So after changing the meals, we can see how much the blood glucose is coming down with the lifestyle modification itself. So the patient can scan hourly for the first 4 hours post meal, so that he can get the data. So accordingly, he can change the diet and see whether the blood glucose is coming down. And before and after exercise, it's always better to monitor the blood glucose. So during immediately and after the exercise, whether there is any significant change in the blood glucose. And during illness, again, it's a good tool to see whether the patient is experiencing any hypo or hyperglycemia. And post insulin dose correction, or say the patient is taking OH also, post changing the doses, any hyper or hypoglycemia is happening, or whether the blood glucose is within the range, we can get data from this. Coming to what are the benefits of CGM. So time in range, so if you see this time in range, if there is a 10% decrease in the time in range, there is a 64% increase in the retinopathy and 40% increase in the nephropathy rate when the time in range is decreasing. So again, this is exploratory data from the DCCT study. And coming to macrovascular event, 10% increase in the time in range leads to 6.4% lower risk of abnormal carotid intima media thickness. And this is data in the peripheral neuropathy in type 2 diabetes and CKD. Again, with increase in the time in range, the neuropathy prevalence is also decreasing. And this is the data on the autonomic neuropathy. And the autonomic neuropathy is significantly associated with the change in the time in range. Good thing is the autonomic neuropathy decreases with the increase of TIR. So that is, if the TIR is improving, the autonomic neuropathy is also improving. So this data says autonomic neuropathy is more if the TIR is less, and if TIR is improving, the autonomic neuropathy prevalence is also decreased. This is the data based on TIR. So there are few landmark trials for CGM. So I'll discuss only important landmark trials. So Diamond and this Gold trial, it has been done in type 1 diabetes with poorly controlled type 1 diabetes. So they have shown there is improvement in the HbA1c level, but we don't want this one only, because the main use of CGM is to decrease the incidence of hypoglycemia also. So the IMPACT trial is again a very well conducted trial. They have chosen well controlled type 1 diabetes, and they have seen there is a reduced time in hypoglycemia, because in type 1 diabetes we are more worried about hypoglycemia. Usually the patient goes for the hypoglycemia due to glycemic variability. So this data shows there is significant decrease in the hypoglycemia. And replace study has been done in type 2. Again, lot of CGMS data are with type 1 diabetes. Type 2 diabetes, we have very, very scarce data. And here, type 2 diabetes on insulin therapy, they have done this study. They have shown there is a sustained reduction in the hypoglycemia. and episodes in the type 2 diabetes patient also. Concept studies done in pregnant patients, they have shown more time in targets, less time hyperglycemia, and neonatal outcomes also significantly improved with the CGM. Cosmer study again in type 1 data, there is a significant decrease in HbA1c and hypoglycemia with SIR, sensor augmented insulin regimen. FLAR data from both type 1 and type 2 from Netherlands, they have showed 58% reduction in the work absenteeism, and they are also improved in the quality of life. Coming to barriers, what are the important disadvantages of using CGM? One is the cost, and in our country, insurance doesn't cover the CGM. Aversion to wearing a device on the body, and many times you do see patient after second or third day they used to remove the CGM, and they don't want to show to the other that they are having diabetes. Denial of disease. Over much data, we are talking about data, we are getting a lot of data from the CGM that helps in the patient. Sometimes over data also can lead to diabetic distress, and many times if the patient gets frequent alarm, that also can cause alarm fatigue. Sensors side skin irritation or adhesive problems, we do see some of the patient. Data gap, sometimes if they are not going to scan the flash glucometer, flash CGM, every 8 hours the data can be lost. Body image concerns in the young. Clinician or physician barrier, if they are not very well versed with the CGM, or they don't know how to download, how to install, again, the physician may not advise the CGM to the patient. Coming to the last part, there are Indian guidelines, consensus guideline on CGM. So these are the recommendations for the CGM. So in type 1 diabetes, adult and pediatric, whenever the patient is having severe hypoglycemia or hypoglycemic unawareness or uncontrolled hyperglycemia, then CGM is recommended. Type 2 diabetes, receiving insulin sulfonylureas, again it's strongly recommended, particularly if the patient is prone for hypoglycemia. Gestational diabetes, the CGM can be used to evaluate the glucose pattern, fine-tune the insulin regimen. Again, the concept study has shown there is a significant improvement in the neonatal outcomes also with the usage of CGM. So to summarize, CGM is a promising technology for improving glycemic control. Not only improving glycemic control, there is a significant decrease in the hypoglycemic episodes also. Most of the data are with the type 1 diabetes. We have few data to support for use in type 2 diabetes also. And it also helps in managing the patient-specific PPG excursions. And novel parameters, it's helpful for managing the diabetes in a better way, like time in range, glycemic variability, AGPs, and trend. What are the changes in the glucose trend values help in making the decisions. And overcoming barrier is very, very important, and a lot of patient barriers is there, particularly the cost, and they don't want something to be attached to the bodies, many times, so counseling is very, very important. And clinical barriers by good education to the physicians, like having the hands-on experience with the CGM and how to interpret the data if physicians are taught, they may use this technology more in the coming days. Thank you. Thanks for patiently listening.
Thank you, Dr. Shanmugam, for your excellent highlighting the points. And we should understand that this continuous monitoring is another feather in the support systems. Yeah, of course, it is useful for especially for some populations who do not have adequate control, and though they need calibration with the SMBG at times, we should understand that they will give a better picture about the patient's issues, and they can be addressed in a better way. And this episodes of hypoglycemia can be detected, and it can also be extrapolated to the caregivers. They can also be alarmed and sensed for such complications.
I think the session is open for questions. As we are running late, we'll limit the time to 5 minutes.
Good afternoon, ma'am. How long we can use sulfonylurea, ma'am? Is there any limit to use glimepiride 2 mg, 4 mg, 10 years, 15 years? Because it's a progressive disease, diabetes. How can we find its sulfonylurea failure like that and all in a general practice?
All the patients have to be followed up regularly. As long as the durability depends on, I always tell my patients, whatever medication you give, unless they change their lifestyle, restrict the carbohydrate, and do proper physical activity, any medication you are going to give is going to fail. So our guidelines say that if you are having a HbA1c of more than, say, 7.5 in elderly patient, 7 in a younger patient, then possibly it is a failure and you need to escalate the treatment. Either increase the dose or you have to introduce a new medication. So it is not that the drug is failing, it is the part of problem with the patient as well.
So in the first case, is there any possibility of using short-term insulin therapy, sir? Since the patient,
when the patient is presenting with a very high blood sugar, symptomatic, then possibility of giving there are evidence that if you give insulin short-term, about 1 or 2 weeks, and then change over to oral hypoglycemic agents, then the blood sugar will be remaining in a normal range for a longer duration of time. So yes, when the patient is symptomatic and the HbA1c more than 10, yes, insulin therapy short-term would be a best option.
So, we can use glimepiride for a short while and then we can wait and can use insulin as a for the patient.
First start panni.
Yeah,
short. See, no. You can use, I mean, if the patient is very high blood sugar, then possibly, I mean, they have a criteria of the fasting is more than 200, postprandial, I mean, you don't need to consider postprandial. Fasting is more than 200, if the HbA1c is more than 10, they mean that the patient is having insulin deficiency, maybe glucotoxicity.
Thank you, sir.
So my question on CGM. So we know that HbA1c is not very reliable when there are coexisting conditions like chronic kidney disease and liver disease. What about the accuracy of CGMs in such patients with kidney disease or liver disease? Is there any problem because of the metabolic derangements in interstitial blood glucose monitoring?
So there are data show that even in CKD patients, TR is a valuable indicator to show that there is improvement in the many microvascular complication. But the accuracy, I don't think so it changes in CKD or other population also. There is no specific guidelines or mention on it. So we can very well use in CKD also.
One more, sir. You told about Freestyle Library Pro and Medtronics, that is Guardian, which is the common things which are available for us to use. From your practical experience, like, do you find any significant differences, not in terms of accuracy, but even in terms of technical aspects? For example, this lost signal and that data gap, or like frequent falling of that sensor, something like that, if you find.
Yeah, this happens mostly with abort, as it has to be weighed in the arm. That's a preferred site. So many times the fall of the sensor is more common with the abort freestyle, whereas in Medtronic it's very rarely we see those kind of problems. And but nowadays, as because of the cost, abort is slightly cheaper than this Medtronic. We prefer to use that also, and it gives a 14 days values also. So what I do in my clinical practice, after insertion, I call them after 7 days to see what are the readings. Then it's better to intervene the prescription or change the lifestyle, so that after 14 days we can see
we'll get a review.
What are the changes happening also. That helps in making the changes, and patients also will understand. So due to that purpose, I prefer more freestyle than Medtronic.
So thank you very much, dear speakers and chairpersons. We'll bring that session to the close. So can I request the chairpersons to felicitate our speakers? And can I request Dr. Vijay Bhaskar Reddy to felicitate our chairpersons, please? Thank you very much. We move on to symposium number 5. And may I request my Professor of Medicine, Professor Vivekanand Sir, and Professor Venkatesh, Professors of Medicine, to take on to the stage, please, to the next session.
Good evening to all. I first of all thank the organizer for giving me this opportunity to chair this session. This session is a wonderful session where we have mostly electrolyte disturbances, which will be beneficial for all specialities. So the hyponatremia is one of the common problem we often encounter. Any person presents with drowsiness, irrelevant talk, we always think about hypoglycemia. In addition, if it is normal, we will think about hyponatremia also. With these few words, I is over to Professor Vijay Bhaskar Reddy for this deliberation.
Thank you, sir. Thank you for the introduction. Moving on from glucose metrics to common electrolyte disorders. First talk I will be giving on hyponatremia, common mistakes during management. Agenda will be, I will discuss a few basics about hyponatremia. I will discuss about what are the common mistakes during management and few take-home messages. So we know that sodium is a major osmotic solute in the extracellular fluid. It's an important determinant of the ECF volume status, tonicity and osmolality. So often when we are talking about sodium, people always think about salt and sodium only. But actually serum sodium is a measure of water status rather than the total body salt content. So when we are thinking about sodium, you should think about water. A low serum sodium actually indicates excess water mostly. So it's not only a problem of sodium, it's actually a problem of water. So sodium is closely regulated by these three mechanisms: renin-angiotensin-aldosterone system, ADH or vasopressin, antidiuretic hormone, and the thirst mechanism. So these three mechanisms control the body's sodium. So sodium is affected by both changes in osmoregulation and volume regulation. So changes in the plasma osmolality triggers the ADH and thirst mechanism, and if the plasma osmolality is going up, so then there is reduced water excretion and the water dilutes the osmolality. Similarly, you tend to drink more. So if you're losing volume, then also the sensors and the carotid sinus, atria and the afferent arteriole, this triggers the sympathetic nervous system, renin-angiotensin system, natriuretic peptides, and then you get sodium excretion. So both osmoregulation, volume regulation is there. So how do we define hyponatremia? So hyponatremia, as I already told, is actually excess water relative to the sodium. So people are losing more sodium and there is relatively excess water. Either the person is taking more water or the body is retaining more water. So normal serum sodium level is 135 to 145 milliequivalent per liter or millimole per liter. And hyponatremia is serum sodium less than 135 and severe hyponatremia is less than 125. So it's a very common clinical problem, mainly in hospitalized patients. It's the most common electrolyte disorder in the hospitalized patients. In outpatients, we often do not check the electrolyte levels and we do not find major problems in ambulatory patients. So ambulatory patients, the prevalence will be less than 5%. But in hospitalized patients, depending on the setup, whether in the ICU or whether in sick patients, the prevalence can vary from 10 to 30% in various studies. And hyponatremia is a bad prognostic indicator. It can increase the morbidity and mortality. So we can classify hyponatremia in various ways. So based on the onset and rapidity and duration, we can classify into acute, which is classically less than 48 hours, and chronic, which is more than 48 hours. We can have true hyponatremia or pseudo-hyponatremia, Based on the severity, we can classify as mild or severe. So most of the cases will be mild hyponatremia between 130 to 135 range, and severe hyponatremia will be only 10% of cases, less than 125 milliequivalent per liter. So the clinical manifestations of hyponatremia depend on the rate of decline of serum sodium, what is the severity, and acute free fall of sodium over 24 to 48 hours produces severe cerebral edema, which can be fatal and it has to be corrected quickly. Gradual fall, however, is much compensated by the brain and can be asymptomatic. The symptoms can vary according to the severity of hyponatremia and also the rate at which the sodium is falling. So mild hyponatremia, 130 to 135 sodium, so they can be asymptomatic or there can be subtle mental changes. And moderate, patient can have nausea, malaise and non-specific tiredness. And less than 125 sodium, then we develop progressive symptoms, confusion, coma, seizures also can be there. So if the patient is unconscious, comatose, and your sodium is 133, it is difficult to say that hyponatremia is the cause for the symptoms. So recap of the relevant physiology, hyponatremia is less than 135 milliequivalent per liter. It is not a diagnosis per se, so it can be due to various causes. Always we should see sodium along with water balance. Hyponatremia is most often due to relative water excess rather than sodium loss. Irrespective of the cause, hyponatremia, if severe and rapid, it causes cell swelling or cerebral edema. On the other side, if you correct the sodium too quickly, especially in chronic setting, then you will end up in this condition called osmotic demyelination syndrome. So you have to be careful. So why are we concerned about hyponatremia? So if it is acute fall in the plasma sodium, so the water content in the blood increases and the water enters the cells. So you get swollen brain cells and intracerebral edema. And if you correct the sodium fast, then the same fluid comes out from the brain cells, you can get osmotic demyelination. So you should not allow rapid changes in the sodium. So what are the practical issues faced during management? The previous technology of sodium measurement was flame photometry. Nowadays we have ion electrodes which are much accurate and which can be more dependable. Another issue which I want to discuss is many labs may not be reliable. So if you are not confident of the lab in which you are getting, it's always preferable to repeat a serum sodium because many labs may not give accurate reports. In ICU, you will get a ABG report with so many parameters. So in that, sodium report is less reliable, so you cannot depend on the ABG serum sodium value. Hyponatremia, as I already told, it's a major solute. It's associated with low osmolarity. So pseudo-hyponatremia is where the osmolarity tends to be normal or high, like hyperglycemia. So osmolarity has to be calculated to accurately manage the sodium levels. We can do either calculated versus measured osmolarity. So how do we approach the patient? First we have to look at how is the patient, whether the patient is symptomatic or asymptomatic. Is it acute or chronic? Is it volume depleted or volume replete? And whether we need to treat fast or slow. So the first step is confirm the low serum sodium levels, especially if you're not confident of the lab and it's not matching with the patient. And we have to take a detailed history, especially the other medical illness, like some endocrine causes can cause hyponatremia, then any CNS causes, lung causes, drugs. So this history has to be taken properly. After that, we can calculate a serum osmolarity, and we need to do a clinical assessment of the volume status, and we can do a urine sodium. Based on this, we can come to a conclusion what is happening with the sodium. So the first step in hyponatremia evaluation is serum osmolarity measurement to assess the tonicity. This is the classical formula, 2 into plasma sodium plus glucose by 18 plus BUN by 2.8. So this is a calculated osmolarity. If you have a gold standard method, we can calculate the serum osmolarity directly by freezing point depression method. It's not available mostly. So hyponatremia is serum sodium less than 135. So normally when hyponatremia is there, usually hypotonic serum osmolarity will be there, less than 275 milliosmol per kg. So if it is hypertonic, then this is not a true hyponatremia. So then you have to look at hyperglycemia or hypertonic fluids like mannitol. Isotonic, again it is pseudohyponatremia. So classical or true hyponatremia is associated with hypotonic. Hypertonic hyponatremia, most often we see due to hyperglycemia. Serum sodium drops by 1.6 milliequivalent per liter for each 100 milligram deciliter rise in the blood glucose level. So blood glucose retains the water in the blood and dilutes the sodium. Isotonic hyponatremia used to be a problem previously when sodium was measured by flame photometry. The lipids block the estimation of sodium. But now with ion-specific electrodes currently, we do not have this issue. So once we clear out the hypertonic hyponatremia and isotonic hyponatremia, we are left with true hyponatremia or hypotonic hyponatremia. Then we look at assess the volume status, and we have to classify these patients, whether they are hypovolemic, whether they are losing fluids like renal, like diuretic, or cerebral salt wasting, or extrarenal like GI loss or third space loss, or whether they are hypervolemic like congestive heart failure, cirrhosis, or nephrotic syndrome, or whether they are euvolemic like SAADH, hypothyroidism, hypocortisolism, and primary polydipsia. So once you decide these three, already I told, when you're looking at sodium, we have to look at water. So based on the volume status, we manage these patients. So SAADH is, there are clear-cut criteria. So you need hypotonicity, that is serum osmolality should be less than 275. And normally when the serum osmolality is low, the urine gets dilute. So, but in this case, urine osmolality will remain high, more than 100. Clinical euvolemia will be there. Urine sodium will be more than 30. And it's a diagnosis of exclusion. You have to exclude adrenal, thyroid, and renal insufficiency. No recent diuretic use should be there. And additional criteria are there. Uric acid less than 4. So SAADH is one of the common causes of chronic hyponatremia. There are so many causes of SAADH: malignant disorders, pulmonary disorders, CNS disorders, various medications, especially antidepressants, anticonvulsants. So that's why we need to take a good history and assess for all these conditions. So patients who are having CNS disease, we have to differentiate cerebral salt wasting versus SAADH. Cerebral salt wasting is hypovolemia, and serum sodium is reduced, but urine sodium is actually increased, and urine output is also increased. So here we tend to replace volume, whereas SAADH we tend to restrict the volume. So coming to what are the common mistakes during management. So this is one case which I saw recently, 45-year-old lady, known case of type 2 diabetes of 10 years duration on 3 OADs. Blood glucose level 500 milligram per deciliter. Serum sodium was 129, and outside she was treated with 3% saline. So this is a clear error in management. First, we already saw that when hyperglycemia is there, then the sodium level tends to drop, that is pseudohyponatremia. So if you correct the serum sodium, so for every 100 milligram per deciliter rise above 100, you have to correct by 1.6. So this patient had 400 above the 100 milligram. So 4 into 6.4, so actually this patient did not have hyponatremia. She did not require any correction with 3% saline. So when the hyperglycemia is there, patients can have pseudohyponatremia. So we don't need to hurry to treat it. This is another case, 45-year-old alcohol excess found collapsed on street. This is very common in Puducherry, from where I come. Alcohol is very famous in Puducherry. If you go to government general hospitals, a lot of these patients will be brought and kept in the emergency department. It's confused, disoriented, however, no focal signs. Often we give thiamine and dextrose in these conditions because the alcohol causes hypoglycemia. So we check the blood glucose, we give dextrose, and patient did not have diarrhea or vomiting. You can see sodium was 109 and potassium is 3.2. Alcohol excess patients, they can have gastritis, they can have vomiting. He had seizures and GCS dropped to 9. So this case, you can see that sodium level is quite low and patient is symptomatic. So this actually needs to be treated quickly. So what would you do? We can arrange the tests. We saw a lot of tests, urine osmolality, urine sodium. We can wait for the results, or we can give normal saline or 3% saline. So this case already I told, sodium likely to be acutely depleted, but we cannot say whether it's acute or chronic, but the patient is very symptomatic, so we have to give 3% saline. So you don't do it, you're damned, and you do it, you're damned. So you're in a difficult position. So if you give sodium quickly, you can reverse the cerebral edema and the patient can have improvement. But if you do fast, you'll end up with osmotic demyelination syndrome. So you have to be careful. So we have to differentiate whether it's acute or chronic. More than 48 hours duration is chronic. Unless you should assume it's often chronic if you don't have clear evidence that it's acute. There is a danger of rapid correction. Don't correct the sodium levels too fast. It can cause central pontine myelinolysis. Suggested rate of correction is not more than 0.5 to 1 milliequivalent or 1 millimole per hour. And in one day, we should try to correct only 8 millimole per hour. Sometimes doctors are very happy that sodium is 109, I brought it to 130 within 4 hours. In this condition, that is very bad. Similarly, when patient comes with malignant hypertension, we give sublingual nifedipine and drop the BP very fast. So that is also bad. So mostly we have to do this very gently and slowly. So acute hyponatremia management, there are different formulae available. So 3% saline is what is used. So 3% saline is 513 milliequivalent per liter. Normal saline is 154 milliequivalent per liter. I'm not going to difficult formulae. I think all of us have moved away from max into biology. So simple calculation is 1 ml of 3% saline if per kg body weight. Suppose for a 70 kg person, if you're giving 70 ml per hour, you would expect a 1 milliequivalent increase in serum sodium, approximately. So if you want to give 4 milliequivalent per liter increase over 4 hours, so for 70 kg person, you would use around 280 ml. So that's how you have to calculate. So another case, 50-year-old, lethargy and anorexia for 15 days, abnormal behavior and vomiting for 5 days, serum sodium is 120, normal renal liver function, normal blood glucose levels. So patient had history of self-medication for 5 years, stopped 1 month ago. On appearance, he was Cushingoid, and 8 AM cortisol was less than 5 microgram per deciliter. So this case is likely secondary adrenal insufficiency with euvolemic or hypovolemic hyponatremia. Managed with IV hydrocortisone, isotonic saline, serum sodium returned to normal in 48 to 72 hours. So if you don't find the history and if you don't find the diagnosis, then you will end up giving water restriction for the patient or fluid restriction. Patient will not improve. So it's important that we make a good diagnosis. Cortisol deficiency can cause hyponatremia in various ways. And that's why it needs to be considered and excluded before you diagnose SAADH. So SAADH, I already told, I showed the criteria. So it's one of the common causes of hyponatremia, CNS conditions, pulmonary conditions, and various drugs, especially antidepressants and antiepileptics like valproate. All of these are associated with SAADH. Treatment is fluid restriction to less than 1 liter per day. Identify the cause. And we have newer drugs called aquaretics. Instead of diuretics, we have aquaretics, where only the pure water is lost through the urine. They are tolvaptan. So aquaretics can be considered in confirmed SAADH once you exclude the other diagnosis, especially when patient is symptomatic, sodium less than 125, and not responding to fluid restriction. So take-home message, how to avoid common mistakes in hyponatremia management. Confirm low serum sodium less than 135. If you are not confident of the lab from which the report is coming, please repeat it before you embark on treatment. Exclude pseudohyponatremia. Acute symptomatic hyponatremia, you need to correct it fast in the initial 2 to 3 hours. But you should also be cautious. Avoid rapid correction. There is risk of osmotic demyelination. So you have to maintain the balance very properly. Make a good diagnosis based on the volume status and history of the patient. Rule out endocrine causes where appropriate. Detailed drug history is required. Water restriction is needed for euvolemic and hypervolemic patient. But all the patients you cannot do water restriction. You have to pick up the hypovolemic patients where you would not do water restriction. In fact, you would give fluids. Thank you.
Sir, we will have the discussion at the end.
So next we invite Dr. Sivanarul Selvan, eminent endocrinologist, for deliberating on hypokalemia evaluation. Dr. Sivanarul Selvan is consultant endocrinologist at Pundra Hospital, Tirunelveli, NS Hospital, Kollam. He has done his DNB endocrine from CMC. Over to you, Dr. Sivanarul Selvan.
Respected chairpersons and colleagues, Dr. Vivekanandan is my teacher and Dr. Venkatesh is my colleague. Happy to share with your dais. So the next 20 minutes we'll discuss about how to approach and how to evaluate hypokalemia. So the outline will be what is the definition of hypokalemia and what is the severity, various severity, and how common is hypokalemia, and what is the importance of hypokalemia, and what are the aims of evaluation, and what are the etiology, and how to evaluate in a given patient. I will not be covering treatment for want of time, so I will stop with the evaluation. But you may be asking what endocrinologist is talking about hypokalemia. Most of the causes is like diuretic use, vomiting, diarrhea. What does endocrinologist have to do about hypokalemia? I'll tell you how most of the causes are related to aldosterone or renin-aldosterone axis. Some could be primary endocrine disease, or even in non-endocrine causes like vomiting, diuretic use, it is the aldosterone causing hypokalemia, even though the cause may be GI cause or diuretic. So most of the causes, it is somewhere related to aldosterone axis. So the hypokalemia is defined as a persistent low potassium less than 3.5. Just now one value of 3.1 or 3.2, don't jump and make a diagnosis. Please repeat it if it is only mild and patient is asymptomatic. So persistent low potassium less than 3.5. And it could be mild to severe. Mild is between 3 to 3.5. Most of the times patients is asymptomatic. Moderate is 2.5 to 3. Patients may have mild symptoms, neuromuscular symptoms. And if it's less than 3.5, patient is at risk for paralysis and cardiac complications. Most of the times in mild patients, you may not treat at all if there is no ongoing loss. Moderate disease, most of the time oral supplement will be enough. And severe disease, you should consider IV replacement. So how common is hypokalemia? Most of these studies previously have noted a prevalence of between 1 to 5%. And this is one of the studies from Swedish population. It has noted a quite high prevalence, up to 14% in OPD population from the national registry, and up to 20% in inpatient setting. And up to 20 to 50% of patients using diuretic develop hypokalemia at some point of time. This numbers is quite slightly high than what we see, but still hypokalemia is quite common. So what is the importance of hypokalemia? For that you should know what is the role of potassium in the body. So potassium is quite opposite to the previous one, so it is sodium. Sodium is the main extracellular cation, whereas potassium is the main intracellular cation. The total body potassium is around 50 milliequivalents per kg. That will be around 3,500 milliequivalents per in a 70 kg male, of which most of the potassium is intracellular. 98% is intracellular, whereas only 2% is extracellular. Totally opposite to the sodium. And this gradient is very important for all cellular fractions. The potassium intracellular versus extracellular gradient is important to maintain the resting membrane potential. That helps in maintaining the cellular excitability. That is why this change in potassium can alter this RMP, and it can become the cell to less responsive to stimulation. So hypokalemia can cause hyperpolarization. So cell will become more and more less responsive, and earlier effects are seen in excitable tissues like cardiac and neuromuscular. However, all cells will be affected. Just food for thought. In community, we say discrimination and inequality as bad things, but at intracellular level, discrimination and inequality is the basis of life. Potassium has to be specifically segregated or discriminated intracellularly, whereas sodium has to be specifically discriminated extracellularly. If sodium and potassium ask for equality, they want to be equal between inside and outside the cell, there will be no life. So discrimination is the basis of life at the cellular level. And also negativity we talk as a bad thing, but at the cellular level, negativity is the basis of life. The resting membrane potential has to be maintained at a negative level. The RMP is usually between -50 to -70. If there is no negativity, there is no life. So just why potassium is important. So this maintaining the RMP is so important by the sodium potassium ATPase, so much so that 30% of all the ATP generated is used for this one sodium potassium channel. It is present in all cells, and about 1/3 of all the energy is consumed in maintaining this function. So much is important for this gradient. And 1 milliequivalent drop in potassium may not look very significant, but 1 milliequivalent drop can alter the intracellular extracellular ratio by up to 25%, thereby causing hyperpolarization and less responsiveness of the cell. That is why hypokalemia is very important and need to be treated. So what are the aims of evaluation? First, you need to confirm the hypokalemia, rule out pseudohypokalemia, assess the severity so that you can decide the mode of treatment, tempo of treatment, find out what is the cause of hypokalemia, and once you start treatment, you should monitor for the side effects. Basically, you need to monitor ECG to rule out any adverse effects. So first, confirm hypokalemia, whether it could be lab artifact or pseudohypokalemia, sometimes called as spurious hypokalemia or seasonal pseudohypokalemia. 3 things mainly can cause pseudohypokalemia. One is the increase in the WBC count. When the counts are high, it can consume the potassium so that there will be a falsely low potassium. And when there is a delay in the sample analysis, when it is stored for a longer time, more and more WBC will consume the potassium in the plasma so that you will have a falsely low potassium. And if there is an increase in the ambient temperature, again it can activate the sodium potassium ATPase and can cause pseudohypokalemia. This one study has shown that the temperature and potassium are inversely related. During the summer time, there is an increased incidence of hypokalemia. It is not a disease per se, it is just a pseudohypokalemia. More is the temperature, more is the stimulation of the sodium potassium ATPase. And if you store the sample for more time, there may be a falsely low potassium. And this may be important, and there are some places in UK where they will lower the cutoff of potassium, normal potassium, because of the higher ambient temperature. Maybe this is, we have to study in our population also, because ambient temperature is most of the time higher than in the Western countries. Maybe we should consider lowering the potassium depending on the temperature. So once you confirm, assess the severity so that you can decide whether to treat, what route to treat and how fast to treat. The main tissues affected will be the neuromuscular and cardiac tissues. In neuromuscular, initially the patient can complain of leg cramps, fatigue. Later on they can go on to develop muscle weakness, flaccid paralysis. And smooth muscles in this GI system can also get affected, constipation, paralytic ileus. And patient can also rarely develop respiratory muscle failure. And cardiac problems both in the conductive and cardiac muscle can be affected. Most of the time there will be ECG changes in severe hypokalemia, starting from UVA changes, TA flattening, etc. And patient can develop arrhythmias, both atrial and ventricular arrhythmias. And there are other manifestations also, like patient can develop diabetes, nephrogenic diabetes insipidus. Severe hypokalemia can cause rhabdomyolysis, and it can impair insulin secretion, and it can also precipitate hepatic encephalopathy in a liver disease patient. These are all at-risk patients for arrhythmias who have hypokalemia, older patient with the coexisting heart disease, patient on digoxin therapy or at risk for digoxin toxicity. If you are giving anesthesia, patient can develop arrhythmias if you don't correct hypokalemia. And coexisting hypomagnesemia can aggravate cardiac complications. It can cause torsades pontis. So all these groups, you should carefully treat hypokalemia because they are at risk for cardiac arrhythmias. So what are the causes of hypokalemia? For that, you should know how potassium is regulated. So there is external balance based on the input and output. There is internal balance based on the intracellular shift, and then there is renal balance. So this is the potassium homeostasis. This is the external balance based on how much you intake and how much that is excreted. On an average, the intake will be 100. It may vary between 40 to 150 milliequivalents. 90% is excreted in the kidney and 10% is excreted from the feces. That is the external balance. Most of the time, the requirement is around only 40 milliequivalents. Most of the time, we take up more than what is required. 40 milliequivalents is sufficient for any given patient. So we most of the time consume more than what is required. So this is the internal balance. That is a shift between the intracellular and extracellular space. 98% is in the ISF and 2% is in ECF. And three things can stimulate the shift from extracellular to intracellular space. That is, one is insulin. It can stimulate intracellular shift. Beta-2 agonist can again stimulate intracellular shift, and alkalosis. All these things can stimulate a shift from ECF to ICF. So why insulin is acting like that? Because most of the time we consume more than what is required in the diet. So when you consume lot of potassium, body has developed mechanism to prevent hyperkalemia when you consume more potassium from the diet. So when you consume diet, insulin gets secreted to control the hyperglycemia. So also it stimulates potassium shift to the intracellular space so as to protect from developing hyperkalemia due to diet. And lastly, there is renal balance. That is a final important mechanism whereby it maintains the total body potassium. So the renal balance is the ultimate important thing to maintain the total potassium balance. And the main site of regulation is distal nephron. And renal balance is not by absorption, actually it is by excretion. What I mean is that most of the potassium is absorbed in the proximal tubule and the loop of Henle, but ultimately kidney regulates the body potassium by secretion. If there is a lot of potassium in the body, distal nephron will secrete more so that it prevents hyperkalemia. If there is hypokalemia, distal nephron will decrease the secretion. So ultimately the regulation is by secretion from the distal nephron. That is the DCTN collecting duct. And the main cell is the principal cell in the collecting duct. And the main hormone is the aldosterone. So the body is more tuned to protect us from hyperkalemia because we consume more than what is required. That is why the preservation is less perfect. It is more tuned for excretion. So there will be some amount of obligate loss in the kidney, and if the patient is not taking orally, by 2 to 3 days he will develop hypokalemia. So causes, these are the causes, either it is a decreased intake, increased GI or renal loss, or intracellular shift. Decreased intake, as I said, it is available in most of the foods, and we most of the time consume more than what is required. So it is an uncommon cause if the patient is taking orally. But rarely it can occur, especially in alcoholic patients, patients with severe eating disorders, or post-op patients who are kept in nil orally, or TPN patients. Increased GI loss, it can be due to either chronic diarrhea, laxative abuse, vomiting, or some gastric fistulas, etc. Increased renal loss is one of the most common causes, and the main mechanisms which increase the renal loss is one is aldosterone. It can stimulate the renal secretion, and the potassium in the diet or potassium in the blood. If there is hyperkalemia, there will be more renal loss. And distal sodium delivery. So if there is a lot of sodium reaching the distal nephron, there will be more potassium excretion. That is one of the mechanisms by diuretic. The diuretic causes hyperkalemia because there is more distal sodium delivery, and because the distal nephron tries to absorb more sodium, there will be collateral damage, more potassium will be excreted, and increased urinary flow rate like in uncontrolled diabetes can also cause hyperkalemia. So these are various renal causes. Aldosterone, some of various causes, we will come to that in the next slide. Diuretic use, acute hyperglycemic uncontrolled diabetes, or primary renal tubulopathy like Barter's Gentleman renal tubular acidosis, and hypomagnesemia, again a very important cause. Any patient who is not able to correct, you should definitely check hypomagnesemia, because hypomagnesemia can increase the renal potassium excretion. So aldosteronism can be of various forms. It could be either primary autonomous aldosterone production, that is primary aldosteronism, or other derivated hormones can act in the mineralocorticoid receptor, like Cushing's disease. Some forms of CAH can cause hypertension with hypokalemia, or it could be secondary hyperaldosteronism like renal artery stenosis, Bartus, etc. Or little syndrome, it has aldosterone-like picture, aldosteronism-like picture, but that it's actually activating mutation of the sodium channel in the distal tubule. Or other forms like glucocorticoid remedial aldosteronism, apparent mineralocorticoid excess, etc. So there's a lot of endocrine causes which can cause hypokalemia. And only word of caution, even though primary aldosteronism can cause hypokalemia, most common presentation is normokalemia. Only up to 1/3 of the patients may have hypokalemia. So just because the hypertensive patient does not have hypokalemia, don't disregard the diagnosis. Still it could be primary aldosteronism. And thirdly, the third cause is the intracellular shift. Three things, that is insulin, beta-2 agonist, and alkalosis can cause intracellular shift. And this can be seen in conditions like thyrotoxic periodic paralysis and familial or sporadic hypokalemic periodic paralysis. It is an intracellular shift. So how to evaluate? You need not extensive evaluate in all patients. When the diagnosis is obvious like diuretic use or vomiting, there is no need for extensive evaluation. When the cause is not clinically apparent, or when the clinical picture is suggestive of underlying cause like renal tubular acidosis, you should evaluate further. Or if it is refractory or recurrent, you should definitely evaluate completely. What are the tests you should do? Main evaluation will rest on the urinary potassium excretion. We will come to that in the next slide. Another highlights whether it is an isolated hypokalemia or there are associated other electrolyte abnormalities. You should check sodium chloride, bicarbonate, calcium phosphate, etc. Always check magnesium, because hypomagnesemia can cause refractory hypokalemia, and unless you correct magnesium, it will be very difficult to correct the hypokalemia. And check the ABG to rule out whether there is acidosis or alkalosis. If ABG is not available, at least check a serum bicarbonate. And don't forget to check thyroid function. That is one of the acquired causes for periodic paralysis. And other urinary tests may or may not be done, like urine sodium chloride and osmolality. So urine potassium excretion is one of the important tests to classify the hypokalemia. Various types, 24-hour urine excretion, spot urine potassium excretion, etc. can be done. 24 urine excretion, if it is less than 20, that will indicate a non-renal cause. If it is more than 20 or more than 30, that will indicate a renal loss. Similarly, if a spot sample, if it is less than 20 milliequivalents per liter, that will be a non-renal loss. Or if it is more than, it is high, it suggests a renal loss. Similarly, you can check spot urine potassium create ratio. Transtubular potassium gradient was suggested as a better investigation initially, but I think it has got a lot of limitations and it may not be necessary. So based on the evaluation, you can construct an etiological tree. You need three things. What is the urine potassium excretion, low or high? Whether the patient is hypertensive or not normotensive, whether the patient has acidosis or alkalosis. Based on that, you can do further test. So this will be the etiological tree. First, you check the urine potassium. If it is low, that means it is either a GI loss or an intracellular shift. For the GI loss, it could be diarrhea or laxative abuse or villus adenoma, or it could be intracellular shift like HPP or thyrotoxicosis or insulin usage, etc. The urine potassium is high, then you look at the blood pressure. If it is low or normal, it could be either of the two things like loop diuretic abuse or Bartter syndrome, magnesium deficiency, or some drugs like penicillin group or vomiting. You can further classify based on the urine chloride, but if it is low, that will be the important thing. So we can further classify based on the ABG status, whether the patient has acidosis or alkalosis. If it is acidosis, it is RTA. If it is alkalosis, it could be diuretics, Bartter, Stitelman, etc. And if the blood pressure is high, this is where most of the endocrine conditions comes. If it is increased urinary potassium, and if the patient has high BP, then there could be multiple endocrine causes. Either it could be a primary aldosteronism or secondary aldosteronism, or it could be aldosterone-like defect like Cushing's, etc. In this situation, you should check renin or aldosterone to further classify. So this will be most of the endocrine conditions comes in this session. So I asked what does the endocrinologist has to do with hypokalemia? As you can see, most of the causes is somewhere related to aldosterone. Some could be obvious cause like primary aldosteronism. Some could be still related, even though vomiting may be the cause, still it is the aldosterone causing potassium excretion. In diuretic also, it is the aldosterone causing potassium excretion. So some way aldosterone is related to hypokalemia. So hypokalemia, even though we may not like it, hypokalemia likes us, so we cannot avoid. So what to do and when to seek referral? So look for obvious clinical causes. If it is obvious, just replace and no need to do extensive evaluation. And look at the drug chart because diuretic is one of the common causes. And don't jump and label everything as HPP. Complete workup if it is persisting. Seek endocrine referral, especially if the etiology is not clear and specifically if it is associated with hypertension, because that is where the endocrine conditions come in. So thank you. We'll stop with this.
Thank you very much. We'll go to the last topic of this session. Hari Kumar, the consultant endocrinologist from Hyderabad. Approach to a case of tetany.
Good afternoon, everybody. Thanks to Dr. Sridhar, team Trendo for inviting me. When compared with the previous two talks, the sodium and potassium, calcium is relatively better electrolyte to manage. Doesn't give much confusion, has not many causes which disturbs it, and limited options, limited symptoms, easiest to treat and evaluate. Okay. So I shall not take 20 minutes. I shall possibly finish in maybe 15 minutes so that we can have better interaction. I shall cover the topic under the following headings: hypocalcemia, hypopara, some issues, management, and some special situations. The cartoon will depict most of the things what I am going to speak in the next 15 minutes. Approach to tetany is what has been told. Tetany is basically means it's a spontaneous involuntary muscular contraction. Why it happens is something different, commonly due to low calcium. So tetany as a symptom just indicates likelihood of low calcium. There can be low magnesium or other things also as well. The another important thing about tetany is there are two components of the same symptom. It is sensory as well as motor. The sensory symptoms are the ones which are like the perioral paresthesias, some tingling happening, or premonition, the patient is likely to get a spasm. So the spasm, cramps, all those things are the motor symptoms of tetany, whereas the paresthesias are the sensory symptoms. Some of the patients may just have symptoms sometimes and not completely evident, which is known as a latent tetany, where you have to do some stimulatory tests, clinical stimulatory tests, to find out whether they have the tetany or not. Those are the Chostek's and Trojer's sign. The another important thing to understand, commonly the Chostek's is the one where you tap on the facial nerve and then the twitching happens. 25% of normal public has it. 25% is a huge number for any sign to be positive in a disease. So that is not much of use. So Trojer's is the one which most of us follow in the clinical practice. You inflate the cuff for about above systolic 20 mm Hg, keep it for 3 minutes. There is a classical carpopedal spasm. So that is important to know. And whenever you have tetany, just remember the cramp as an acronym. What are the causes for it? The hypocalcemia being the first one. The clinical situation where you find is second is respiratory alkalosis because of hyperventilation. Third thing, metabolic acidosis, As a compensation, you may have respiratory alkalosis and get the same symptom, hypomagnesemia and porphyria. So these are the common symptoms, diseases which you should evaluate when somebody has got tetany. Now, calcium homeostasis, why it is important to understand. There are three key hormones which are relevant here. First and foremost being the parathyroid hormone. Whenever your calcium is low, it is sensed at the calcium sensing receptor and the PTH is released more, and it goes to the bone and breaks more bone and releases more calcium into the circulation. Now at the same time, it also goes to kidney and activates the vitamin D, and it also prevents the calcium loss, other mechanisms to bring up the calcium. When calcium is high, the calcitonin is the one which takes note of it and then suppresses the PTH. Third player is the vitamin D, which is also a hormone, which activated vitamin D actually helps in increasing the intestinal absorption of the calcium. So those are the three key players whenever you are looking at the calcium metabolism. Definition of hypocalcemia, less than 8.5 milligrams per deciliter. Ionized is 50% of the one, and it is bound form what we are measuring. Conventionally now, by and large, most of the labs are checking ionized calcium. There are some issues about the calcium measurement. You have to look at the albumin also. There is something known as a corrected calcium to correct for the serum protein. But to circumvent all this, most of the labs now do the ionized calcium also. The etiology of hypocalcemia, very busy slide, not need to know anything much in this. Only thing, on your left, there are plenty of genetic reasons, causes which cause hypopara. And the post-surgical hypopara is the commonest cause of the hypocalcemia, hypomagnesemia also. And you have non-PTH mediated. On to your right side are some of the commonest causes, that is the vitamin D deficiency and malabsorption. Nothing much to know. The epidemiology of hypopara is actually not documented in India. This was our study which we published few years back in Clinical Endo. It is reasonably rare, 2.6 per 1 lakh patient year follow-up. Now what are the clinical features of hypocalcemia? If you can see, the acute ones are what we have already discussed about the muscular, the cramps, spasms, all those things. And you have other systemic involvement. These are more applicable in a chronic hypocalcemia segment. Maybe you can have some of these cataracts, basal ganglia calcification, prolonged QT interval is seen in more acute setting. So you can have a various acute as well as chronic manifestations in presence of hypocalcemia. The spontaneous contractions are the ones which are actually the problem to the patient. The laryngeal spasms, stridor, severe colicky pain abdomens, those are some of the life-threatening situations. These clinical clues are more relevant in a syndromic hypoparathyroidisms, the commonest being the Digeorge syndrome, which is you can remember it by the catch-22 acronym. And for the pseudo-hypopara, you have what is known as the Albright's hereditary phenotype, round face, some flattish about the nasal bridge, brachydactyly, all those things. But these are very rare, not need to know much about them. We will go to the investigations, which are first and foremost, obviously the serum calcium, which is corrected to the albumin which is prevalent. If not, do the ionized calcium. Whenever you are looking at calcium, you should look at magnesium also associated, and the other electrolytes. Creatinine is an important one, alkaline phosphatase, vitamin D and PTH. These are the battery of tests which will tell you what the patient has got, what disease. I'll show you in the approach. And some other investigations as a follow-up depending on what the patient is likely to have, or maybe if you have found some family members or some other issues, maybe that is the time you look for extended screening. Here I'll spend about few minutes. This is the basic approach to hypocalcemia. Whenever somebody comes with hypocalcemia, first you confirm actually it is a hypocalcemia. look at the setting. Is it acute or chronic? Because you cannot keep on evaluating without management. These are some of the situations where your evaluation should run parallel to your treatment also. And the first and foremost is you look at GFR, the parathyroid hormone, and the phosphate and magnesium. If you have low GFR, that is, there is evidence of CKD, there is definitely a hypocalcemia, and because of a chronic kidney disease, so that is a different subset altogether. So GFR will give you that clue. If suppose you have normal GFR, then you look at the PTH, whether you have a high PTH or low or normal PTH. And here you have a patient may have high phosphate, low calcium, and the low or normal, inappropriately normal PTH. This is the classical of hypoparathyroidism, which is what I am going to talk about in the management. And if somebody may have high PTH, we'll go to that. That is typical biochemical spectrum of hypopara, but your PTH is normal or high. That is basic, simple pseudo hypoparathyroidism. Other reasons for it. Suppose patient may have low or normal phosphate, then you check the alkaline phosphatase and vitamin D, and here you have the common garden variety of osteomalacia, where you have a high alkaline phosphatase and low vitamin D, or vitamin D deficiency, or BDDR type 1 and 2, which will have high alkaline phosphatase and normal vitamin D dependent rickets. So this is basic approach whenever you are looking at hypocalcemia. What I have highlighted in the yellows are the ones which are the common conditions: CKD, hypopara, vitamin D deficiency, pseudohypopara, and osteomalacia. These are the common things what we see in the clinical practice. Management is very simple. If it is acute hypocalcemia, there is no other way other than replacing it intravenously. The conventionally, most of the places, calcium gluconate is the one which is available. Each ampule is 10 ml and it is 10%, so it gives you about 90 milligrams, to be specifically 93 milligrams, and you have to give 2 ampules of it dissolved in 5% dextrose over a period of 15 to 20 minutes. Don't push, because that will cause a lot of problem. You have to give it slowly over a period of 15 to 20 minutes, preferably under a cardiac monitoring. As parallelly, when you are giving a acute management, you have to give a long-term infusion of the next 8 to 12 hours. Maybe you can infuse about 5 to 6 ampules again over a period of next 10 to 12 hours. That is the management of acute hypocalcemia. In some patients, especially if there is a magnesium deficiency suspected because of the clinical reasons, you can give magnesium 2 grams as a bolus and infusion of 16 grams over next 24 hours. The only difference what you need to know is acute magnesium replacement will not correct the clinical symptoms so fast as what the calcium would correct. Chronic infusion we have already talked about. The chronic management is where actually the hypopara maximum people have problems, and adequate dietary supplements, and you should always ensure that patient doesn't take much of phosphate containing things in the diet, because this phosphorus binds to calcium and prevents the absorption. Commonly we use calcium carbonate for the sake of more availability of elemental calcium, 40%, than when compared with citrate. But only thing being, calcium carbonate requires a acidic medium, so you have to take it along with the meal, whereas citrate you don't require a acidic medium, it can get absorbed either way. It is to be given 1 to 3 grams in 3 to 4 doses. Vitamin D you require calcitriol 0.25 to 2 micrograms per day, and whenever you are using high calcium dose, there is risk of hypercalciuria and kidney stone formation. So to prevent that, you give thiazides. Some phosphate binders also may be given along with the diet to prevent the loss of calcium, and you require regular monitoring of all the calcium, phosphorus at least 3 to 6 monthly to prevent any complications. What are the complications of therapy? As I said, hypercalciuria, and the only way to address is giving hydrochlorothiazide. Nephrolithiasis and the CKD and progression of soft tissue calcifications. The basic rule is to reduce calcium, but the moment you reduce calcium, the patient will start having symptoms of paresthesia coming up, or some working people will find holding things, all those complaints will start coming. So there comes the management of PTH. The only hormonal diagnosis where we know the deficiency of the hormone but still don't use the hormone so commonly is hypopara. For any other hormonal deficiency, we use hormone as a replacement and that solves the problem. PTH, unfortunately, is not so much practiced, but these are the indications why you should use PTH, especially if somebody has got unresponsive, less improvement with the use of calcium and vitamin D, propensity to develop nephrolithiasis or history of nephrocalcinosis, calcium phosphate product more than 55, or requirement of high dose calcium, all these patients, you should be using PTH in the clinical practice. Erstwhile, the teriparatide, which is the 1:34 amino acid, was the only thing available for the management in the hypopara. Now you have the full length PTH molecule of 1:84 amino acids, but full length is quite exorbitant cost, which is, I'm not sure it is available in India, but abroad it is just launched few years back. Because of the issues concerning PTH in the management of hypocalcemia, you had to use it twice daily. It's a short half-life, but the benefits are it will reduce the dose of calcium, it will improve the symptomatic management, symptoms on the patient. Some of the clinical pitfalls, especially whenever you are looking at managing hypocalcemia, is corrected calcium, as what has been described by the previous speakers. The electrolytes, unless the lab supports you or lab is in sync with the patient, please don't jump on to treating. You recheck and recheck, both have to match, then only you should start management. Hyperventilation, earlier days we used to advocate rebreathing masks, that metabolic respiratory alkalosis as the commonest cause of tetany in the clinical practice, especially young females or young people who come with the carpopedal spasms. The rebreathing masks are not much used nowadays. It is just reassuring, and maybe a dose of benzodiazepines would help. Ionized calcium, whenever you are estimating in the sample, it should be estimated within 2 hours of drawing the sample, and in these 2 hours also the sample has to be maintained in a cold chain. So that is important to know. Another important, unlike acute hypocalcemia, chronic hypocalcemia may not be much symptomatic. Patients may have actually 7 to 8 milligrams per deciliter of calcium and they may not have much symptoms. So a chronic, the body adjusts, the hyperexcitability of the nerves is not much, so be very clear about it. ICU, neonate, I'll speak later. Infusion of calcium, preferably central line in 5% dextrose and no phosphate for the risk of bindings. 3 different settings. Post-surgical, as I said, is the commonest one, that is post-thyroidectomy hypocalcemia. Permanent hypopara is seen in only about 2 to 3%. These are the risk factors why patients develop. Pre-existing vitamin D deficiency, large goiter, females, and any bleeding in that during operation which would affect the blood supply of the parathyroid, or a drop of 1 milligrams within 12 hours after surgery also is a risk factor. Drug induced, you have plenty of drugs which can commonly lead to a hypocalcemia. One is a pseudo hypocalcemia because of gadolinium, and commonly used drugs which are like bisphosphonates, anti-epileptic drugs, all these things you should be worried or you should be vigilant about replacing calcium. Neonatal hypocalcemia is also another different spectrum. Causes remain almost the same, except that the genetic causes come higher up here. Definition varies from term babies to preterm babies. The replacement is almost the same. It's a weight-based replacement. Again, you need to rule out the hypomagnesemia, hypopara, and one relevant related condition is a maternal untreated hyperparathyroidism can be picked up by a neonatal hypocalcemia. Actually, your calcium is set point, more transferred, and the baby, the moment he is delivered, there is a hypocalcemia. So there are few case reports where because of the neonatal hypocalcemia, the maternal hyperpara is picked up at a later date. We are in the era of COVID, so my penultimate slide about COVID and hypocalcemia, because nowadays you can't get out without speaking COVID. So there is some osteometabolic phenotype of COVID-19 also has been described. More hypocalcemia as a marker of severity independent of other reasons which the patients have been admitted for. Maybe because of widespread vitamin D deficiency, and I'm sure most of you would agree that people have taken excess dosages of vitamin D during the COVID era, but the relation being hypocalcemia aggravates the coagulopathy. So there are some reasons why it increased the mortality in the COVID era also. So to conclude, hypocalcemia is an emergency in clinical practice. Both assessment and management have to go parallelly. Don't wait for the final diagnosis to come. Both acquired and genetic etiologies have to be identified, and beware of the clinical pitfalls in the management. And objectives are very simple: elevate calcium without having any complications which are likely to be due to hypercalciuria. Calcium, vitamin D, hydrochlorothiazide and PTH remain the mainstay of management. Close monitoring and dynamic management helps in improving the quality of life of these patients. I have finished here. Any questions or comments?
Now the session is open for discussion.
Sir, as it has been commonly discussed, how common you come across the osmotic demyelination syndrome, sir?
I haven't, I've seen a couple of cases during my training in PGH Chandigarh. After that I have not come across, because mostly I'm doing outpatient practice, I'm not dealing with inpatients, so I'm not handling acute hyponatremia patients.
Yeah, rarely we see, but sometimes the symptoms is a delayed onset, maybe 2 to 3 weeks. So if the patient doesn't come for follow-up, we may miss it. Or sometimes the patient expires before it develops. It's rare only.
Can you provide us some more details about hyponatremia in adrenal insufficiency and hypothyroidism?
I showed there are various mechanisms how the adrenal and thyroid control the sodium metabolism. So adrenal insufficiency, there are various mechanisms. One is it can act on through the aldosterone mechanism. Aldosterone, we know that it retains the sodium and sends out the potassium. So in adrenal insufficiency, you get hyponatremia with hyperkalemia. So once you get hyponatremia with hyperkalemia, that can point towards adrenal insufficiency. Another thing is both cortisol and thyroid hormone are required for free water clearance. For the ADH, antidiuretic hormone or vasopressin to work, you need a supportive role of cortisol and thyroxine. So without this, water will not get excreted well. That's why if you see hypothyroid patients, they have fluid retention. So these two are required for free water clearance. So in both the ways, they retain more water in the blood, and once water is there, sodium gets diluted.
What about prevalence of hyponatremia in secondary adrenal insufficiency?
In secondary adrenal insufficiency also we get, madam, but what you are telling is the aldosterone pathway is spared in secondary adrenal insufficiency. So in that case also, there is some overlap between the glucocorticoid and mineralocorticoid action. So there also we get hyponatremia with hyperkalemia.
So we have seen many commonalities in this discussion. So hyponatremia, hypokalemia, hypocalcemia, all these three things, we have to first rule out whether it is pseudo or true. That is very, very important. So we have to repeat the test, or we have to check the background of the patient. to confirm ourselves whether we are treating with a true setup. That is the next thing. And next thing, that is all the three electrolytes have the commonality of acute and chronic presentation. So we have to be sure whether it is an acute or a chronic setup we are treating. And other important commonality is the treatment parameter. So when you are treating also, we should not over-treat and we should not under-treat. That is common to all these electrolytes. That is very important. And as all the speakers have very clearly made up, the summary, we take home the message of this, the electrolyte session is, first we have to recheck whether the lab values are correct. So pray God, the results come again as normal. So that is the first thing as clinicians we normally expect. And next thing after that, they told that we have to assess the osmolality. So we break our head, what is osmolality, and then we come to a conclusion, okay. Then after that, when we have to assess the volume status of the patient. So volume status, again, we have to find out whether it is hypervolemic, euvolemic, or hypovolemic. So that also is a clinician's nightmare. After that, we have to come to the urinary sodium excretion. So we have to prove ourselves that we are an astute clinician by ordering a urinary sodium excretion to a lab, that too in front of attenders. And we have to prove ourselves that we are astute clinicians. And finally, we come to the conclusion, as usual, sir has told, the commonest cause is SAADH. So we come to a conclusion, okay, they remove the cause for the SAADH so that the hyponatremia will get it corrected. Or if we are not coming to any conclusion, finally we call our nephrologist friend, and he, as usual, mocks us, and you end with nothing to do with this patient, conservative management. So that is how we finally, clinicians as physicians, we end our electrolyte management. But now we have come to a very good deliberation of hyponatremia, hypokalemia, and hypocalcemia management by our expert clinicians. Thank you, sir.
Thank you, chairpersons for.
Sir, one question, sir.
The last question. There is a tremendous use of SGLT2 inhibitors nowadays by various specialties. What is the electrolyte problems you come across, or is they to be highlighted, or electrolyte problems with the SGLT2 inhibitor therapies?
SGLT2 inhibitors, the electrolyte problem, only thing is the hyponatremia was there initially considered. Only thing, if somebody is using diuretics parallelly prior to starting, you may need to consider reducing the dose of diuretics. Routine monitoring of electrolytes is not advised. Only thing is you need to be cautious, vigilant, and maybe reduce the other drugs dosages if required. Especially in elderly, we routinely use.
Thank you, sir.
Commonly we use the thiazides along with the hypertension drugs in the management, sir. So in that patient, is there any role for be cautious with the SGLT2 inhibitors, sir?
The thiazides you mean?
Yes, sir. Yes, sir.
Yeah.
Thiazide SGLT interaction.
See, that's what I said. It is, one, we are more worried about the hypotension. Loop diuretics routinely not many patients use as a routine management as an antihypertensive agent. So the risk of hyponatremia is not a significant problem. Only thing is the risk of hypotension is a problem, and postural hypotension to be precise. So that is where you need to reduce the dose slightly of the diuretic whenever you are starting the SGLT2 inhibitor. Yes. That is important.
Thank you, sir.
Thank you, sir. Thank you for the great discussion as well. I would like to honor the speakers. First, Dr. Vivekanand sir can give the memento to Dr. Sivan Arulselvan sir. Vivekanand sir, please. I would like to call Venkatesh sir to honor Dr. KVS Harikumar sir. Vivekanand sir can give memento to Dr. Vijay Bhaskar sir. We would like to invite Dr. Gopinath sir to honor our chairpersons. to Vivekanand sir and to Venkatesh sir. Thank you, sir. Thank you for the wonderful session. And we are breaking for tea now. We will assemble at 4:35 p.m. exactly to start the last symposia. Good evening, one and all. Welcome you for the post-tea session of the day. This is the last symposium, and to start with, I would like to invite Professor Sridhar sir from Chennai and Dr. Syed Sultan sir from Madurai for chairing the session. So I would like to invite the chairperson to start the proceedings for the next 3 sessions.
Name is wrong. Good evening to all. Thank the organizers for this excellent organization and kind invitation. So, regarding inpatient hyperglycemia management, the whole thing is slowly undergoing a change. About 20 years back, there was the famous surgical study of Vandenberg, where they indicated that very tight control of sugar, keeping the glucose around below 110, is very advantageous for quick healing and improves mortality and morbidity. So there was a lot of interest. But the same Vandenberg group, they conducted a study in the medical ICU and did not replicate their own epoch-making findings few years later. So subsequently, we are enthusiastic about control of sugar, but nevertheless not at levels like 160 to 180 milligrams would be sufficient. So, tell us more about inpatient management is none other than Dr. S. Ramkumar, MBBS, MD, DM, All India Institute, and DNB Endocrinology. He is Clinical Fellowship in Diabetes in New Zealand and Fellow of European Society of Sexual Medicine. He is Assistant Professor of Endocrinology at Madras Medical College and also attached to Apollo Main Hospitals and Dr. Ram's Clinic. And he is awarded the A.V. Gandhi Award for Excellence in Endocrinology in 2014 and ISPAD Alan Drash Clinical Fellowship in 2014. He has numerous publications, and without further ado, it's over to Dr. Ramkumar.
Good afternoon, sir. So I sincerely thank Dr. Kumarvel sir for giving this opportunity to talk on Trendo. Actually, this is my first talk on Trendo in a physical form. This topic, management of hyperglycemia in a hospitalized adult, this was decided a month back. Fortunately, 2 weeks back, this was the publication from our endocrine society. This is the management of hyperglycemia in hospitalized adult in a non-critical care setting. So I just share what the society wants us to know in the next 15 minutes. This is actually an update on the 2012 guideline. So to me, this guideline looks like more or less a generalized statement, unlike other protocols where they are giving exactly how much to give, how much units per kg to give, or at what level should we intervene, how much to step up. This is more or less a generalized statement. The reason is obvious, because every patient has to be individualized. Unlike a DKA where there is a fixed protocol, here there are a lot of factors which could interfere. So whenever a patient gets admitted in the hospital, there are many reasons why the sugar can go high, from stress response, the administration of any steroids, octreotide, or any continuous enteral nutrition or a parenteral nutrition, and also a decreased level of activity. All these can contribute to high blood sugar, which can subsequently predispose to a lot of changes at the cellular level, oxidant damage, which can predispose to infections, and increase the morbidity as well as the mortality. As I was telling, in the early 2000, the major landmark trial published actually showed that if you control the blood sugar in an intensive way, maintaining between 80 to 110, it actually improves the outcome. Subsequent study also showed an intensive glycemic control improves actually the outcome. Subsequent studies that nice sugar have changed the way the patients with diabetes are managed at hospital. So if you actually look at the way you want to treat a patient, see whether the patient is critically ill, whether the patient is admitted in the intensive care unit or is just admitted in a routine ward for maybe for an infection, maybe for a surgery, etc. So these are the two important landmark trials. One is the NICE sugar and the glucocarb. These two trials have shown that if you try to control the sugar intensively, the mortality is actually much more. The first study published in NEJM in 2009 showed that the intensive glucose control increased the mortality. A blood glucose target of less than 180 resulted in a lower mortality than did a target of 80 to 108. The second study, the gluco-CABG, intensive insulin therapy to target sugar between 100 and 140 in the ICU did not significantly reduce the perioperative complications compared with a target glucose of 140 to 180. So these were the target glucose concentrations in the critically ill and non-critically ill. After the NICE sugar guidelines, the ADA and AAC has published a consensus statement that the sugars should be maintained between 140 to 180 for majority of critically ill patients. If you could avoid hypoglycemia for selected patients, a target of 110 to 140 is acceptable. The Society of Critical Care Medicine recommends a value between 150 to 180, and for non-critically ill, the initial recommendation by both ADA and AAC was a pre-meal of 140 and a random of 180. The latest, the ADA 2022 guidelines recommend whether the patient is critically ill or not critically ill, a value between 140 to 180. And this is by the Joint British Diabetic Society, a recommendation of 108 to 180. So if you actually look at the protocols that are available in the literature, most of these protocols on continuous insulin infusion are all in the early 2000s. So most of these protocols are trying to control the sugar much stricter. This is one protocol which is published in 2005, the AL insulin infusion protocol. The aim is to control the blood sugar somewhere between 80 to 110. This is another protocol which was published in the endocrine clinics. So if you actually look at the protocol, between 110 to 180, they are not recommending any change. So they are trying to maintain the blood sugar somewhere between 110 to 180. If you look at both these protocols, actually what they look at is two factors. One is absolute sugar level and the rate of change in blood sugar over the last 1 hour. Here they have taken a blood sugar, the decline of 30 milligrams or an increase of 30 milligrams is taken to make a decision in the insulin adjustments. So for these type of adjustments, the staff nurse who is looking after the patient has to be very vigilant and to adjust the blood sugar. So this is possible only in the 1:1 nursing care setup. This is the another protocol, that is variable rate intravenous insulin infusion. Here the absolute value is taken into consideration, but not the rate of change. So if the sugar goes to another level, say for example from 210 to 180, then the rate of infusion changes from 2 to 1. So here we have a reduced rate, standard rate and increased rate. This is a publication by the Diabetes UK and also the position statement of the Joint Diabetes British Society. I think this is the only thing which I could find. There are other variable rate intravenous insulin infusion. This is by standard consensus statement. Here they have 3 scales. Suppose if you find when decreasing the insulin infusion, the sugar starts going high, then you can go to the higher scale. Or you can even give a customized scale to handwritten to the staff nurse to decide on the insulin rates. This is a protocol which we follow in our critical care unit. So if you actually look at it, you can see the rates are much higher than the previous insulin the variable rate insulin infusion. The rates up to 13 units per hour. And one thing which you can see also here is the CBG monitoring once in 2 hours. Personally, if any of my patients are getting admitted in critical care, I always ask them to monitor it hourly. If you monitor hourly, the chance of hypoglycemia is actually very, very less. So it's always better to monitor the blood sugars hourly. So what ADA says is ADA is not giving any protocol. It just recommends that any validated protocol or a computerized protocol has to be followed. It depends on the hospital. And use of a sliding scale insulin regimen is strongly discouraged. Most of us have already been using a sliding scale regimen. At the maximum, we can use it for a period of 24 hours. Beyond 24 hours, I think you know how the patient reacts and how the patient's diet intake, everything, and we can go to a scheduled insulin regimen. So once the patient has been on intravenous insulin infusion and he is stable, the blood sugars are remaining stable, there is no acidosis, the normal anion gap, the hemodynamic stability is there, he's taking nutrition, meals at regular intervals, and the infusion rates are stable, we can change to a subcutaneous insulin. So these are all about the patients who are critically ill. Now coming to the JCM guidelines on patients who are not critically ill, I'll just go through the recommendation one by one. The first recommendation is on continuous glucose monitoring system. So this guideline recommends the use of continuous glucose monitoring system in patients who are at high risk of hypoglycemia, and provided you have the resources to monitor it. If the patient CGM is not available, or if the resources are not available, or if the patient is not at high risk of hypoglycemia, point of care blood glucose testing is an alternative. So who are all the patients at high risk of hypoglycemia? The elderly, patients with chronic liver disease, heart failure, renal failure, they have a pancreatic problem, they are have an active malignancy, they have a previous hypoglycemia, etc. So these continuous glucose monitoring may not be applicable in situations like extensive skin infections, shock, those who are receiving inotropic support, and certain drugs. So the next recommendation is on insulin pump. So if the same thing here again, if the patient has already on insulin pump and you have a staff nurse who is trained in insulin pump, then it's better to continue with the insulin pump therapy rather than changing to a subcutaneous basal bolus regimen. But if a patient has an impaired level of consciousness, inability to adjust the pump settings, and critical illness, decay, or hyperosmolar state, then they are not the candidates for insulin pump. So the next recommendation is on glucocorticoids. If the patient is on receiving glucocorticoids, recommendation is to give a NPH or a basal bolus regimen. So when we give a short-acting prednisolone in the early morning time, the prednisolone reaches a peak level at 4 to 6 hours. The NPH also peaks at the same time, 4 to 6 hours, and that is the reason it is always better. It's always better to give both NPH and prednisolone concomitantly. That is the latest ADA 2022 guidelines. So if a patient is on long-acting steroids like dexamethasone, or the patient is getting multiple doses of steroids, then we can go for a long-acting insulin basal bolus regimen. So these are the different ways we can manage diabetes in a patient on steroid. If the patient is on multiple doses of insulin, unlike the routine situation where you have a high or an equal 50-50 of basal and bolus, here more of a prandial is required, especially after the lunchtime, and the basal requirement is less. If the patient is not a diabetic and he's become hyperglycemic after initiation of steroids in the morning, a single dose of isofene insulin in the morning. If you are giving isofene insulin 2 times, then you can give 2/3 of isofene in the morning and 1/3 in the night. And this is another interesting way of managing diabetes. If the patient is already on basal bolus regimen and started on a steroid, then adding an NPH to the usual basal bolus regimen. And regarding diabetes education, it's very clear that every patient needs to be given an inpatient diabetes education, but it is obvious that we cannot give the same type of education for hospitalized patients, so many of times the staff nurse may not be having sufficient time. So at least prioritize for those people who are started newly on insulin, who are admitted for the first time with diabetes, they have a type 1 diabetes, and who have a diabetes-related complications. And next recommendation is on preoperative glycemic control. So what should be the target HbA1c and the target blood sugar levels? The recommendation is to have a HbA1c less than 8% and blood sugar between 100 to 180. If you cannot achieve a HbA1c less than 8%, then at least have a preoperative blood sugar between 100 to 180, which should be at least 1 to 4 hours before the surgery. And this is one of the difficult areas in the inpatient management, patient on enteral nutrition. Either a NPH or a basal bolus type of regimen is recommended. So this is one flow chart. If you actually look at it, if there is a facility for continuous intravenous insulin infusion, this is the best. Or if they have a facility for automated closed loop insulin delivery, it is the best. But if these facilities are not available, the patient is in the general ward, then the patient is receiving a parenteral nutrition, then the recommendation is to add insulin in the parenteral fluid itself. Or if the patient is on enteral feeds, then you can follow a basal bolus regimen. A basal, here they actually mentioned NPH thrice a day, detimir twice, and glargine once a day, and supplemental insulin short acting every 4 to 6 hours. If the recommendation is on oral hypoglycemic drugs, so in most patients, we suggest that scheduled insulin therapy to be used instead of non-insulin therapies for glycemic management. So that is in most patients, but what we generally do, most of us would be giving patients on metformin, sulfonylureas and gliptins. But these are all not studied well, but recently there are a lot of studies on DPP-4 inhibitors as well as GLP-1 analogs. DPP-4 inhibitors may be appropriate in selected patients, especially those with non-insulin requiring diabetes nearing hospital discharge, and if the patients are very stable prior to discharge, then as a part of a coordinated transition plan. In selected adult patients who have a mild hyperglycemia, DPP-4 inhibitors can be given with the correction insulin, or we can change to a scheduled insulin therapy. Who are those selected patients? If the HbA1c is very less than 7.5, blood sugars are like less than 180 or 200, and the requirement for insulin is very less, like 0.6 units per kg, then we can recommend DPP-4 inhibitors with a correction insulin. So this was one of the review article on should we give oral hypoglycemic drugs in patients in the in-hospital stay. This was the statement by them that not all patients need to be treated with insulin. In particular, stable patients with good nutritional intake and preserved renal function. Solid evidence indicates that incretin therapy, particularly DPP-4 inhibitors alone or in combination with the basal insulin, is safe. And no prospective studies have determined the efficacy of other, which means metformin and sulfonylureas in the hospital setting. So these are the other non-insulin agents and what are the pros and cons of these agents. Most of the guidelines, you see, even the ADA 2022 do not recommend non-insulin medications because of the two reasons. One is safety and efficacy. Metformin because of lactic acidosis due to anaerobic metabolism in sepsis, hypoxia, impaired metformin clearance or impaired lactic acid clearance. And they are contraindicated in these situations. Sulfonylureas, the main concern is actually sustained hypoglycemia. If you look at the risk of hypoglycemia with sulfonylurea and basal bolus regimen, actually the risk of hypoglycemia is much more in the basal bolus regimen than with sulfonylurea. And thiazolidinediones, fluid retention, delayed onset of action. SGLT2 inhibitors, now even the authors strongly recommend not to use SGLT2 inhibitors, especially in patients who have a variable diet pattern, risk of ketosis, risk of euglycemic DKA and mycotic infections. But nowadays, at the time of discharge, most of these cardiologists are starting the patients on SGLT2 inhibitors at the time of discharge. DPP-4 inhibitors, as I mentioned earlier, there are even the Endocrine Society recommends it because it decreases the insulin injections and it is safe and effective in mild to moderate hypoglycemia, hyperglycemia. GLP-1 receptor agonist, there are a lot of studies on GLP-1 receptor agonist, but the main risk factor is the increased prevalence of GI side effects. The next recommendation is on preoperative fluids. Generally, non-carbohydrate containing NS is recommended, but in one of my recent patients with appendicitis, almost it's kept for nil oral for a long time. So in those conditions, we can add a DNS with a neutralization drip. So on carbohydrate counting, this is rarely we practice carbohydrate counting in an adult type 2 diabetes. We usually follow it in a type 1 in a younger age group. This is not necessary to follow carbohydrate counting in non-insulin treated patients, and if the patients are if the adult patient with type 1 diabetes or insulin treated type 2 diabetes, also the carbohydrate counting is not mandatory, either a carbohydrate counting or no carbohydrate counting with a fixed prandial insulin dosing. Regarding correctional insulin, there is a difference between correctional insulin and a sliding scale. So in adults with no diabetes, no prior history of diabetes, the blood sugars are more than 140, we can recommend a correctional insulin. If the patient has a persistent sugar more than 180, then we can go for a scheduled insulin regimen. In a patient with established diabetes, we suggest therapy with either correctional insulin or scheduled insulin therapy as long as the sugar is below 180. But if the sugar is more than 180, it's always better to go for a scheduled insulin therapy. Scheduled insulin therapy means actually a basal bolus regimen. So if the patient has already been treated with insulin, we continue the same insulin regimen in the hospital and try to maintain the blood sugars between 100 to 180. Pre-mixed insulin regimens are not routinely recommended in hospital use, but most of us widely use that in our practice. Especially, this is safe, especially if the patients have a good dietary plan. For example, someone who is admitted for any infections and their appetite is normal, then this can be considered. But ADA recommends against the use of pre-mixed insulin regimens. So most of the sugar orders we give it through the phone. So having a fixed printout like this and giving to the sister might be very useful. When to check the sugar, which insulin to give, how frequent to give, and how much dose of supplemental insulin, correction insulin to give. As I said earlier, the sliding scale is different from correctional insulin. Suppose, for example, if you give recommended 5 of regular insulin and the blood sugar is like 180 to 200, then 5 plus 2. So 7 units of insulin will be given at the lunchtime or the time. So this is in a short, if the patient is having a high sugar, nothing by oral, basal insulin. If the patient takes orally, a basal bolus regimen. So this is combining both the critical ill and non-critical ill. In severe DKA and hyperosmolar hyperglycemic conditions, we give a fixed dose of insulin, whereas in critically ill patients, we give a variable dose insulin, continuous insulin infusion. And once it is stable, you can change to a basal bolus regimen. If the patient has type 1 diabetes, then we are going to follow the basal bolus regimen. If the patient has a type 2 diabetes and mild hyperglycemia, consider gliptins or a low dose basal insulin. Moderate hyperglycemia, basal insulin with the gliptin plus correction insulin. If the patient has a severe hyperglycemia, basal bolus regimen. Okay, so continuous intravenous insulin infusion remains a choice for hyperglycemic crisis. For non-critically ill patients, insulin is still a choice. Preferably a basal bolus regimen. If mild to moderate hyperglycemia, basal insulin with DPP-4 inhibitors, or mild hyperglycemia, DPP-4 inhibitors, then a bolus, then a correctional insulin can be given. Thank you very much.
Thank you, Doctor, for your excellent presentation. As we all know, diabetics, they have increased the risk of hospitalization, and hyperglycemia that is implicated in the increasing the mortality and morbidity, which needs a protocol-based effective treatment. You discussed all aspects in a very clear way. Thank you. We'll go to the next topic. Steroids, a savior, Satan, or a serpent. Dr. Satish Kumar from Puducherry will give the lecture.
pointer. Good afternoon, ladies and gentlemen. It's my proud privilege to be part of Trendo 2022, and I would like to thank Dr. Kumaravel, Dr. Manikandan, and the Madurai team for having given me this opportunity. I would go about this topic in the following order. First, deal with the overview of this topic, go on to the functions of the glucocorticoids, the route of administration and the formulations involved, the therapeutic uses, the effects of the steroid excess, and go on to summarize the talk. All steroids have a common cyclopentanophyrhydrophenanthrene structure and are produced predominantly by the adrenal cortex as well as gonads. The adrenal cortex predominantly produces steroids, which can be categorized into three categories, namely the glucocorticoids, mineralocorticoids, and the androgen precursors, which also estrogens. Therapeutically, these corticosteroids can be categorized into based upon their mineralocorticoid and their glucocorticoid property. Glucocorticoid property being classically shown by the anti-inflammatory potency, and the mineralocorticoid effect shown by the sodium retaining potency. And hydrocortisone is the classic prototype with standard with an anti-inflammatory potency of 1 and a mineralocorticoid potency of 1, and based upon which prednisolone has anti-inflammatory potency of 4 and mineralocorticoid potency of 0.8. Here we'll have to see that dexamethasone and betamethasone are purely glucocorticoids with no mineralocorticoid activity, and they have a long duration of action. And additionally, we have to remember that the prednisolone, whatever we use, has an intermediate duration of action. When it comes to functions, the predominant metabolic function is to degrade the muscle proteins and increase the nitrogen excretion and increase the glucose levels and the hepatic glycogen synthesis, and to increase the fat mobilization and to redistribute fat. As regards the immune function, it increases the anti-inflammatory cytokine production while decreasing the pro-inflammatory cytokines, and also decreases all inflammation related cytokine downstream pathways involving prostaglandins, leukotrienes, bradykinin, and serotonin, and decreases the blood counts of eosinophils, basophils, and lymphocyte counts, while it increases the neutrophil, platelet, and RBC count, and also impairs the cell-mediated immunity. The hemodynamic parameters as such, it helps to maintain the vascular integrity and reactivity and responsiveness to corticosteroids pressure effects, and maintains the fluid volume, and it also serves to modulate the perception and emotion and decreases CRH and ACTH release. As regards administration of steroids, the route of administration would depend on various factors. Primarily, that depends upon the disorder to be treated, the formulation which is going to be used, oral, inhalation, topical, or parenteral, and the route will depend upon the drug to be used and the disorder treated. Parenteral route is used in emergencies and oral drug intolerance, and oral is commonly favored for chronic diseases, and it's always preferred for non-systemic therapy whenever possible. Coming to the indications, the prime endocrine indications would include the primary and the secondary adrenocortical insufficiencies, congenital adrenal hyperplasia, hypercalcemia associated with cancer, subacute thyroiditis, and active thyroid ophthalmopathy. While for rheumatic diseases, it's used as adjunctive therapy for short-term administration in psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis, non-specific tenosynovitis, acute gouty arthritis, and synovitis of osteoarthritis. Dermatological conditions, steroids have a wide gamut of use, and its prime use is in pemphigus, all the bullous disorders, predominantly the bullous dermatitis herpetiformis, then Stevens-Johnson syndrome, exfoliative dermatitis, severe psoriasis, and eczema. And also in allergic states where control is not achieved by conventional treatment, it's used in seasonal allergic rhinitis, bronchial asthma, contact or atopic dermatitis, and drug hypersensitivity reactions. It's also a savior for various ophthalmological conditions like allergic corneal marginal ulcers, herpes zoster ophthalmicus, diffuse posterior uveitis and choroiditis, sympathetic ophthalmia, allergic conjunctivitis, optic neuritis. It also finds a use significantly in systemic sarcoidosis, in Loeffler's syndrome not managed by any other means, and in disseminated pulmonary tuberculosis concurrently with ATT drugs, and aspiration pneumonitis. And hematologically, it finds use in ITP in adults, in autoimmune hemolytic anemias, and in multiple myeloma, and in collagen vascular diseases when there is exacerbation or as a maintenance treatment in selected conditions of SLE, systemic dermatomyositis, or giant cell arteritis. And neoplastic diseases for palliative management of leukemias and lymphomas, and for acute leukemia in childhood. And for gastrointestinal disease to tide over critical period of disease in ulcerative colitis and regional enteritis. And for miscellaneous conditions like acute exacerbations of multiple sclerosis, and to induce diuresis and remission of proteinuria and nephrotic syndrome, and in tubercular meningitis with subarachnoid block or impending block when used concurrently with appropriate ATT. So now we have found that it has been a savior in multiple etiologies, multiple conditions. We will see what are the side effects due to these steroids. First, we will deal with the metabolic endocrine conditions and the other side effects. The classic one is the iatrogenic or exogenous Cushing syndrome, which can result due to chronic steroid use and can lead on to steroid-induced diabetes and secondary adrenal insufficiency, growth retardation. It can lead to, especially in children, when used chronically, it leads to growth retardation. It's found to delay growth spurt and the puberty initiation and hypogonadism and delayed puberty, and also leads to fat accumulation in disproportion, namely accumulation of adipose tissue in facial, dorsocervical and abdominal regions with loss of subcutaneous fat thickness in the limbs. So one commonly seen feature is skin atrophy, and with increased skin fragility, and you can see purpura here. It's really ecchymosis what is seen with a cigarette paper like consistency, and we have striae. Classically, a broad livid striae is a classic of Cushing's, and we have acne presenting due to glucocorticoids, and also hirsutism in this corticosteroid excess patients. Other feature which is classical of the glucocorticoids is the myopathy. Corticosteroids have been associated with proximal muscle weakness and atrophy, which has been developing over weeks and months. And higher doses has been lead to a more rapid onset. Classically, myalgia and muscle tenderness is not typically seen, and there is a severe catabolic effect on these muscles, and the symptoms typically improve and resolve at 3 to 4 weeks after discontinuation of these steroids. As coming to neuropsychiatric side effects, it predominantly affects the mood with mood lability, depression, mania, and bipolar symptoms predominating. Then it also can lead to anxiety, psychosis, and suicidal ideations. And cognitive effects are more common than the mood effects due to these steroids. It also affects memory, abstraction, and analysis in those taking it. Other neuropsychiatric side effects includes difficulty in concentration, and there is a global change in cognition with presentations either of delirium or dementia with varied manifestations. Most of these neuropsychiatric manifestations usually quickly resolves once it is dose tapered or discontinued, and the risk factor for such manifestations are found to be higher doses of steroids or prior history of psychiatric disorders, and high incidence is found in the initial 3 months of treatment. We will now dwell on glucocorticoid induced osteoporosis. There is a significant decrease in the bone mineral density within the first 2 to 3 months of initiation of these glucocorticoids. Initially in the first year, there is nearly, it can go as high as 12% of BMD is lost, and this slowly comes down to, in the subsequent years, to 2 to 3%. The increase in the fracture risk is usually dramatic and early, especially for the vertebral fragility fractures. And then the negative effects on bone is usually dose dependent. Here you can see the vertebral bone collapse due to the corticosteroid use. And usually the negative effects on the bone is usually dose dependent, and all we have to know that there is no dose which is safe when it comes to corticosteroid. There is even the lowest of the dose has been found to have some effect on the bone. And this bone loss is found to be predominant in the trabecular bone and leading to more of fragility fractures. And this has involvement both due to decreased osteoblast activity and increased osteoclast activity. And there is a contribution pathophysiologically due to decreased calcium absorption in the GIT and increased renal calcium excretion, and also decreased collagen synthesis in the pathophysiology of this. As compared to the fracture risk, there is an increased fracture risk with glucocorticoids, but this decreases on discontinuation of the steroids. But nevertheless, it doesn't return to normal immediately on stopping the drug. And the Frax tool, which we use for the fracture risk, captures this corticosteroid use, but it doesn't give allowance for dose modification, but nevertheless subsequently there has been an article which gives about adjustment for corticosteroid dose by Canis himself. Other commonly encountered effect on the bone is the osteonecrosis, which is avascular necrosis. This refers to the cellular death of bone components due to interruption of blood supply, frequently requiring surgical treatment to rebuild the bone. And there has been no consensus on the relative risk with different routes. And identifying this entity of avascular necrosis and having a conservative intervention early on could reduce morbidity associated with aggressive surgical treatments of osteonecrosis. And once suspected, it would be a best idea to safely reduce the dose or discontinue it altogether. The commonly affected joints are the hips and the knees, and the plain radiographs show the bone collapse, but it may not be evident immediately, only after a few weeks after the onset of symptoms, then we may be able to see it in the plain radiographs. So if you want to capture it early, then the best modality to use is the MRI, where we can capture the bone edema as well as bone destruction. Other predominant effect of glucocorticoids is the risk of infection, and this glucocorticoids affect both innate as well as acquired immunity, increasing the risk of various infections. These observational studies show the increased risk of serious infections, and this risk of infection was found to have a dose-response relationship. With higher the dose, the higher the infection. And concomitant immunosuppressive medication and underlying disorder is also to be taken into account while considering this infection risk. A meta-analysis had gone into this aspect, and they found that the relative risk of the serious infection complications was 1.6, relative risk of 1.6. And for those taking prednisolone doses between 20 to 40, the relative risk of infection was 2.1. But they did not find much increased risk when prednisolone doses were below 10 milligrams. And when they found this combination therapy with immunosuppressive agents was found to increase the infectious complications. As regards the bacterial and fungal infections, the bacterial infections are most common complications of corticosteroid therapy, and any bacterial pathogen could be causative. And invasive fungal infections are commonly observed, especially in chronic corticosteroid therapy. Classical is the pneumocystis carinii, or recent newly named pneumocystis zerovesi pneumonia, especially associated with high dose glucocorticoid therapy in children or adults with cancer, solid organ transplants, or collagen vascular diseases. Here we see is a classic orbital mucormycosis following long-term steroid therapy. The viral infections of steroid most commonly involve viral complication is the reactivated herpes infections, and H1N1 influenza pandemic showed a trend towards increased mortality in corticosteroid patients of all ages. And the recent recovery trial with COVID-19 had shown the benefit. Usually there has been till now there has been only increase in mortality due to use of steroids, but there is it has been shown in the COVID-19 studies that in a section of people with those oxygen requiring or in those requiring mechanical ventilation, steroids have been found to have a benefit and have a decreased 28-day mortality. And reactivation to active replication of hepatitis B and C virus occurs also is found in glucocorticoid therapy. As regards the ocular side effects, cataracts related to corticosteroids usually develop following prolonged corticosteroids and is usually bilateral, develops gradually and located in the posterior subcapsular location. They have been found to elevate the intraocular pressure by accumulation of the extracellular matrix material in the trabecular meshwork, leading to increased aqueous outflow resistance, and increased risk of glaucoma is found to be there in those receiving even glucocorticoid steroid eye drops. Actually, these steroid eye drops are found to have more risk as compared to systemic administration. Therefore, patients receiving prolonged glucocorticoid high dose therapy should have periodic ophthalmological monitoring. As regards the gastrointestinal side effects, These increase the risk of gastritis, ulcer disease, gastrointestinal bleeding, and glucocorticoids per se, they do have only a marginal increase over the GI events, while concurrent use of NSAIDs, there is a synergistic increase in the rise of GI events. There is an increased risk of cardiovascular disease, especially in doses of more than 7.5 milligrams of prednisolone, and this has been predominantly with ischemic heart disease and heart failure in large studies, but the association with smaller doses less than 7.5 milligrams per day has been found to, the association is unclear. So in summary, we saw that corticosteroids have been a double-edged sword. It has been both treatment of choice for various inflammatory, allergic, immunological, dermatological disorders, but also on the other hand has been associated with myriad side effects encountered in supraphysiological or inappropriate concentrations. So I would like to conclude by saying that it's a savior when used judiciously, and a Satan guised as a serpent when used indiscriminately without evidence. Thank you.
Thank you, Dr. Satish, for that excellent talk. We'll reserve questions at the end of since there's one more talk. The final talk in this session is about COVID and its consequences. There cannot be a session complete without discussion on COVID. And this is although we know that diabetes is so common after COVID, there is lot of discussion on other autoimmune diseases, especially thyroid diseases after COVID. So to throw more light on that will be Dr. D.B. Naik, MD, DM Endocrinology. He is additional professor and head of the Department Endocrinology, JIPMER, Puducherry. His research area of interests are steroids, cancer-induced diabetes, osteoporosis, and adrenal disorders, and he's got 50 publications in reputed journals to his credit. Over to Dr. Naik.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank the Madurai Trendo team for giving me this opportunity. As we know, everybody has know about the acute complication of COVID and their outcome. Today we are here to discuss about the post-COVID related to thyroid dysfunction. This is the agenda of presentation. First of all, I will be discussing the post-COVID syndrome and what is its mechanism, acute COVID and what is its impact on thyroid dysfunctions. Then subsequently, I will discuss the post-COVID and the impact in its mechanism on thyroid autoimmunity and thyroid dysfunctions. And as we know that everybody has received COVID vaccine and what is its impacts on the thyroid dysfunction. If you look at the current scenario of COVID, as of now, nearly 537 million people are being infected by the COVID. And total death rate till date is 6.31 million. But if you look at even after recovery, these patients develop many kind of symptoms, and this is categorized as a post-COVID syndrome. Can be seen up to a tune of 10 to 15% in patient with COVID. And this post-COVID syndrome was defined by the WHO saying that if the symptoms, the post-COVID symptoms which are persist more than 12 weeks after recovery is defined as a post-COVID symptom. If you look at the symptoms which are seen in post-COVID, are largely maybe like fatigue and weakness, but it has symptoms can be of any system. If you look at neurological symptom, psychiatric symptom like cognitive impairment, decreased sleep, headache, anxiety, depression, cardiovascular symptom like chest pain, palpitation, respiratory breathlessness, persistent cough, and GI symptoms like altered bowel habit and musculoskeletal symptoms these are the very most common type of symptoms has been described with post-COVID. This is the possible mechanism of post-COVID syndromes. This has been there are several studies look at the persistent of virus, persistent contribute to the post-COVID symptoms. And even if you patient recovery from the infection, there will be still persistent of inflammation that also can contribute to the post-COVID symptoms, and persistent of tissue and organ damage, and that will also trigger the autoimmunity and immunodysregulation. And even in the change in the central nervous system, cardiovascular system can contribute. Moreover, there is dysregulation of pituitary adrenal axis, pituitary thyroid axis, even pituitary gonadal axis, which can contribute to the post-COVID symptom. I'll be next covering the thyroid dysfunction in acute COVID. This is the mechanism how the SARS-CoV virus entered through the thyroid gland, because it has a SC receptor, so it can directly attack the thyroid glands. Similarly, after it is entering to the airway, it can produce excessive cytokine because of inflammation and produce a cytokine storm, which can impact the hypothalamic pituitary axis, or it can directly impact the thyroid. Even through the mediated through the autoimmune process, which can produce the chemokines, which can impact the thyroid function. So there are various thyroid functions which are described in the COVID patient with acute infection. Most common is the CQ thyroid syndrome, also known as low T3 syndrome. And as I told, the inflammatory markers can involve the HPT axis, which can mimic like a secondary hypothyroidism, which is also known as functional hypothyroidism. And there are several reports of clinical picture mimicking like thyrotoxicosis, which is predominantly because of thyrotoxicosis. Looking at this data, which is available in Indian contest, this is the study which has done from the India. So you can see around 230 patients was studied in this study, and you can see around 24% of patient has CQ thyroid syndrome, and low TSH was found in around 4%, and high TSH was found in the 7%. So this kind of pattern of thyroid dysfunction has been described in various studies. And in many studies also, they have looked at the prognostic factor. Similar to this study, in this study, they have low T3 is being considered as an independent predictor of severity and outcome in COVID. This is another study from the PGI Chandigarh, where they have looked for the thyroid dysfunction in a COVID patient. They have included 84 patients. If you can look at the previous studies, the low T3 or CQ thyroid syndrome proportion is very less. But in this study, they found about 74% of the patient had low T3 or CQ thyroid syndrome, and more so in the patient with severe illness. And they have described a very atypical pattern. Normally, thyroiditis, we consider it as a subacute thyroiditis or decruven thyroiditis, which is typically associated with low TSH and high FT4 and high T3. But particularly in case of COVID disease, this atypical thyroiditis is typically described as the T4 above the upper normal range with normal or low TSH, and it was more found in severe patients as compared to mild cases. Not necessarily that there may be only abnormality in the single parameter of thyroid function, like isolated T4, isolated low T, isolated T3, and isolated TSH abnormality also described in the literature. This is another study from the Italy where I looked at the 287 patients, but this study is totally different from what described in the other literature. They found about 20% of patients have a feature of thyrotoxicosis, because in case of thyroiditis with COVID infection, initially there was no symptom or the levels are not very high. But in this particular study, they reported out of significant number of patients have biochemical feature of overt thyrotoxicosis characterized by low TSH, high T4 and high T3. The high incidence of thyrotoxicosis in these cases could be because of dystotic thyroiditis, and it is primarily due to the systemic immunoactivation. So from this all three studies, it is clear that in patient with COVID, particularly in acute phase, you can have a abnormality in CQ thyroid syndrome, thyroiditis, secondary hypothyroidism due to functional hypothyroidism. So whether these findings in the acute COVID is replicated in post-COVID, or their findings are totally different. How the SARS-CoV produce autoimmunity? Because once the inflammatory process is subsides, most of the time the functional abnormality, non-thyroid illness will be not very common in post-COVID. So it is largely can be because of thyroid autoimmunity. This is the mechanism. Once the virus is entered into the thyroid in body, they usually taken over by the antigen presenting cell. They act on the subsequently stimulate the T helper cell. The T helper cell subsequently stimulate the B cell, and they are the cell which is responsible for the producing autoimmunity. If you look at the pattern of thyroid involvement, like you see thyroiditis or Hashimoto's thyroiditis or Graves' disease, with regard to autoimmunity kind of thyroid disease, we define as a Hashimoto's thyroiditis, Graves' disease, and painless thyroiditis come into the category of autoimmune disease. From this slide, you can be clear that like Graves' disease is always associated with pre-existing autoimmunity, or it can be due to de novo induction of autoimmunity in case of post-COVID. But thyroiditis, particularly subacute variant, is usually not related to autoimmunity, but paleness or postpartum heredity can be related to pre-existing autoimmunity. Hypothyroidism is a Hashimoto's thyroiditis, can be a autoimmune disorder, and it is can be due to de novo induction of autoimmunity by COVID. This is the study which is looked at the thyroid function during COVID and after COVID. They try to compare the thyroid function with the thyroid function available in the previous year in the non-COVID era. And when they compare, they found that if you compare between the during and before the non-COVID timing, the TSH and FT4 was found to be significantly lower during the acute infection. And they follow up these patients for a period of 3 months. And during their follow-up, they found that around 2 patients has thyroiditis. So this is not necessarily common with COVID. It can occur with any kind of COVID, any kind of viral infection, that they can develop a kind of thyroiditis known as subacute thyroiditis or proven thyroiditis. This is another study from India, which was done from the West Bengal. It is a retrospective prospective study. Retrospective because they have taken the thyroid function done during the time of acute COVID, and they have prospectively followed the 160 patients, those are come for a follow-up. In this study, they found about 11 patients, that is constitute about 7% of patients have subacute thyroiditis. And these patients, they have followed for 6 months. And the typical picture of subacute thyroiditis in their studies, mean age was 44. And all kind of thyroid patients with severe, mild, moderate, asymptomatic patient can have a subacute thyroiditis. And if you look at the outcome of these studies, significant number of patients with subacute thyroid usually resolve by itself. So out of 11 patients, 9 patients become euthyroid and 1 patient have subclinical hypothyroidism. They have categorized into 2 groups, that is painless thyroiditis and painful thyroiditis. Painless thyroiditis, if you compare between the painless and painful thyroiditis, you can see that the age of onset are younger, and the presentation from the recovery was much shorter, and inflammatory markers are higher in patients of painless thyroiditis. But painless thyroiditis is something it's very, very difficult to pick up, because largely we only evaluate these patients when they are present with the painful thyroiditis. And at the outcome, I have already told that most of the patients become euthyroid. So in another study where the thyroid dysfunction and relation to immunoprofile were studied, in this study they have looked the thyroid function in a patient with abnormal thyroid function was found in 25 patients. They have measured the autoantibody in this patient, about 188 patients. At the acute infection, they found that around 30% of the patients have TPO and antibody positive. But presence of TPO antibody or anti-TG antibody does not define that they are likely to develop dysfunction. Even these patients in the acute COVID have this autoantibody, they are not having any significant thyroid dysfunction. And they have followed the patient, around 25% they have followed up and re-evaluated after recovery. And they have found that about 2 patients persistently have low TSH, elevated FT4 and FT3 and TSH receptor antibody, which is suggestive of Graves' disease. And 2 patients have autoimmune thyroiditis and that are favoring Hashimoto's thyroiditis. From this study, it is clear that they not necessarily subacute thyroiditis. Patient recovering from COVID can have chance of developing Graves' disease and Hashimoto's thyroiditis. This is another study also looking at the outcome of the study done at baseline at 3 months. About 1 or 2 patients were having normal thyroid function. When they follow up these patients, you can see that significant number of the patients become euthyroid. Only 1-2 patients have abnormal thyroid. So there is a variable report. Some studies show there is abnormality in the thyroid function, but some studies show there is no significant abnormality in the thyroid function during follow-up. But in this particular study, they looked at the antibody status, and trap antibody, that the TSH receptor antibody which was measured at baseline and at the recovery. And they typically found that there is an increase in the TPO level during the time of recovery in patient with COVID. So, but this is not translate into the positivity rate because they have taken cutoff of more than 100. And they have also measured the trap antibody, that is for TSH receptor antibody. There was no significant difference in the TSH receptor antibody at the baseline and at recovery. But there are factors which can associate with the high titer of TPO antibody if there is severity of illness, high titer of TPO at baseline, and high CRH. And they have looked at the patient, those are baseline TPO positive and baseline TPO negative. Particularly in the negative, there is mild increase in the titer of TPO at the time of recovery, and 4 patients become positive. But those patients having TPO positive, they remain positive. Only 1 patient have TPO negative, but titer is very high because positive anti-TPO titer is defined as 100. So another study from India, we are looked at the, because in the, as we are looking at whether the autoimmunity, post-COVID autoimmunity increase the risk of thyroid problem in post-COVID or not. This is another study from India, from All India Institute of Medical Science. They have taken the GDM patient, those are GDM, post-GDM, those are following with them, and they looked at the autoantibody status at various time points following the recovery. They have categorized the mild infection into those of seropositive and non-symptom of the COVID-19 infection. And in the study, they have shown that categorized into the infected group and non-infected group. But if you look at the proportion patient of TPO positive, there was no significant difference in the autoantibody positive in the mild patient. So in the study, they have concluded that TPO positive between infective and non-infective patient was not significantly different. Even the progression to thyroid dysfunction also was not significant. And Graves' disease, with regard to Graves' disease, there are only case reports available in the literature with regard to the occurrence of Graves' disease and also occurrence of recurrent Graves' disease in patients with post-COVID. With regard to vaccine, as you all know that we are all received a vaccine, the post-COVID vaccine can also induce autoimmunity. It's also known as ASIA syndrome, autoimmune inflammatory syndrome in response to adjuvant. So far from India, there is only 1 case reported with regard to this, and most of the literature are from the Western countries. This is the 47-year female, which was presented 2 weeks after first dose of vaccination. This is because of AstraZeneca vaccine. But this kind of thyroid autoimmunity only seen in patients with mRNA-based vaccine and viral vector vaccine. This mechanism behind can be because of molecular mimicry, epitope spreading, paniculal activation, or bystander activation. There are several reports of thyroid dysfunction in post-COVID, like Graves' disease, Hashimoto's thyroiditis. As these reports are not from the India, I have not shown in the literature. To summarize, I can say that the association between the acute SARS-CoV infection and thyroid dysfunction is very, very definite in the acute stage. As we have seen the literature, that SARS-CoV-2 do induce the thyroid autoimmunity, and post-COVID, SARS virus could induce the subacute thyroiditis, but subacute thyroiditis is not an autoimmune disorder, unless otherwise it's a painless thyroiditis. It can induce the autoimmune other disease like Hashimoto's thyroiditis and Graves' disease. But if you look at the whole literature which is available at present, the proportion of patients developing this kind of autoimmune thyroiditis are very, very minimal. So we need further research in this area or a long-term study to define that the post-COVID leading into more thyroid disorder. Finally, to approach to a patient with post-COVID thyroid dysfunction, if you have a patient having been referred with a thyroid function abnormality, you may need to look at whether the patient having any post-COVID symptom or not. Particularly in case of acute thyroiditis, patient will have acute neck pain. If his acute neck pain is there, probably patient have a painful subacute thyroiditis. But if you have a thyroid function like that, even without pain, patient probably have a painless subacute thyroiditis. But however, you cannot rule out Graves' disease from the painless subacute thyroiditis or painful thyroiditis. For that purpose, you need to know this investigation. Thyroid ultrasound can help you and guide you. Particularly in case of subacute thyroiditis, these inflammatory markers can be elevated. So that can guide you in saying whether patient have a subacute thyroiditis or not. And if you have availability of thyroid scan, it can clearly tell you whether there is increased uptake or decreased uptake. Particularly if there is high uptake, then it's more suggestive of Graves' disease. Graves' disease, and if you have low uptake, it's more suggestive of subacute thyroiditis. If there is no pain, it can be easily be managed with beta blocker. If there is pain, then you may need to consider starting with NSAID or steroids. And if you want to further prove, then TRAP antibody, the TSH receptor antibody, can guide you whether you are dealing with a Graves' disease or not. And if you patient have a specific hypothyroidic symptoms, you should look for TSH. If TSH is more than, then there is an indication to define them as a patient having overt hypothyroidism. And you want to further establish the etiology, whether it is because of Hashimoto's thyroiditis, then ATPO or ultrasound, ATPO positivity can tell you whether it is Hashimoto's thyroiditis. And thyroxine are the definite treatment for this hypothyroidism. Thank you for your questions here.
Thank you, Doctor, for your nice presentation. Of course, the word COVID, it paralyzed the entire world for the past 2 years. The COVID infection, of course, it produces autoantibodies, which can affect every organ in our body, and of course, thyroid is not an exception. You presented very well. Now the session is open for discussion. I ask the speakers to come to dais.
I thank all the speakers for excellent talks. I'll set the ball rolling for the discussion by asking Dr. Ramkumar. I saw one slide where the latest guideline of the Endocrine Society says target up to 8% HbA1c in for preoperative thing. I think I was very surprised with this new
Actually, none of our surgeons are ready to wait till the HbA1c is under control. So I think that is probably the reason why they have added a second statement. If HbA1c cannot be controlled below 8%, at least targeting 100 to 180. Because most of the patients in my hospital, they are getting admitted mainly for surgery. And even if the sugars are not under control, they invariably take up for surgery. If they don't clear them for surgery, they will send to some other endocrinologist.
In COVID, with the usage of steroids in the inpatient, we are using high doses of insulin. And despite that, sugars were not controlled and had many opportunities of using OHAs in supplement. What's your experience of using OHA?
Sir, even when I was given this topic, the main thing I also wanted to know whether are there any guidelines which actually mention OHA to be used in inpatient management. Unfortunately, no. Only DPP-4 inhibitors. I do not know how much the DPP-4 inhibitors are going to reduce the blood sugars in a severe hyperglycemia. Maybe it can reduce as I mentioned, it can reduce the insulin requirement to some extent. But I'm not sure whether it. But I actually use a lot of patients on other OHAs, including sulfonylureas and metformin, especially in those patients who are taking on a regular diet. But unfortunately, no guidelines mentioned that to use metformin or sulfonylureas. There are some doctors whose patients, physicians who refer the case for diabetes management, even they are also very clear that they should not use any oral drugs, then they should control only with insulin. So for my patients I use and I don't find any complications. Although the textbook says the risk of hypoglycemia is more, I find it more with insulin rather than with sulfonylurea. Probably maybe we choose the patients, not that the main problem with sulfonylurea they mentioned is a sustained hypoglycemia. That it's very difficult to treat if they are not eating and you give a sulfonylurea. I think the patient selection is more important. I'd also like to know from Dr. Satishar, whether do you strictly avoid all, there are certain, even in the guidelines as clearly mentioned, in some patients we can still use it.
Actually, for mild cases, we can use just DP4 inhibitors. We have used it.
DP4 inhibitors, now the guidelines have also cleared, are going in favor of it. Regarding other, suppose no liver dysfunction,
If the
metformin
glucose
and
intolerance
sulfonylureas.
is on the higher level, then insulin is the only choice. Maybe even in those cases,
Like
we
as
can use
I was
DP4
asking,
inhibitors
even
to
on
decrease the
DP4
insulin dose.
even on DP4 inhibitors and even on maximum dose of insulin, is there any role for sulfonylurea or metformin? I think that's what you're asking.
Probably in non-critical illnesses, when the patient is admitted for non-diabetes related illnesses, I think we can use the OHS in hospital admission.
The main reason they are mentioning is about the safety and efficacy. Regarding the safety, we already mentioned about lactic acidosis. If those contraindications are not there, I don't think we will avoid them. And for sulfonylurea, the only concern is hypoglycemia, and obviously we are going to consider that only when the sugars are really going to be high, even on insulin.
Audience,
sir, this is a question to Professor Naik. Good evening, sir.
Yeah.
Nice that you gave good recent informations, but you really scared me. Let me tell you, I am a hypothyroid patient for the last 25 years, and I'm presently going on with 200 micrograms of L-troxin daily. So I also had, in the second wave, incidentally, I was COVID coordinator for Puducherry State, so you know how much I had to run about here and there. I had been with COVID in the second wave, May last year, and this time with Omicron also. Now my fear is, my voice was not like this. It's over 2 months that my voice has become little gruff. There is a change in it. I do have neck pain, but their last slide really scared me, telling COVID, post-COVID is really producing hypothyroidism. I'm a known case of hypothyroidism. Will it aggravate people who are hypothyroid? And will they have to add on more thyroxine? As such, I'm 200. So do we have to increase the dosage of thyroxine is my question. Second thing, what should I do further? Will it get aggravated more? And my voice, I want to get back because I'm a singer too. So your answer, sir.
To your first question, you are telling whether I have risks to develop this kind of problem or not. Because if you look at the percentage of population which has developed this subhypothyroiditis, Graves' disease are very minimal. And these studies are primarily done on patients, those are euthyroid at the baseline. So going to whether you have risks for developing any other problem is very unlikely, unless particularly if you have a thyrotoxic features, then you can think of, but very unlikely you can develop these symptoms. And with regard to your treatment, it primarily depends upon your thyroid status. You cannot increase the dose or something. It's best predominantly if your thyroid function is within the normal, there may not be worry to. Then you may need to readjust the dose. Yeah, it may have to readjust the dose, or you need to look for if there is any other things which are interfering your absorption of thyroids. There may be several other factors responsible for having persistently high TSH, as in normally what we see in the OPD, maybe rather than thinking it is due to the COVID.
Even now your voice is very nice, madam. No problem.
My question to Dr. Ramkumar, sir. Sir, you didn't mention anything about alpha glucosidase inhibitors in non-critically ill patients admitted with normal HbA1c, only stress hyperglycemia, patient taking orally normal diet, sir. Shall we use alpha glucose inhibitors if postprandial alone is increased?
I think some of the review articles they mentioned that mainly because of they're not that efficacious, one, and because of GI issues that usually not considered during even for non-critical ill. That's
usually patients with diabetic foot infections admitted for treatment. So they don't have any GI symptoms?
Yeah, previously. Actually, I think even in Apollo there are many consultants who use actually alpha glucosidase inhibitors. I've seen a lot of prescriptions on patients on alpha glucosidase inhibitors. So these are, but as you know, this is not a much stronger drug when compared with other gliptins or sulfonylureas or other sulfonylureas. So I think for mild cases, I think gliptin is safer. But if you want to use alpha glucosidase inhibitors, if there are no GI concerns, I don't think it's any issue.
Thank you.
Only there's no safety issue.
So the discussion is over. We'll conclude the session. I congratulate the Trendo team for having organized such a wonderful mega scientific event after a long time. I think this is the first mega event post-COVID, and my sincere thanks to the organizers for giving me the opportunity to be one of the chairpersons for this excellent session. Thank you. And before concluding, okay, we will conclude the session.
Thank you, sir. Thank you. Thank you, speakers, and thank you, chairpersons. Sir, please don't go. Sir, it's an honor always to facilitate the speakers. I would like to ask Sridhar sir to honor Satish Kumar sir with a memento. Sir. I would like to invite Dr. Syed Sultan sir to honor Dr. D.B. Naik sir with a memento. It's an honor to invite Dr. Ram Kumar sir to be felicitated. Sir, both the chairpersons can do it. I invite Dr. Shanmugala sir to honor the chairpersons. Dr. Syed Sultan sir and Dr. Sridhar sir. Yes. Sir. With this, we are closing the day of sessions, and we will proceed to the industrial symposium, starting with the ARIS team. Industrial symposium, yeah.
Yeah, good evening to all the doctors. This is Balachandar. I'm a divisional sales manager of Eris Life Sciences. And I welcome you all on this platform. And it has been a very nice day. And at the end of this day, we have been allotted this symposium. And we are very glad to welcome Dr. Gopinath, our chairperson for today's evening program. Doctor, I would like to request you to welcome Dr. Shanmugavel, our today's speaker.
Great. Good evening. First, thanks to the organizing committee for this industry symposium, also the Eris Pharma for asking me to chair a very powerful discussion going to be by a legend in diabetes from Trichy, Dr. Shanmugavel. I think you can read. And this is fully a synopsis. I think you'll go to pages, his things. So cut short, he's a well-known friend of mine. He's my mentor also. And I also asked him to consider once to how to form the Diabetes Club of Madurai, following Trichy Diabetes Club. So he has been always been my advisor. So I'm very happy, very privileged to chair this session where we got very important topic to discuss about HLD inhibitors. Of course, there is no symposium, there is no CME on diabetes without HLD inhibitors. And every day they are discovering some new aspects of HLD inhibitors. It was discovered as a diabetic drug, but today is, to be practical, to be frank, it is going away from diabetes. It is going away from diabetes. Yesterday I read one paper that HLD inhibitors are useful for this hyponatremia, for outpatient hyponatremia, because this syndrome of inoperation ADH induced hyponatremia was responding to these HLD inhibitors, even in non-diabetic patients. So every month or every week we are discovering some new aspects of HLD inhibitors apart from diabetes. And even recently some of my colleagues are there. I have spoken on 14, the last my number was 14. I don't know, it has gone to 15 non-glycemic benefits of HLD inhibitors. So today I am very happy to present this HLD inhibitors, the statins of the year. The statins of the year, this is HLD inhibitors. So I welcome Dr. Shanmugavel to present his deliberations on this topic.
Respected chairperson, senior doctors, my doctor friends, and of course, former friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on SGLT2 inhibitor, the statins of the 21st century, with a particular focus on evidence and outcomes. So I thank our chairperson, Dr. Gopinath, my friend, for his generous introduction. Also thank the organizing committee members, Dr. Kumaravelu, Dr. Manikandan, Dr. Anand Kumar Annamalai, and others for their kind invitation. I also extend my sincere thanks to Eris Pharma. Right, my disclosures. So what I'm going to do for another 40 minutes, SGLT2 inhibitors, the statins of the 21st century. We know pretty well. Type 2 diabetes is a multi-causal heterogeneous progressive cardiometabolic condition. It's a major risk factor for atherosclerotic cardiovascular disease, heart failure, as well as CKD. Despite major therapeutic advances leading to improved outcomes over the past 2 decades, cardiovascular disease remains the major cause of morbid mortality in patients with type 2 diabetes. So the development of treatment strategies to improve the cardiovascular outcomes in this vulnerable patient population remains a major priority, not only cardiovascular outcomes, but also CKD outcomes, heart failure outcomes. So the progressive complexity of type 2 diabetes. So type 2 diabetes progressive disease. So multiple intervention will need to be used while managing diabetes as the disease advances. So there is a need to modify and individualize anti-hyperglycemic regimens in order to improve glycemic control and also delay the advancement of the CKD, as well as heart failure, as well as atherosclerotic cardiovascular disease. So new agents proven to reduce adverse cardiovascular outcomes, renal events, as well as heart failure outcomes in patients with the type 2 has triggered a major paradigm shift beyond glucose control to a broad strategy of comprehensive CV risk reduction. So SGLT2 inhibitors, the statins of the 21st century. This particular statement was issued, released by the Department of Medicine, Harvard Medical School. My question is, can we all consider SGLT2 inhibitors the statins of the 21st century? Let me take all into evidence, and at the end, I'm going to ask our chairperson whether he is going to agree or disagree on this particular statement issued by the Harvard Medical University. So relatively small number of drugs have been responsible for major advances in medical practice. So the discovery, development, and elucidation of the mechanism of actions of aspirin, penicillin, and statins are remarkable, with the success stories, each with some surprises and each crowned by Nobel Prize. So the SGLT2 inhibitors has been proven effective in the treatment of type 2 diabetes, various forms of heart failure and kidney failure, and represent one of the major pharmacological advances in cardiovascular medicine in the 21st century. So if we look into the prevalence of cardiovascular disease in patients with the type 2 diabetes with reference to stroke, myocardial infarction, heart failure, coronary artery disease, and overall CVD. So what is the reason? So the CVD is a major cause of comorbidity and death among patients with the type 2, with the CAD having the highest prevalence. So this particular study, ICAR, for diabetes survey, this particular study highlighted the importance of prevalence of CKD risk in Indian patients with the type 2, 58.7% of patients with the type 2 in the Indian patients, outpatient setting, having increased high CKD risk. If you look into the publication from All Indian Institute of Medical Science as well as Bhubaneswar, they also confirmed the similar prevalence. And based on the G, that is based on the EGFR categories, we have these G1, G2, G3, A, B, as well as G4 and G5. Based on albumin categories, urinary albumin excretion, A1, A2, A3. And based on it, we have low risk, moderate risk, high risk, and very high risk. So this particular study is very important. This was published in Diabetes Cat 2019 December. This literature confirms that strict glycemic control, keeping the A1C less than 7, in the first year significantly reduces the risk of macrovascular events and mortality, the so-called the impact of early glycemic control on future complications. So A1C levels greater than 6.5 for the first year, after diagnosis demonstrated what's outcomes among patients with the newly diagnosed patients and 10 years of survival in comparison with the A1C less than 6.5 for the first year. So longer periods of exposure to A1C levels greater than 8% were associated with increasing microvascular event and mortality risk. So strict glycemic control, risk reduction with the A1C level less than 6.5 versus between 7 to 8%. If you look into the microvascular risk reduction, down by 39%, microvascular 29%, death 29%. If you see the p-value, it is statistically significant, thereby demonstrating, highlighting intensive treatment for newly diagnosed patients might be necessary to avoid irremediable long-term risk for diabetes complications and mortality. So typical Indian patients phenotype, we have thin fat Indian, high visceral fat, higher insulin resistant, high inflammatory markers, and characteristic dyslipidemia, high risk for diabetes complications, as well as the cardiovascular risk, early decline in beta cell function. So we need to prescribe, because these are all the common patients we come across in our day-to-day practice. If you look into the efficacy of modern diabetes treatment, DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor in white compared to Asian patients with diabetes. So SGLT2 inhibitors, Asian versus white, based on the number of studies, the glucose-lowering efficacy of SGLT2 inhibitors and to a lesser extent DPP-4, it was greater in studies of predominantly Asian ethnicity. So there is a definite role for us to prescribe both SGLT2 inhibitors followed by DPP-4 inhibitors in addition. So if you look into the glycemic efficacy, SGLT2 inhibition, that is stronger in Asian patients with the type 2 diabetes. So in Asians, in whites, if you see from the baseline with reference to A1C reduction, there was significant. and p-value is also statistically significant. Compared to DPP-4 in Asians and whites, where it did not reach statistical significance. So the difference in response, they are more likely to reflect phenotypic or pathophysiological differences. So ominous octet, multiple factors contributing to overall hyperglycemic patient with the type 2. If you look into the SGLT2 inhibitors, they inhibit renal glucose reabsorption, increases lipid oxidation, improves insulin sensitivity, at the same time increases physiological levels of glucagon, accounting for increased endogenous glucose production. So these are the challenges we come across in our Indian patients, and there are relevant SGLT2 related inhibition features. So low adiponectin level, high insulin resistance, low level of adipokines. When you prescribe patients on SGLT2 inhibitors much early, we can correct the basic pathophysiological abnormalities underlying type 2 diabetic patients. So this is very important slide. SGLT2 inhibitors improve insulin sensitivity. How? It increases urinary glucose excretion. There is a change with reference to insulin glucagon ratio, with an impact, beneficial impact on the liver metabolism, adipose tissue metabolism, skeletal metabolism. In that, it reduces the triglyceride content, favors glucose uptake, thereby it improves the insulin sensitivity. In the long run, it also improves the beta cell function based on the fact that it increases urinary glucose excretion. There is reduction of glucolipotoxicity with a favorable impact on the beta cell function as well as beta cell mass. Thereby, it is able to preserve the beta cell as well as beta cell function as well as mass for a longer period of time. So this is the ultimate metabolic changes following inhibition of SGLT2 inhibitors. It reduces the glycemic parameters, number one, reduces adiposity consequent on increased urinary glucose excretion with an impact on adipose tissue. Next is pancreas, altering the insulin glucagon ratio, as well as favorable impact on the metabolism of liver, as well as the substrate switch in cardiac myocytes, as well as in the brain. So it increases the fat utilization. In that, it stimulates the AMPK related activity in the skeletal muscles. It enhances browning, that is differentiation of brown adipose tissue into white adipose tissue into brown adipose tissue. Thereby, it increases thermogenesis as well as energy expenditure. Besides, there is change in the polarity of M2 as well as M1 macrophage. M2 is anti-inflammatory, M1 is pro-inflammatory. There is a change with reference to polarization. Next is SGLT2 inhibition modulates NLRP. It is nothing but a pyrin-containing domain which plays an important role in inflammation. It stimulates the release of interleukin-1 beta that in turn accelerates atherosclerotic process as well as heart failure risk. And that SGLT2 inhibitor attenuates this particular pathway. It reduces epicardial adipose tissue. That is the fat that is located between the visceral pericardium and the myocardium, and that it has a favorable impact on the epicardial tissue. Thereby, it reduces the incident rate of atrial fibrillation. This is how the epicardial fat increases the incident rate of atrial fibrillation. Patient with the diabetes, they are prone to develop atrial fibrillation, and it increases mortality, increases the CVA, that is cerebrovascular accident risk. Not only that, it also carries worse prognosis. So epicardial fat, it produces inflammation, oxidative stress, and also alters the electrical as well as structural properties of the pulmonary vein as well as atrial vein, increasing the propensity to develop atrial fibrillation. So sympathetic activity, it attenuates sympathetic activity, especially to the heart, to the blood vessels, to the kidney, with a positive impact on the renin-angiotensin-aldosterone system. Also, it has an impact on the neprilysin inhibitor, neprilysin enzyme. Thereby, it increases the natriuretic peptide and positive beneficial effect mediated by natriuretic peptide. These are all the mechanisms giving rise to reduction in the blood pressure, in that it alters the hemodynamic mechanism. It induces diuresis, natriuresis. Next is decreases body fat, decreases uric acid, decreases the sympathetic activity as well as the arterial stiffness. Next is it significantly reduces hepatic fat content in patients with the type 2 diabetes and non-alcoholic fatty liver based on the LIFT study. So this particular study, if you see the baseline compared to control and patient on EMPA, there was a reduction in the hepatic content as well as there is a change with reference to the liver enzymes. Next is GLP-1 receptor agonist, and SGLT2 inhibitors significantly improve the biomarker of hepatic steatosis, that is fatty liver index, as well as fibrosis. So the fibrosis score 4. There is significant improvement. And SGLT2 inhibition in non-alcoholic steatohepatitis and type 2 diabetes, possible histological improvement with reference to inflammation, with reference to ballooning and other pathophysiological abnormalities characteristic of non-alcoholic steatohepatitis. Next is obstructive sleep apnea. Patient with obstructive sleep apnea, they develop diabetes. Patient with the diabetes, when they develop obstructive sleep apnea, they carry very high risk, cardiac risk. So patients participated in the EMPA outcome trial. There was 52% lower risk of new onset obstructive sleep apnea. In that, SGLT2 inhibitors in patients with obstructive sleep apnea showed a significant reduction in hypopnea index. Thereby, it modulates the mortality or morbidity due to cardiovascular illness. So, if you look into this three-dimensional view of the tongue, so red indicates the tongue muscle, and the yellow color indicates the fat that is deposited. So, by putting the patient on SGLT2 inhibitors, the retropalatal and retroglossal deposition of fat, there is regression. Thereby, it improves the pharyngeal airway and pharyngeal air pathway. So, the rostral shift of the fluid in the interstitium. SGLT2 inhibitors compared to furosemide. Furosemide reduces intravascular as well as interstitial. In contrast, SGLT2 inhibitor has differential volume loss. So, interstitial fluid volume loss in comparison to blood volume. So, such a differential volume loss may have relevant clinical implications on reducing congestion, which is subjected to further research. So, cardiorenal implications of SGLT2. So, diabetes through hyperglycemia, hyperinsulinemia, insulin resistance, that results in AG accumulation, glucolipotoxicity, as well as alteration with reference to metabolism, ultimately resulting in myocyte apoptosis, fibrosis, and left ventricular hypertrophy, greatly increasing the risk for cardiac myopathy. So, maladaptive pro-inflammatory response furthers the progression of diabetic cardiomyopathy. If you look into the mechanisms underlying diabetes and heart failure, so diabetes is a condition characterized by metabolic overload, number one. Number two, hemodynamic overload, which in turn results in ionic disturbance, inflammation, oxidative stress, that results in mitochondrial cytopathy, contractile dysfunction, vascular dysfunction, cell death, and heart failure. So that is a predominantly mechanism. So if you look into the patient with the type 2 diabetes, there is glucolipotoxicity because glucose is not utilized properly, lipids are not utilized properly. That results in endoplasmic reticulum stress, oxidative stress, and inflammation. That results in dysfunctional mitochondrial cytopathy. Normally, these organelles are cleared by a process called autophagy. In patient with the type 2 diabetes, there is impairment of this particular autophagic reflex, leading to the accumulation of the dysfunctional organelles. So that is the main cause for triggering cardiomyopathy or glomerulopathy or tubulopathy. So enhanced nutrient and oxygen deprivation signaling, that results in autophagy, that results in mitochondrial stabilization as well as suppressing inflammation, oxidative stress, and that in turn increases the ATP production. So the dysfunctional organelles are cleared. So SGLT2 inhibitors, that stimulates the nutrient deprivation signaling. We get two important co-transporters, namely SIRT1, SIRT1 and AMPK pathway. That in turn results in reduction in inflammation, oxidative stress, prevention of organelle dysfunction, as well as slowing of the development of cardiomyopathy, as well as nephropathy. So these are all the plausible mechanisms responsible for SGLT2 associated cardiovascular benefit. Number one, natriuresis, reduction in that is interstitial edema, differential volume loss, preload reduction, afterload reduction, and reduction on the left ventricular wall stress, improve renal function as well as cardiorenal physiology, inhibition of cardiac sodium hydrogen exchanger, that is very important. So SGLT2 inhibitors differentially impact the interstitial and intravascular fluid compartment. So selectively reduce the interstitial volume, thereby it relieves signs and symptoms of interstitial congestion, provide relief of elevated cardiac filling pressure. Next is in the cardiac myocytes, we have the sodium hydrogen exchanger 1. That increases the intracytoplasmic sodium and also interface with the calcium in the mitochondrium. And that is associated with the defective cardiac contraction. It restores, that is effect of sodium hydrogen exchanger, blockade on improving the mitochondrial metabolism. Equally important is the vascular effects of SGLT2. It improves the mitochondrial function, improves the viability of endothelial cells, improves the nitric oxide activity and the vasodilation. Next is with reference to left ventricular remodeling, which plays an important role in cardiac myopathy. In patients with CAD and type 2 diabetes, so this particular SGLT2 therapy has been associated with reduction in the left ventricular muscle mass index as well as left ventricular extracellular volume fraction. Next is atrial arrhythmia. So atrial arrhythmia carries bad prognosis, and it is associated with the worsening of heart failure, increasing the risk for CV event. So patients treated with the dapagliflozin in declectomy showed reduced incident rate of atrial fibrillation. Next is patients participated in the EMPA outcome trial. Ventricular arrhythmia, sudden cardiac death, both were reduced in patients in the EMPA arm, probably due to related to the reduced risk of arrhythmia or sudden cardiac death. Next is with reference to various trials, with reference to EMPA-REG, Canvas program, canagliflozin, declectomy with reference to DAPA and VET-CV in patients with the type 2 diabetes and atherosclerotic cardiovascular disease with reference to MACE, CV death, all-cause mortality, as well as hospitalization for heart failure and chronic kidney outcomes. So patients treated with SGLT2 inhibitors, patients with atherosclerotic cardiovascular disease, established cardiovascular disease, EMPA should benefit with reference to cardiovascular death, as well as hospitalization for heart failure or chronic kidney disease. Dapagliflozin in patients with the multiple risk factors, no improvement at all. In patients with established cardiac vascular disease, there is to some extent reduction in cardiovascular death. Next is, as per statistically robust meta-analysis of reduced ejection fraction failure, SGLT2 agents consistently reduce the risk of CV death, number one. Number two, hospitalization for heart failure. So EMPA reduced, EMPA in patient with reduced ejection fraction failure. Next is DAPA heart failure with reference to DAPA heart failure. In patient with diabetes, there was significant reduction in hospitalization for heart failure as well as CV death. Next is patient without diabetes. When given these two drugs, there was significant reduction in composite of cardiovascular death as well as hospitalization of heart failure. No worry regarding the hypoglycemia. So these particular agents are useful in the management of heart failure with reduced ejection fraction, regardless whether they have diabetes or not. So next is this particular sotagliflozin in patient with reduced ejection fraction. In patient with preserved ejection fraction failure also, there was significant improvement. So this is EMPA preserved study. Patients were randomized to receive EMPA and placebo. The composite endpoint, that is time to first event of adjudicated CV death or hospitalization for heart failure in patient with ejection fraction greater than 40. So many drugs have been tried in the management of preserved ejection fraction failure. But this is the first clinical trial which demonstrated the fact that putting the patient on EMPA showed significant improvement with reference to cardiovascular death and hospitalization for heart failure. So EMPA demonstrated clinically meaningful 21% relative risk reduction. So the number needed to treat 31. So if you treat 31 patients, we can prevent one event. So in the composite primary endpoint of CV death. Next is secondary endpoint. Again, there was significant reduction, 27%. So patients with heart failure, preserved ejection fraction failure, EMPA preserved, you can see the risk reduction 21%. If you see the p-value, it is statistically significant. Next is paragon heart failure, sacubitril/valsartan combination. It showed 13% reduction. Next is top cat, spironolactone, 11%. Next is I-preserve, 5%. Next is PEP-CHF, all-cause mortality, perindopril, just 8%. Charm preserved, candesartan, 14%. So this is the first trial which clearly showed. Next is summary of studies in patients with recent heart failure. So heart failure with reduced ejection fraction, preserved ejection fraction, patient with diabetes, patient without diabetes, in hospital treatment initiation, solaized with a reference to sotagliflozin. Next is with a reference to pioneer heart failure as well as impulse. So these are all the trials with various drugs. So EMPA preserved, breakthrough results. So for the first time in medical history, treatment showed beneficial outcomes in patients with heart failure, preserved ejection fraction by reducing the risk of hospitalization for heart failure or CV death. The benefit was independent of ejection fraction and consistent across further subgroups. So EMPA not only played important role with reference to the composite of CV death and hospitalization for heart failure, it also protected the kidney by slowing the decline in kidney function, that is doubling of serum creatinine, or persistent decline in eGFR less than 40%, or end-stage renal disease, or the need for renal replacement therapy, or renal death, or all-cause mortality. So the treatment of heart failure, preserved ejection fraction failure, EMPA would change the clinical practice. So decoding EMPA molecular mechanism of action. So the most probable cascade mechanism in heart failure with preserved ejection fraction with 94% accuracy. One is it reduces oxidative stress in cardiac myocyte, systemic inflammation, cardiac myocyte stiffness, extracellular matrix remodeling, and concentric hypertrophy. So these are all the hypotheses that has been generated with reference to improvement in preserved ejection fraction failure. It also improves diastolic function in common heart failure with reference to diastolic stiffness. So non-failing myocardium compared to patients with heart failure with preserved ejection fraction, you see the improvement with reference to the diastolic function. Patients treated with the EMPA, the p-value is statistically significant. So these are the possible mechanisms detailing why SGLT2 inhibitors may work in heart failure with preserved ejection fraction. It reduces the ROS activity, reduces sympathetic nervous system activity, reduces inflammation as well as oxidative stress. So SGLT2 inhibitor improved cardiac structure and function by reducing preload. Next is afterload with a positive beneficial impact on myocardium in terms of efficiency as well as contractility. So the estimated clinical benefit. So heart failure with the reduced ejection fraction failure. We normally put the patient on ACE inhibitors or ARBs plus beta blockers plus melanocortical receptor antagonists and various other treatment drugs. So we have the foundational therapy as well as novel therapies. So patients treated with ARNI, beta blocker, MRA, and SGLT2 inhibitors. Look into the CV mortality, 64% improvement compared to treatment without SGLT2 inhibitors, including RNA, beta blocker, MRA, and other drugs that are used in the management of heart failure. So this particular drug therapy clearly shown the benefit with reference to the reduced ejection fraction failure. So heart failure, we normally put the patient on ACE inhibitor, angiotensin, we updated the dose, then we add beta blocker, melanocortical receptor in the order, right? Propose new sequencing based on the RCTs with reference to EMPA and DAPA. So put the patient on beta blocker and SGLT2 inhibitors. And next is angiotensin receptor neprilysin within a week time. And within a week time, please put the patient on melanocortical receptor. Over a period of 4 weeks, put the patient on 4 drug therapy, small dose. This will offer distinct benefit. So the new expert proposal for sequencing of heart failure, foundational therapy completed in 4 weeks, step 1, simultaneous initiation, step 2, within 1 to 2 weeks of step 1, ARNI, and within 1 to 2 weeks of step 2, step 3 is MRA. So this will give a very good outcome with reference to hospitalization as well as cardiovascular death and mortality. Next is diabetic kidney. So we have the normal kidney. Normal kidney, you see the glomerulus, the basement membrane, the podocytes, the glomerulus structure, Bowman's capsule, as well as the tubule. Next is patient with the diabetic kidney disease. Change with reference to glomerular basement membrane, podocyte, and next is with reference to mesangial cell. Next is collagen, and changes with reference to the proximal tubule. Tubules undergo. And see the afferent arteriole and efferent arteriole. Afferent arteriole dilates, efferent arteriole constricts. This disparity increases the interglomerular pressure. So kidney protection with SGLT2 inhibition. So I have told changes with reference to afferent and efferent arteriole, interglomerular pressure. Next is changes with reference to glomerulus. So there is hyperfiltration, and whatever that is filtered by the glomerulus is absorbed in the proximal conductive tubule. That proximal conductive tubule is exposed to higher sodium as well as the glucose, naturally increasing inflammation, oxidative stress, increased demand for oxygen, and these are the changes we come across in diabetic kidney disease. When you put the patient on SGLT2 inhibitor causes afferent vasoconstriction and efferent arterial dilatation, reduces interglomerular pressure, and increases the sodium load in the distal conductive tubule. Thereby, it restores the interglomerular pressure and reduces inflammation. And very important thing is, it also induces the release of erythropoietin, which in turn improves the oxygen carrying capacity, release hypoxia with a favorable effect. So SGLT2 inhibitors reduce the burden on the proximal tubule. The proximal linear epithelial cells are overloaded with excessive energy. I told you, type 2 diabetes is characterized by hemodynamic overload as well as energy overload. And if you look into the changes in the microenvironment, there is a myofibroblast changes that in turn reduces the release of erythropoietin. By putting the patient on SGLT2 inhibitor, it restores erythropoietin secretion as well as release. So SGLT2 inhibitor improves kidney outcomes in patients with the type 2 diabetes, consistent kidney benefits. So the kidney outcomes by baseline albuminuria. Patients with higher urinary albumin excretion, they are the ultimate beneficiaries. Patients with higher EGFR, they are the beneficiaries. So if you look into the overall, A1, A2, A3, you can see the difference. And we normally say MACE, major adverse cardiovascular events. Here I have given MAKE, that is major adverse kidney events. That is the decline in EGFR greater than 50%, or progressive decline in EGFR, or end-stage kidney disease, or all-cause mortality. There was 32% reduction in the risk of kidney function events with EMPA. So among patients with the type 2, EMPA use was associated with the EGFR preservation, very important. And it also slows down greater decline in EGFR. So next is reduction in BMI, reduced risk of MAKE, that is major adverse kidney events compared with other non-SGLT2 antihyperglycemic treatment. So SGLT2 inhibitor use results in 58% lower risk of serious kidney events based on the Scandinavian real-world evidence. So if you look into the serious kidney events, EMPA treated compared to DPP4, DAPA treated compared to DPP4 inhibitors. So in this analysis, using nationwide data from 3 countries, use of SGLT2 inhibitors compared with the DPP4 was associated with a significantly reduced risk of serious renal events. So major studies with SGLT2 agents based on the kidney disease improving global outcome, KDIGO categories. So we have the G1, G2, G3A, B, as well as G4 and G5 with reference to glomerular filtration based on the albuminuria stage A1, A2, A3. And that what is seen in here, ECD, that is with reference to the cardiovascular outcome trial, EMPA, CANA, and D, ECD. And with reference to credence, that is patients recruited for the credence trial, that is CKD only. EGFR between 30 to 90, DAPA CKD, you can see the CKD as well as EGFR as well as the EMPA kidney with reference to EGFR category. So the proposed renal protective pathways, one is it reduces blood pressure, potential direct cardiovascular effect, reduces intraglomerular pressure, loop diuretic sparing effect, that is differential volume loss, reduces albuminuria, improves oxygen delivery, oxygenation, and it has anti-inflammatory as well as antifibrotic, and above all, it improves the metabolic parameters, right? So the effect of SGLT2 on major kidney outcomes. So if you look into the events and the patients and the relative risk and the hazard ratio with reference to all the parameters, patients treated with the SGLT2 inhibitors showed remarkable improvement. So SGLT2 inhibitors have demonstrated clinically meaningful kidney outcomes even in studies involving patients with type 2. Patients in the EMPEROR, non-diabetic. Next, DAPA CKD and DAPA heart failure, non-diabetic patients. They also showed benefits with reference to the SGLT2 inhibitors. So EMPA kidney trial, that trial was stopped due to evidence of efficacy. And in fact, EMPA kidney, they recruited patients even with the EGFR of less than 20 and urinary albumin excretion less than 200 milligram per gram creatinine, right? So SGLT2 again showed clinically, reduced risk of incident and recurrent nephrolithiasis. So if you look into the ADA standard of care with reference to the patient category, first line therapy depends on the comorbidities. So when we come across patient with ACVD or CKD heart failure risk, put the patient on SGLT2 as monotherapy. Next is Heart Failure Association of the European Society of Cardiology. So assessing the landscape of the use in the prevention as well as treatment of heart failure, they have prescribed, they have recommended CANA, DAPA, EMPA, or etugliflozin. They have consistently demonstrated to be effective for the prevention of heart failure. Next is the combined ADA and KDIGO guidelines for the use for glucose lowering. That is standard of medical care in patients with type 2 diabetes with CKD. So metformin lifestyle changes and indicators of high risk or established cardiovascular disease, SGLT2 inhibitors with a proven or reducing CKD progression. Again, clinical practice guidance for patients with the type 2 diabetes and CKD when we want to achieve, that is, when the patient is already on metformin, you can add SGLT2 inhibitors. RSSDA, Endocrine Society of India Therapeutic Wheel, again highlights the indications with reference to SGLT2 inhibitors and GLP receptor analogs. So SGLT2 inhibition improves hemodynamic parameters in patients with the type 2 diabetes, leading to cardiorenal protection. So remember vascular euphoria? That is the cardiovascular effects of SGLT2 inhibition. E stands for endothelial function improvement, utilization of energy substrates, pressure and volume offloading, hemoconcentration, oxidative stress reduction, reverse left ventricular modeling, inflammation control, and autonomic balance. So the priorities always take into consideration the risk factor, weight management, glycemia management, blood pressure management, lipid management, as well as CKD management, with a view to offer target organ productions with the aim to improve the metabolic parameters, cardiovascular as well as renal. So the CVOTs have raised expectation that newer glucose lowering agents should offer advantages that extend beyond glycemic control and weight management to address complications and comorbidities of type 2, particularly cardiorenal. And SGLT2 inhibition, holistic cardiorenal outcome, short-term effects and long-term effects. Short-term effects, purely hemodynamic and metabolic, and long-term effects with reference to blood pressure and lipid profile and with reference to ASCVD. So improved compensation for diabetes or blood pressure is probably associated with better long-term outcomes after SGLT2 inhibition. Now, let us come to the topic of this day. Can we consider SGLT2 inhibitors the statins of the 21st century based on the evidence so far I have presented? So in 2015, the results of the first large placebo-controlled SGLT2 inhibitor clinical outcome, EMPEROR outcome, in patients with the type 2 and cardiovascular disease and reduced ejection. It showed EMPEROR resulted in a significant 14% reduction of primary endpoint. Even more exciting were the 32% reduction in death from any cause and 35% reduction in hospitalization for heart failure. So findings were soon confirmed with CANA and DAPA, leading to the first major paradigm shift affecting the clinical practice. So SGLT2 inhibitors are not only glucosiluric, but also reduce the development and progression of heart failure and prolong life in patients with the type 2 and reduced left ventricular ejection fraction. There followed 2 trials on patients with a history of heart failure with reduced ejection fraction, DAPA and EMPEROR, both of which showed equal benefits in patients with and without diabetes. So these observations led to the second paradigm shift. That is, it improves outcomes in patients with reduced ejection fraction, irrespective of presence or absence of type 2, thereby greatly expanding the potential target population for these drugs. Next is SOLIST, sotagliflozin trial. Demonstrated patients with type 2 and reduced heart failure across a full range of ejection fraction, including small subgroup of patients with preserved ejection fraction. So in the EMPEROR Preserved trial in 2021, extended the improvement in outcomes in patients with preserved ejection fraction to patients with type 2 diabetes, leading to third paradigm shift. That is, SGLT2 inhibitors appear to be beneficial in patients with chronic heart failure over a wide range of ejection fraction, again greatly expanding the target population even further. So patients with the type 2 of longer duration, they carry high risk of developing diabetic renal disease. So it causes constriction of the afferent arterioles and dilation of the efferent arterioles. These changes result in reduction in intraglomerular pressure, hyperfiltration, and later responsible for glomerular fibrosis and diabetic renal dysfunction, ultimately end-stage renal disease. So the above-mentioned trials of SGLT2 in patients with type 2 diabetes and heart failure with reduced ejection fraction, combined with the 2 trials on patients with chronic kidney disease that included patients without diabetes, they exhibited substantial significant renal protection, leading to a fourth paradigm shift. That is, SGLT2 inhibitors slow the development of end-stage renal disease in patients with chronic kidney disease. So the benefit of SGLT2 inhibitors in patients without type 2 with a variety of chronic disease is under investigation. So the management of type 2 diabetes, of heart failure in patients with and without type 2, across a wide range of ventricular function, as well as diabetic renal disease, have all been substantially improved by the development of ACLT2 inhibitors. So the research recently posed a question: could flozins be the statins for risk-based primary prevention of heart failure? Can now be answered affirmatively. I hope Chairperson will also agree. Right. So before I conclude my talk, may I request all our delegates on behalf of the organizing committee of RSSDI 50th annual meeting to register your name for this event, which is going to be held in Chennai on 6, 7, 8, 9 October 2022 in Chennai Trade Center. So I request all our members to register. Those who have not become member of RSSDI, if they become life member before this month, you are eligible for pre-registration for RSSDI 2022. Thank you very much for the kind listening. Please remain safe, take care, stay healthy, protected, and connected in the days to come. I thank Harris for the kind invitation.
So great. I think it's not it's a postgraduate lecture on HLT inhibitors, not for the delegates. But anyway, I think it is far beyond. I will say it is not statin, it is more than statins, because statin is only for cardiovascular disease prevention, that is anti-atherosclerotic. But statin is a very wide spectrum. So what is called this cardiovascular renal metabolic axis of diabetes. Whereas statin is only cardiovascular. It is cardiovascular renal metabolic axis of the diabetes is touched upon by these HLT inhibitors across a wide spectrum of conditions like diabetes control, heart failure, MACE reduction, and kidney disease management. So definitely, I will say confidently and vehemently that HLT inhibitors are statins of the 21st century, but more than that, I will say it's more than statins to be utilized by every practitioner of taking care of diabetes patients and every specialty. Open.
Sir, good evening.
Very good evening, sir.
And about this automaticity of the cardiac muscle.
Pardon, sir?
Automaticity of the cardiac muscle.
Yes, sir.
Leaky sodium channels are the cause.
Pardon, sir?
Leaky sodium channels.
Yes, sir. Leaking sodium channels. Yes, sir. Of course.
Yes, yes.
Yes, there
and
are
less, less resting membrane potential. That is also another cause.
Yes, sir. Multiple factors have been incorporated with reference to arrhythmic potency in a patient with diabetes.
Yes,
one such as changes with reference to the various channels. Certain channels are overexpressed, upregulated, certain channels are downregulated. Of course, if you look into primarily, diabetes induces metabolic changes, structural changes, hemodynamic changes, and of course, functional changes. And with reference to arrhythmic potentiality, it produces primarily electrical alternates, electrical changes also. So these various parameters, per se diabetic patients, they are prone to develop arrhythmia. And patients presenting with cardiac autonomic neuropathy, the symptoms of first episode of atrial fibrillation may not be felt. It may be silent. So it increases the mortality also. So it can also precipitate cardiovascular, cerebrovascular accident.
Nowadays, I am facing more patients with heart rate below 60 and above 50. But they are very stable. Is there anything to do with that?
No, sir. As long as the patient is stable, never disturb.
No problem.
Never disturb at all.
Not
but the thing is,
40,
stable by definition is not a clear definition. Stable by definition. If you look into the New York Heart Association class 2, they say it's stable. Despite stable, they put the patient on 4 drug therapy: a diuretic, a beta blocker, plus ORNI, plus MRA.
Diuretic Lasix will lead to hyponatremia.
Yes, sir.
Lasix and what I will say husband and wife.
Yes, sir. The classical furosemide
Yes.
It reduces both intravascular as well as interstitial.
Yes.
In contrast, SGLT2 inhibitors, it produces differential volume loss, namely interstitial predominantly, no intravascular effect at all.
And about this HDL and LDL?
Pardon, sir?
HDL and LDL. LDL.
Yes, sir.
LDL mobilizes fat from lipids, fat from liver, and source in the vascular endothelium. And HDL is the reverse action, does the reverse action. It mobilizes the fat or lipids stored in the endothelium of the vessels back to the liver.
Yes, sir. Actually, if you look into SGLT2 inhibitors, it has an impact on the lipid profile, no doubt at all. It actually it converts atherogenic LDL into less atherogenic. That's all.
Yes, that's all. Not on LDL.
LDL, it converts.
HDL.
That is, it makes small dents into large and buoyant.
HDL or LDL?
LDL.
Okay, sir. Thank you, sir.
Okay, if there is no discussion or questions, I thank the speaker again for his voluminous presentation and thank Iris Pharma for the nice occasion and also the organizing committee. Thank you.
Thank you very much, sir. Thank you so much.
So thank you very much, Doctor, for your excellent deliberation of your speech. So kind of you. And we would like to facilitate with a momentum. And sir, fine. So it's a pleasure having Dr. Sridhar. Thank you so much. Please sit down, sir. Yeah. So Dr. Sridhar will facilitate Dr. Gopinath. Thank you so much, sir. Thank you very much. Yeah. So thank you once again, sir, Dr. Shanmugavel, doctor, and Dr. Gopinath, Dr. S. Sridhar. Yes, thank you so much.
I haven't heard about any problem with diabetes problem in lungs, only infections.
No, sir. It produces changes with reference to microangiopathy complication.
Yes.
That in turn will interfere with the oxygen perfusion capacity within the lungs. So pulmopathy. But only limited data are available.
Yes, sir. Yes, sir. Thank you.
So thank you once again. So it's thanks all from Eris. And I wish all the doctors a great evening. And once again, welcome you all to the Temple of Meenakshi Amman. Thank you so much. Thank you, sir. Thank you, sir.
I am chairperson for Microsoft.
Thank you, sir. Thank you. So kind of you. Thank you.
Good evening. It's the final event of today. We heard an excellent talk by Dr. Shanmugavelu on dapagliflozin. How to further improve the effect of dapagliflozin is to use it in combination. If the HbA1c is 1.5% above the target, it is welcome straight away to use a combination of drugs, especially a combination like dapagliflozin and vildagliptin, and it will help us to quickly achieve the target. And many side effects of the drug like SGLT2 inhibitors may be reduced if you use with the gliptin. To tell us more about this optimum clinical approach to use Vilda-Dapa combination in Indian settings, I invite Dr. Adeline Reena Asirvadam, DNB General Medicine and DM Endocrinology. She's the Associate Professor of Endocrinology at SRMC, Chennai. Over to Dr. Reena.
Thank you, sir. And I thank Microlabs for having me here to talk about on the optimum clinical approach. So many times when we approach to manage type 2 diabetes, we often are misleaded or misguided by the fasting plasma glucose, the postprandial plasma glucose, the affordability of the patient, the comorbidities of the patient. So what I'm going to emphasize in the next 15 to 20 minutes is to clinically look at a patient and how we really choose to probably prescribe this combination of vildagliptin and dapagliflozin, which is the molecule for discussion today, in Indian settings and for our patients. So this is just a prototype case. This is about a 49-year-old gentleman who's an executive by profession. By the term executive, we all know about the sedentary lifestyle that tags along with that particular profession. And patient seeks for glycemic control. So when patients seek for glycemic control, it becomes more easier for us to convince the patients to intensify therapy or intensify lifestyle modification, rather than we picking up an A1C of 8.59 and striving hard to convince the patient to again intensify therapy. So digging up the history, patient has diabetes for last 2 years with associated hypertension, dyslipidemia, has had failed metformin monotherapy. He was initially on 500 milligrams twice daily, then increased to 1000 milligrams twice daily for an A1C of 8.3. So on examination, we find that patient is obese with signs of insulin resistance, BMI on the higher side, blood pressure controlled on antihypertensive. When you look at the biochemical profile, we see that the fasting plasma glucose is high, the postprandial is again high with an A1C of 9.2%. So what we need to understand is this particular gentleman has both fasting as well as postprandial hyperglycemia, a combined abnormality which needs to be addressed, and that's how we will be able to bring down the HbA1c. And looking at the cholesterol, not very satisfactory despite being on a rosuvastatin of 10 milligrams. Luckily, he has a normal renal function, giving us a lot of room to probably play with the anti-diabetic drugs that we have now. So going back to the details, we all know that type 2 diabetes is increasing steadily and steeply worldwide, and India is no exception. So what you see here in numbers based on the IDF projected data, we will soon become the diabetes capital, or probably we would wish to become the diabetes care capital of the world. Now, how are our patients different? Our patients are definitely much different from the Western counterparts, and the reasons here are listed here. Apart from the environmental factors that are more or less the same between the Western population and our population, what we need to understand is this particular column. So we have a very conceiving low body mass index or a low BMI. The moment you check a BMI, it is branded as a normal BMI, and many times it is very misleading. But unfortunately, when we really need to measure or probably put these patients or probably risk stratify them, it is the waist circumference of our patients that will really give us a clue of the visceral adiposity, subcutaneous adiposity, and probably the metabolic risk as well. So a higher waist circumference and a high waist hip ratio will indirectly point towards a high visceral fat, and this particular fat distribution makes these patients more prone to succumb for cardiovascular and metabolic complications. So this in turn causes an increased insulin resistance, a very high prevalence of atherogenic dyslipidemia, and more importantly, what we are as physicians concerned is the early beta cell defect. Many times we see patients failing 1 drug, 2 drugs, 3 drugs as early as in the course of type 2 diabetes, possibly because of the inherent beta cell defect that our patients encounter. So why are we very concerned about this particular Indian phenotype? It's because these patients have diabetes at a younger age, have diabetes with normal BMI, and are more prone to develop cardiovascular complications and succumb to cardiovascular events. So that is the reason why we are more concerned about our patients and as a whole, and not just looking into a narrow spectrum of just bringing down the numbers of the plasma glucose. Now, the type 2 diabetes doesn't come alone. It always comes along with a lot of friends. So what we also understand is that almost when you see 85% of patients have associated dyslipidemia, 75% have hypertension, 50% of Indian patients do have chronic kidney disease. So when you keep tagging and keep looking at the various permutations and combinations, you find that type 2 diabetes as an isolated abnormality happens in a very, very few subset of patients where you have a combination of all these abnormalities tagging along with type 2 diabetes, making it a bit more tougher for managing the patient and not just type 2 diabetes. Now, unfortunately, though we talk about all these comorbidities, they don't come in a very broad daylight, and we have a lot of our patients having asymptomatic cardiovascular disease. What you see here is that at least 60 to 70% of patients have LV dysfunction at different stages, which remain asymptomatic, and many times it is often missed because it doesn't present in the classical way. And again, when you look at cardiac failure, again, at least 25 to 30% of patients do have asymptomatic heart failure. Now, this makes our patients more prone to have cardiovascular event and also cardiovascular death. So how do we really go about looking at these patients? We often are familiar with this particular term, the cardio-renal metabolic continuum. So when you try to see a patient, we have to place the patient in any one of this journey or the course of type 2 diabetes and the metabolic complications. So they start from being diagnosed with hypertension, diabetes, and obesity, and they slowly progress. What you see here in the outer circle is the macrovascular complication, having a cardiovascular event, ventricular dysfunction, and ultimately succumbing to cardiovascular death or stroke. And then in the inner circle, you find that patients have endothelial dysfunction, macroproteinuria, and ultimately ending up having an end-stage renal disease. So if you have an individual with type 2 diabetes, we would rather want to place them at some point of time, and what we really intend is to hold on that patient in that particular phase so that they don't progress in terms of not just type 2 diabetes, but also diabetes-related complications. So having looked at about all the Asian Indian phenotype and how they are more prone for all these complications, how do we really improvise the type 2 diabetes management? Is that something which we can do? So if we are able to have a combination therapy that could address the multiple pathophysiological abnormalities which contribute to hyperglycemia and type 2 diabetes progression, that could help us to at least retard the progression to some extent. And when you have a drug which not just provides glycemic benefit, but also non-glycemic benefits would help, and a drug that has to achieve the same glycemic efficacy, but not at the cost of hypoglycemia and weight gain, and more importantly, which would help these patients to have some adherence to therapy and compliance so that the dropout rates and the poor HbA1c doesn't happen. And more importantly, the durability of glycemic control. We often talk about the sequential therapy, and now we know that it is not always the sequential therapy that helps, rather hitting them hard and hitting them early with combination therapy helps them to have a sustainable and a durable glycemic control that can prevent microvascular complications, especially when achieved in the first 2-3 years of type 2 diabetes. Now, looking at this molecule as a combination of SGLT2 inhibitors and DPP4 inhibitors, there are two different molecules having mode of action, site of action at different places. But what we also understand is that they complement each other and ultimately offer a better glucose lowering effect. So when you look at SGLT2 inhibitors, they potentially act on the kidneys and therefore cause renal glycosuria and improve the glucotoxicity. On the other hand, we have DPP4 inhibitors, which have a predominant effect on the pancreas, both the alpha and the beta cells, and also on the intestine, increasing the endogenous GLP-1 and GIP, and ultimately contributing to diabetes control. So what I mean by saying complementary is that we know that SGLT2 inhibitors can potentially increase the glucagon secretion, which is suppressed by DPP4 inhibitor. So the diabetic ketoacidosis risk that is possibly due to SGLT2 inhibitors is kind of neutralized when it is given along with DPP4 inhibitors. Now, to add on to this combination, in the kind of patients which we discussed, when these two molecules in combination is added along with metformin as a triple drug combination, what you see here is that the entire 8 pathophysiological abnormalities that contribute to type 2 diabetes is being addressed, and overall we get down into the core abnormality of type 2 diabetes, and we are able to not just bring down the glycemic control but also to improve the metabolic milieu of the patient so that we can prevent type 2 diabetes related complications. Now, whenever we talk about combination therapy, the first and foremost combination that comes to our mind is sulfonylurea and metformin. It's one of the pioneers of using fixed drug combination is India. We've been the pioneers in starting the sulfonylurea metformin combination. Though it is a very powerful combination, many times the hypoglycemia, renal benefit, and other extra glycemic benefits are not addressed. We have the DPP4 and metformin, which has a good potency in terms of glycemic control and low risk of hypoglycemia. And when you add in an SGLT2 inhibitor to this combination existing pool, what you see is a holistic benefit of metabolic abnormalities. Now, beyond the glycemic control, beyond the metabolic abnormalities, there is something which these combination drugs can also do. So the time in range is gaining importance now. We are not just bothered about how the HbA1c looks at the end of 2 months or 3 months, but we also want to know the quality of glycemic control, how far and how flat the glycemic excursion really plays over the day, and probably inter-day variability. So by improving the time in range and by reducing glycemic variability, the combination of DPP4 inhibitors and SGLT2 inhibitors brings down the complications due to type 2 diabetes, because we know that glycemic variability per se has an independent prediction of microvascular complications due to type 2 diabetes. So that way we are definitely able to bring down the complications and possibly improve the outcomes of these patients. Now, how does this combination, though theoretically addressing multiple pathophysiological abnormalities, very good drug to reduce the glycemic variability, how do our patients fare in this combination? This is an Asian cohort which was studied, especially in this meta-analysis. And what you see here is the glycemic response or efficacy of the molecule in Asian Indians. And what you see here is that the SGLT2 inhibitors did show a better A1C reduction in Asian population compared to the Western population. DPP4 inhibitors, again, numerically better, but statistically not very significant. So when you have a combination of these two molecules, which do better or probably offer better glycemic efficacy in Asian population, because of the fact we know that our patients' pathophysiological abnormalities are quite different from what has been proposed in the Western population, these combinations really work well. Now, this is an unpublished data of a study with fixed dose combination of vildagliptin and dapagliflozin. And this was a 16-week study where they primarily looked at the mean change in the fasting plasma glucose, 2-hour postprandial, and also to look at the proportion of patients who achieved an A1C less than 7% at the end of 16 weeks. So they had included around 318 patients and had 3 arms. Patients were randomized into DAPA 5 plus Vilda 100 SR and DAPA 10 plus Vilda 100 SR and DAPA 10 with saxagliptin 5 mg SR. Now remember, the US FDA has approved the combination of DAPA 10 mg and saxagliptin 5 mg, but we don't have the combination available in India. But what we do have is the combination of Vilda and dapagliflozin. Now, if you look at the 16 weeks results, what you see here is the A1C reduction close to 1.5, 1.6%, as good as the DAPA-Saxa combination. And there isn't much difference between the DAPA 5 Vilda 100 and DAPA 10 and Vilda 100. And onto your right side is the fasting plasma glucose reduction, almost to the tune of 30 milligrams per deciliter. And also when you look at the postprandial control, again, a good significant postprandial reduction also achieved with this particular combination. Now, when you look at the proportion of patients who achieved an A1C of less than 7%, close to 50 patients were able to achieve at the end of 16 weeks. So overall, this study showed that the glycemic efficacy is on par with the US FDA approved DAPA and Saxa combination. Now, when they looked at the adverse event profile, what we can see is the adverse event profile is very comparable. You don't see any vague increase in adverse events with this combination of Vilda and DAPA and in this particular study. So looking at the data behind how these two drugs, when prescribed as a combination, would probably impact the cardiovascular system. So when you look at the comparison of dapagliflozin and vildagliptin in this particular study in patients with diabetes and a coronary artery disease, you can see that most of the graphs or most of the parameters, you see that DAPA and Vilda are in synchrony. The effect of DAPA cannot be matched by Vilda, but what you also see is that at least it is in the same direction, except for the body weight, which we all know SGLT2 inhibitors do offer weight loss compared to the DPP4 inhibitors, which are weight neutral. Now, the interesting fact is about not just complementary mechanism in terms of glycemic control, but also the complementary mechanism in CV benefit, and that's what we are more probably interested. So what you see here is a reduction in the NT-proBNP marker over a period of 6 months of use with dapagliflozin, and you also see a good amount of reduction in the NT-proBNP with vildagliptin at the end of 6 months. So overall, they work together in synchrony and complement each other, not just in glycemic control, but also in bringing down cardiovascular risk and probably offering a bit more cardiovascular benefit. Now, this is a preclinical study because we don't have the clinical study for cardiovascular benefit as of now. And what you see in this particular animal study is that the cardiac ischemic reperfusion injury is quite common in patients with type 2 diabetes. And when dapagliflozin was added in these animals, what they showed was there was a significant recovery from the injury. But when they added vildagliptin over and above the dapagliflozin, they still saw a further increase in terms of the ischemia reperfusion injury size reduction. So this kind of tells us that DAPA, yes, we have very clear data to say that it does have an effect on the cardiac ischemia reperfusion injury, but vildagliptin does no harm or probably adds on to the benefit a bit more. Now, a quick word on the beta cell function. And as diabetes care specialists, we also know that we are more interested to provide a drug that could be durable for the patient so that the patients can be on a single pill with 2 drugs on, and you can forget glycemic control for the next few months or few years. So one such benefit that this molecule can offer is the beta cell function improvement. We know that DPP4 inhibitors have an impact on the beta cell function and has also been shown to have some beta cell preservation effects. So what you see here is all the gliptins that have been studied, including Sita, Vilda, Lina, and all of them showing an improvement in beta cell function and possibly the reason for having some beta cell preservation as well. Now, talking about the adverse effects, whenever we have SGLT2 inhibitors, we are more concerned about the possible increase in the genital and urinary tract infections. Of course, we do have an increase in genital and urinary infections while being on SGLT2 inhibitors, but when this combination is given, what we understand in this particular meta-analysis is that right from the Rosenstock data to the DeFronso data, what you see here is the combination of SGLT2 and DPP4 does have a very less prevalence of genital and urinary tract infection, more importantly, genital infection. And the proposed mechanism is 2 or 3, one being a good glycemic control, automatically bringing down the incidence of any infection for that matter. The second thing is the presence of the DPP4 enzyme in some of the bacteria and fungi that can contribute to this infection. Once that is inhibited with DPP4, it has been shown that possibly that could be the reason why the infections are much less in a combination. Now, there's an expert opinion that has been published a couple of months ago for the optimum use of SGLT2 inhibitors and DPP4 inhibitors. And what this panel recommends is to consider the FDC of Vilda and dapagliflozin when you really anticipate for an improvement in glycemic control, adiposity, also want to reduce the metabolic and vascular risk. At the same time, you want to have a simple regime and a regime that can really work for our patients. So the key takeaways from this expert opinion for Indian patients include the combination of SGLT2 inhibitors and DPP4 inhibitors can be considered when you have an A1C which is at least 1.5% above the target HbA1c. The second thing is whenever you have comorbidities in the patient, either established cardiovascular or renal disease or possibly a high risk factor for cardiovascular and renal disease, you may still consider this combination too, not just for glycemic control but also in the risk factor reduction. And when you want to offer a good glycemic efficacy without hypoglycemia and weight gain, you may consider this. And more importantly, to bring down the pill burden and improve adherence, which is many times overlooked in our clinical practice. So coming back to our patient, he was continued on lifestyle modification. Metformin again was continued at 1000 milligrams twice daily. He was started on vildagliptin 100 and dapagliflozin 10 milligram FTC once daily. On follow-up, you can see a bit of weight reduction, a good fasting and postprandial control with an A1C reduction good A1C reduction achieving a 7.4%. So this kind of a benefit is definitely possible when you have a combination therapy early on board and when patients are able to not just bring down the glucose levels, but also the cardiovascular and renal risk. So to summarize, Asian Indian phenotype is definitely different from the Western counterparts. They have an increased visceral adiposity, a lower metabolic tolerance, and therefore have a very, very high cardiorenal risk. And more than just following the guidelines, many times we should have an individualized approach to every given individual that we see across the table before we make a decision on the anti-diabetic drug that would suit the patient. And last but not the least, whenever you have an opportunity to provide a drug that can address the core abnormality of type 2 diabetes that causes not just type 2 diabetes but also the progression of type 2 diabetes and beta cell function worsening, then it would be prudent to choose such a combination when you really want to address the abnormality directly. So thank you very much, and I will stop here.
Thank you, Dr. Adlin, for the excellent talk. I open the floor for discussion. Yes, sir.
Yes, good evening.
Good evening,
about combo therapy, there is one positive and one negative. The positive thing is it improves patient compliance. The negative thing is we cannot titrate. That's all.
True. In this particular FTC, we don't have an option of titration because both come in a fixed dose and it's a once-a-day therapy. So that way, when you are looking at a Vilda 100 milligram sustained release with a dapagliflozin of 10 milligram, that's it, and that doesn't really warrant a dose up titration unless the patient is on other drugs which might have to go up or go down.
Unless the patient is on having CKD or something, there is no need to titrate this dose. 100 is the single dose and 10 is the single dose.
In patients having blood sugar less than 200, I think metformin alone is enough.
Blood sugar less than, sir?
200.
That's what the entire message is not just to go by the glucose value per se. When a fasting plasma glucose, if I can take it as 200, that clearly tells us that the hepatic glucose output is huge and may not be just possible with metformin alone. So probably you need a drug, because if the fasting is 200, I expect the A1C to be...
Not fasting, postprandial, PP.
Postprandial.
I think or random. I recommend random more than PP or fasting. I recommend random. Anytime, anywhere, anytime, a normal human being must have a normal glucose level in blood, not during fasting or postprandial.
So
I don't.
Here, she clearly mentioned that if only we use this combination if it is 1.5% above the target. Yes. If it's below 200, we are not going to use this drug.
Yes, and one more. This quinolones, talking about quinolones, they bring down blood glucose.
Which one, sir?
Quinolones.
Quinolones.
Yes.
Quinolones are potent to cause hypoglycemia, which is more common in patients without type 2 diabetes. So non-diabetic hypoglycemia, one of the commonest causes the fluoroquinolones. But the dose that we use in clinical practice doesn't really cause hypoglycemia. The dose which was previously used was a very, very high dose. So that was a dose which has been clearly shown to have hypoglycemia. But what we use in our clinical practice, we don't get to have hypoglycemia unless patient takes it in an intent to overdose him or her. Yeah.
Does it improve any SA node function?
Which one? Sorry, sir?
Any SA node function improvement?
SA node?
Yes.
Quinolones, yeah. The QTC prolongation is one of the known complications.
QT prolongation.
Yes.
QT prolongation over quinolones along with cetirizine, along with antihistamines. It is even more.
Antiarrhythmic drugs, yes. When there's a combination, yes.
Thank you.
Thank you, sir.
So due to time constraints, we are forced to end this wonderful session. I once again thank Dr. Adeline for the wonderful talk.
On behalf of Microlabs, we thank Reena Madam and we thank Sridhar Sir and thank all the participants. And once again, on behalf of Microlabs, we are thanking all of you, sir. Thank you. And we are very much trusting this Vilda plus DEPA. Definitely, it's going to be a trendsetter from Trendo. Thank you. Thank you, all of you. And thanks, Trendo, for this wonderful opportunity.